All right, I declare open this public hearing, the Standing Committee on Health, Aged Care and Disabilities inquiry into the health impacts of alcohol and other drugs in Australia. I'd like to acknowledge the traditional custodians of the lands from which we meet today and pay my respects to their ancestors and elders past, present and emerging. I extend this respect to all Aboriginal or Torres Strait Islander peoples and their cultural and spiritual connections to Australia's lands and waters. I would also like to acknowledge the Tharrawal Aboriginal Health Service in my own electorate of Macarthur and thank them for their support over many years. In accordance with the committee's resolution of the 21st of August 2025, this hearing will be broadcast on the Parliament's website and the proof and official transcripts of proceedings will be published on the inquiry website. I remind members of the media of the need to fairly and accurately report the proceedings of the committee. I remind all stakeholders who are present before us in ensuring the safety and privacy of individuals during these proceedings. This includes avoiding the use of names or identifying details when referring to other parties and ensuring that any discussion is respectful, appropriate and consistent with our shared responsibility to maintain a safe environment. I invite members of the committee to introduce themselves and start with Ms Stanley.
My name's Anne Stanley and I'm a federal member for Werriwa.
Mike Freelander, Chair of the committee, a member for Macarthur and South Western Sydney. And online, Sophie, would you like to introduce yourself?
Hi, I'm Sophie Scombs, member for Mackellar on the Northern Beaches of Sydney.
Thanks. We will probably have other members coming and going through the day. I'd like to welcome members from the Foundation for Alcohol Research and Education to this public hearing and thank you very much for your time today to present to us. For the Hansard record, before giving any evidence, could you please state your full names and the capacity in which you appear before the committee? Although the committee doesn't require you to give evidence under oath, I should advise you that this hearing is a legal proceeding of the Parliament and therefore has the same standing as proceedings of the respective houses. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I now invite you to give your full names and the capacity in which you appear and to make a brief opening statement before we proceed to discussion. Thank you.
Ms Catherine Burney, I'm the Director of Prevention of Gendered Violence.
And I'm Ayla Chorley, the CEO for the Foundation for Alcohol Research and Education.
Thanks. Would you like to make an opening statement?
Yes, we would. Thank you so much for the opportunity to give evidence today and for the committee's focus on alcohol and other drugs in Australia. Alcohol is now the leading cause of death by drug in this country. Around 5,000 people die each year. More than 110,000 are hospitalised and a cost estimated at $75 billion annually. These are not just numbers, they are preventable deaths, preventable injuries and preventable harm. They are families carrying the weight of something that they did not have to. They are systems under pressure because we have allowed harm to scale. Alcohol is also a major driver of gendered violence and harm to children. It is present in around 1 in 3 intimate partner incidents and more than a quarter of family violence incidents. In some cases, more than half of incidents reported to police are alcohol-related. And behind that data are children living in homes, living in fear, where harm is normalised, where safety is unpredictable, and where the impact lasts longer than the incident itself. Gender-based violence does not happen in isolation. It is shaped by the conditions we create, the risks we ignore, and the systems we choose to regulate or leave unchecked. Alcohol is one of those conditions. It does not cause violence on its own, but it intensifies it. It lowers inhibition, increases aggression, and reduces the likelihood that someone will stop before the harm is done. We see this in the data, but we also see it in the patterns. Violence that escalates incidents that become more severe, children exposed to higher levels of risk, and we see it in the home. Because increasingly alcohol is not just consumed in venues, it is delivered rapidly and repeatedly into private spaces where there is no oversight and very little opportunity for intervention. For many women and children, the most dangerous place is already the home. We are now enabling systems that make that environment more volatile, more unpredictable and harder to escape. When alcohol is delivered into the home where violence is present, it can act as an accelerant. It can turn coercive control into physical violence. It can turn fear into immediate danger. And critically, it can remove the small windows where intervention might otherwise have occurred. There is no staff member to refuse service, no public setting where behaviour is visible, no pause. This matters because if we are serious about reducing gender-based violence in this country, we cannot only respond after the harm has occurred. We have to pay attention to the systems that enable harm to escalate. Right now, we are not doing that. We are allowing highly targeted alcohol marketing to reach people at risk. We are allowing a frictionless pathway from advertisement to purchase, and we are allowing rapid delivery into homes, including homes where violence is already present. This is not neutral. This is a policy environment that is enabling harm. These harms are not accidental. They are being fuelled and in many cases worsened by the way that alcohol is marketed and sold. Alcohol advertising is now persuasive in digital environments. Tens of thousands of ads are pushed through platforms like Facebook and Instagram each year with no meaningful way for people to opt out. This is not passive exposure. It is targeted, data-driven marketing designed to reach people at moments they are most at risk, including children, young people, and people experiencing or recovering from dependence. The gap between seeing an ad and buying alcohol has almost disappeared. More than a third of alcohol ads on major social media platforms include a direct link to purchase and rapid home delivery. Australian research shows that this model increases high-risk use and related harm. People experiencing alcohol dependence are disproportionately impacted and are the most likely to purchase after clicking through these ads. What we have created is a system where risk is identified and then actively exploited. Community concern is high and growing. The majority of Australians support stronger restrictions on alcohol advertising, particularly during children's viewing hours like on TV, on streaming, and in digital spaces. There is clear support for government-led regulation rather than the current system which allows industry to set its own rules. But the current system is not fit for purpose. It's fragmented, weak, and largely shaped by voluntary industry codes. These codes focus narrowly on content and are not independently enforced. They have repeatedly failed to protect children and people most at risk. This falls well short of community expectations and of the national strategies that already recognise the need to reduce alcohol promotion, particularly online. There is a clear and achievable path forward. The Commonwealth can establish a national regulatory framework for alcohol marketing through legislation. This must include mandatory compliance, independent oversight, and strong monitoring and enforcement mechanisms, including meaningful penalties for breaches. This is not new. It gives effect to commitments already made under the National Alcohol Strategy, the National Drug Strategy, and the National Preventative Health Strategy. International examples that have already done this, and Norway and Lithuania, show that comprehensive statutory controls are both feasible and effective. Australia has the evidence, we have the public support, and we have the policy foundation. What is missing is the implementation. This committee has the opportunity to close that gap, to move beyond self-regulation and align the law with what we already know. A national legislated approach to alcohol advertising is practical, evidence-based, and ready to be implemented. It will save lives, reduce violence, and better protect children and communities from preventable harm. Thank you.
Thank you very much. Might start with Ms. Stanley.
Sure. Thank you very much for your time today. You mentioned in your presentation about delivery to the home, and we saw that change significantly during COVID. What would your recommendations be to be able to keep people safe, given most of the platforms that you order on, they'll have a front page that says, are you 18? Now, clearly, if you say no, you're not going to go any further, but it's up to the person who's making that decision to say that. So how else do you think we could do it? Like, do we stop it altogether, or because you're right, in a venue there is legislative requirements. If somebody is too inebriated, they are not allowed to be served alcohol, and if they're found later to do so, that can cause the person who did serve them significant detriment. So how do you think we should do this?
Well, I think the good news is there's already documentation that supports what's needed, and this is based on what the evidence shows is required. This includes things like ensuring that there's a 2-hour pause between when alcohol is delivered into the home and from when it's purchased. It also looks like having restrictions around opt-in versus opt-out for marketing in terms of social media, so that you're not getting prompts all the time to purchase these products. You also might have the choice, I guess, within apps like Uber Eats to not be shown products like alcohol as another option. But certainly when it's at the point of purchasing, we would like to see that there are greater safety checks put in place, including a 2-hour safety pause, and then also restrictions on delivery hours. So depending on the state and territory at the moment, they vary greatly. We would like to see delivery hours contained to 10 a.m. to 10 p.m. This is what's been found within the evidence. It was included within the federally commissioned rapid review into family, domestic and sexual violence. It was also found and reported in the recent South Australian Royal Commission into family, domestic and sexual violence as key safeguards that are needed to reduce the level of harm we're seeing.
I haven't read your submission in its entirety, but did you have you actually pointed those points you've just said out in that submission? Yes. Okay, that's great. Thank you. Is 2 hours enough?
I think when we're looking at online sale and delivery, I think we're recognising that this is a platform in which we're seeing an escalation in terms of harm, and I think harm for multiple reasons. I think when we're looking at delivery drivers attending to home, there's a level of risk for delivery drivers that's not currently being considered. You know, we've got things like implementation of RSA, and I think for many in this room it'd be easy to understand how a young person delivering alcohol to a home late at night is quite a risk to that person, and then for them to be making a determination and then refusing service is actually a high risk activity. And so on that basis, plus the fact that we are seeing repeatedly that alcohol now going into the home, we don't have that visibility of those individuals. We're seeing increase in terms of risk to themselves, but also in the family violence context. Online sale and delivery poses a significant health risk. 2 hours at minimum is what we and what the evidence shows is required, but certainly the harm from having this new service of alcohol has been extensive, and so if there was broader support for additional safeguards being put in place, they would absolutely be supported and backed in by the evidence, given the harm we're seeing.
Do you have, I've been on other committees in the health, other inquiries on the health committee where this has been flagged before. Is there actual data about the harm? And has there been, because alcohol delivery was not done this way before COVID. Basically, you could ring up and buy yourself 12 bottles of wine, for instance, from, an online sort of place, but it'd take a couple of weeks, or you might have to wait for the vintage, or, it was a long time coming. This is sort of coming straight out of COVID, really, that this sort of stuff is all of a sudden been available?
I think it's certainly escalated through COVID. It was established or beginning to be established pre-COVID, but certainly once COVID happened, it escalated significantly. We do have data which shows around who's using these platforms to order alcohol and the impact that has. So I think, there was a survey that was done recently about those who are using these online platforms and rapid delivery, and it showed that of the people who were surveyed, and this was representative, 38% of people were drinking in excess of 11 standard drinks on the day of that rapid delivery, so that's significant. A Victorian study of people having alcohol delivered weekly found that 70% drink in excess of 11 standard drinks in a sitting week, and 57% experienced memory loss from alcohol delivered rapidly, and 48% were involved in an alcohol-related injury after having alcohol delivered rapidly. We've heard from so many survivors who have told us about what the delivery system means for them. You might wish to speak to that more.
I think when you're looking at victim survivors of particularly violence in the home, they are very good at managing their own safety. But when you start to introduce the unknown element of rapid delivery, suddenly managing your safety within the home becomes a lot more difficult. And there is a sense of fear. You know, when we talk about the advertising as well, you have on a grand final day. Now, we know, and a state of origin day, that there is a potential for incidents of domestic and family violence to raise by 40%. Now, due to something called a sports loophole, you can start advertising alcohol from 8 a.m. Now, for children who are in that home, for people who are experiencing violence in that home, there is a sense of dread and fear from the start of that day. And how am I actually going to manage my safety, my children's safety? What are we going to do? Because we have this unknown element now. And I think, look, I've heard arguments, and I will put them out there, where people are saying, but this is just people who want to order a bottle of wine with their dinner. That is not the case. The evidence shows that's not the case. People are using rapid delivery to drink at really high risk levels, which accelerates harm, but also really accelerates the level and severity of violence that people who are living in violence are experiencing.
So what's the average amount of alcohol that's delivered with rapid delivery?
Unfortunately, that's not data that we get access to, or nor is publicly available to us.
Who would have that data? I mean, because clearly they're using it for their marketing, so who'd have that data?
That would be the alcohol industry and the delivery platforms that would have that data. That's not something that we would have access to.
Okay. To my last question, Chair, you said, or I picked up that you were talking about children's advertising. Forgive my naivety, but I would have thought that children shouldn't be exposed.
You're absolutely correct. They shouldn't be exposed to alcohol advertising, but we know that they are in a couple of different ways. So Catherine mentioned, of course, the sports loophole, which happens in regards to free TV. So it allows for alcohol advertising during live sports broadcasts, including during children viewing hours, where it would normally not be allowed. At the moment on streaming platforms, there is little to no regulation at all around marketing control, so children can be exposed through those platforms as well.
Even on streaming platforms that are specifically for kids, you know, like ABC Kids. Well, ABC doesn't advertise, but that sort of platform. So, you know, there's Nickelodeon, I don't know, I'm out of the children's section, but they're actual, they're cartoons and things like that. They can be exposed on that, because a lot of parents would not realise that was, that would happen.
There were beer ads when my 9-year-old child was watching Netflix and she was on a kid's profile. Absolutely. We've had that experience when she's been watching movies, and so I've had to actually purchase the option to not have advertisements for that very reason. I've made that choice.
But not everybody could afford that choice, perhaps,
Absolutely.
or even understand that was an issue.
Exactly, and I think that's the point. You know, we are not talking about people who work in this sector. There is a broader people where this isn't a regular concern or something they're necessarily thinking about.
Yeah. Okay. Thank you very much. I appreciate it. If some of that data we talked about is not in your submission, would you mind providing it to the committee?
Of course.
Because having that sort of stuff is easier to make a recommendation.
Of course. Absolutely.
Thank you.
Thank you.
Thanks, Chair.
Great. Dr. Scomps, do you have any questions?
Hello, and thank you so much for your presentation today. I just wanted to follow on from a few questions. One, you mentioned in your submission that other places around the world are acting on marketing of alcohol, including Norway and Lithuania. What are they doing that's successful?
Certainly. So they're looking at place-based marketing, so marketing in terms of public spaces. There's also exceptions within some of their platforms, online platforms and television as well. So we're seeing success in regard to that. I think it's slightly varied. I think other countries as well are also exploring opt-in or opt-out options for advertising on platforms. We would strongly advocate for opt-in versus opt-out, but we have seen the success when those types of mechanisms are put in place, that people are better protected online and given greater agency in terms of supporting their well-being and protecting that of their children as well. As we said, this isn't new, and it's something that's being explored all the time, which is really positive. I mean, the example around this, I guess, in the food space is in the UK, when they recently looked at and they implemented a ban around junk food advertising. So this is something that's happening in different places across the world, which is really promising, but certainly we're not seeing any movement here at the moment.
Thank you. And the other thing you mentioned was that there's clear support for government-led regulation over industry self-regulation and voluntary codes. What's that clear support look like?
Absolutely. So we've got data and polling that shows that, which we can come back to this committee on. It's in our submission as well, but it shows overwhelmingly that there's an expectation from the community that government is regulating this area. And that I think it's actually understood by many people that the government is already doing that. I don't think many, from what we've seen and heard and from those we've spoken to, actually think or expect that it's reasonable that the alcohol industry effectively are able to set their own marketing rules, which is what the current case is. And so when that question is put to them, it's quite shocking actually, because they expect that this is something that the government would be doing instead. The support for regulation is quite high.
The experience of one of my constituents who lost their teenager who had an alcohol dependence issue was that in New South Wales he could walk into any place selling alcohol and not necessarily buy it, but was in there, and teenagers can very easily access it illegally. There's different licensing rules across the different states. Are you able to speak about that? Just, the ability of teenagers and young people to be in places where alcohol is sold.
Welcome to join us.
Certainly, and let me start by extending my sincere I'm so sorry for their loss. It's incredibly sad, and unfortunately not an uncommon experience in Australia for people to lose a loved one because of alcohol. I think what you've highlighted is every state and territory have their own Liquor Act, and there are significant variances between them. In terms of, at the moment, South Australia, for example, has a draft liquor bill which they've sat with for the last year that looks at implementing some of the earlier recommendations we were talking about with the 2-hour safety pause. One of the critical things that Liquor Act does is it puts forward having harm minimisation as paramount within the Act, making it the most important piece of that Act. That would mean that when decisions about alcohol are being made, that harm minimisation is the most important consideration. We'd like to see that across all states and territories in this country, because that then becomes the most critical piece in the puzzle of Liquor Acts in terms of how we're making decisions, but also what the impacts around alcohol are. I think you talk about alcohol in the context of going into stores at the moment, which young children can. Into supermarkets, you can see now alcohol-free products that look like alcohol, that are sold as alcohol, not sold as alcohol, but are sitting on the shelves looking like alcohol, and that's exposure to alcohol marketing and exposure to alcohol products. And what we know about the evidence from that is that when young people are exposed to alcohol marketing from a young age, they're more likely to drink at higher risk levels and at an earlier age later in life. And so the exposure to alcohol marketing and these products is everywhere. And there's a real concern, I think, at the moment that because this is dealt with at a state-based level, and there has been a lack of motivation, I guess, to attend to their Liquor Acts and to update these Liquor Acts, what we are seeing is increasing levels of harm and exposure, because there are so many loopholes within the existing legislation that effectively allow exposure to this type of marketing and products to children everywhere they go.
Can I ask just one last question, and it's around a couple of things. What would you like to see with the marketing of alcohol online? As you mentioned earlier, the junk food ad bans were online, you can't advertise junk food at all online, that type of thing happening in other jurisdictions. So you mentioned the sports loophole, but also what would you like to see as a government-led sort of initiative?
Absolutely. So a couple of things. We would like to see that sports loophole closed. It's currently being considered by ACMA. We would like to see opt-in for alcohol marketing of alcohol and healthy foods as well, but in this case alcohol. So we'd like people to be given the option to have to opt in to be marketed for these products on digital platforms. The same for streaming platforms as well. So again, instead of there not being a choice or they have to opt out of this marketing, we would like it to be an opt-in mechanism. For data that's used and sold to create targeted marketing of alcohol products, we would not like personalised medical data like seeking support for alcohol or cutting back on alcohol be then used and sold to alcohol industries so they can then target that demographic with marketing, because all they are is then tagged as interested in alcohol. They then get sent and very curated targeted marketing. So we would not like sensitive data being used or being able to be used for the purposes of marketing as well. There are a couple of key things that we'd like to see.
Can I just clarify, so you're not calling for a blanket ban of alcohol marketing on social media?
No, we'd like to see common sense measures put in place to protect not only young people but also adults as well on these systems, and to give them greater agency around what type of marketing that they would like to receive.
Thanks. Ali, do you have any questions? Jodie?
Thanks, Chair.
No. I've just got a couple of questions, if you don't mind. You said that risk was identified and then exploited. Can you explain what you mean by that?
So I think what we know about purchasing patterns is that when people are purchasing more online, they're receiving more targeted marketing.
And there's evidence for that?
Yes. It's how in terms of what we know about when you're identified or tagged as interested in alcohol, you then receive more advertising. You're tagged because you might have a higher purchasing rate. So what they can do now is they know when you might be interested, when you are more likely to purchase alcohol, so they'll make sure that then they'll time marketing to go to at that particular point in time, whether it's on a Friday, it's when you tend to be looking for alcohol, they'll make sure that you're receiving targeted marketing around that time to increase the likelihood that you'll go on and purchase those products.
Okay. We also, it's common for us to be described as wanting a nanny state whenever we talk about restrictions on advertising and marketing, etc. Is there any evidence that the alcohol industry itself is putting in place self-regulation?
Well, I mean, they might argue that case through things like Aback, for example. Mm-hmm. I think, which is an industry-led scheme, as you know.
Yeah. Tell me how Aback works.
In what sense? In terms of how complaints are received, or?
Yes. Yeah.
So a complaint might be made by a member of the public. It's then considered through a process, and a determination might be made as to whether or not it's in compliance or not with their rules, effectively. And if it is found to be not in compliance, they will then direct that order back to the company and ask them to either remove it or change it. There are no, to my understanding, there's no consequences for them not implementing their recommendations. So
there's no consequences?
No, not to my understanding.
And am I right in saying Aback has a board of which the government...
Correct. The government sits on that membership. My understanding is they sit as an observer. They don't have any voting rights on board, but certainly what we see as them being a part of that, unfortunately, through no fault of theirs, but it does provide Aback a level of credibility by having a government presence on that committee.
So it's an industry-run committee?
Correct, with a representative from the government.
That has no power?
Yes.
Is that appropriate?
Yes. Yes, and I think if anyone has some time on their hands, you can go through and have a look at some of the decisions they've made. I encourage you; they're quite interesting reads. But what you will see is that time and time again, where members of the public have expressed concern about advertising in their area, and it has been found to be not in compliance, I think, reasonable person would look at it and go, no, really what was being asked is something that needs to be removed, and Aback has found that it's not a problem at all. An example for you, in South Australia, there's a little public school called Glenelg Primary School. It backs onto an NSS-ANFL oval. On that oval, it has advertising for alcohol, gambling and unhealthy foods. The little kids that go to the primary school, they can see that advertising outside of that window. They often play on that field. They have their sports day on that field. There's been complaints to Aback. It hasn't been removed. Aback found no fault with it. There have been complaints to the state government and both to the federal government, and there's been no intervention whatsoever because it's not found to be in breach in any way whatsoever. And these children are now exposed to this advertising on a daily basis. And the parents, and there are many parents at that community school who are deeply concerned, who have had their children there for 5 years exposed to this advertising every single day, and there's nothing that they can do.
So when you say there's been no finding by Aback, is there actually any legislative way that they could be removed?
Not within existing regulation, no.
Okay, yeah.
Okay, good. Any sensible person, I think in Australia, is very worried about the stubbornly difficult problem of trying to reduce death and serious injury in family violence. It seems to be almost insoluble when you look at the data. We had evidence from Department of Social Services yesterday that alcohol is involved in a significant number of fatal episodes of family violence. Is there any correlation, do you think, with the increased availability of alcohol and those fatal attacks? Do you have any data around that?
I think when we think about COVID and we think about the availability and ease of availability that you had to bring alcohol into the home, I mean, the UN called it a global a shadow pandemic of violence against women. And women who were previously able to, and our help services, our national services had spikes of calls in early morning hours of the morning because people were passed out, whereas they may not have had that level of drinking prior to that. And people were seeking help in very early hours because that was when it was safe to be on the phone as they were in the home with their perpetrator. So I think there's a lot of different papers that the Rapid Review into Prevention looked at to say this. If we're looking for solid evidence to say if someone has 11 drinks, they're going to harm their partner, violence doesn't work like that. But when you are reducing inhibitions and we know from the regulation we have in public venues, we have that regulation because people's inhibitions are reduced and violence can occur. But somehow in our minds, we've decided that violence that happens in the home is private and therefore there is an inevitability about it, when actually if we were to take these sort of multi-pronged approaches to how we look at having harmful products in the home, we could actually reduce those levels.
Is it worth considering a trial in some way in some areas?
I think there are things that are happening in Victoria at the moment where they're considering different options around this. I think what the Rapid Review found and both the South Australian Royal Commission found is that there are three important things that are needed that will reduce harm at the moment, and that's making harm minimisation paramount for every state and territory liquor act, introducing a 2-hour safety pause from when alcohol is ordered and delivered, reducing delivering hours, but also regulation of alcohol marketing. They were the key considerations that were found, and the key levers effectively that would look at reducing harm within the home. And so when we talk to your question, what we know what is in the evidence is when the availability and accessibility of alcohol increase, harms increase, deaths increase, harm in the home increase. We have evidence to demonstrate that.
There is evidence for that?
Yes.
Yeah.
Okay.
We're seeing increasingly as well in relation to consumption of alcohol. We're seeing highly targeted marketing towards women, which has been happening since COVID, and we are now subsequently seeing an increased rate in consumption of alcohol by women, women in their mid-20s up through to their 40s and 50s, whereas previously we had a larger gap in gender between women and men. We're now increasingly seeing women drinking more, and we can absolutely point to the fact that the alcohol industry have actively pursued a marketing strategy of targeting women in particular, and that's been very successful.
Great. Good. Dr. Ryan, do you have any questions?
I'm good, thanks, Chair. Apologies for being a bit late.
That's right. It's all good. And welcome. So we have Dr. Monique Ryan, the Deputy Chair, member for Kooyong. There. Good. Well, any further questions? Great. Thank you so much for your time today. If you have been asked to provide any evidence and additional information, could you please forward it to the Secretariat by the 9th of April 2026. You'll be sent a copy of the transcript of your evidence and will have an opportunity to request any corrections to transcription errors. Do you have any questions you'd like to ask us?
No.
No. The timeline for the inquiry is a little bit longer than we'd originally planned because we will be going to Western Australia after Easter, and there will be a couple more public hearings, but we hope to have a final report July, August, if at all possible, with recommendations to the Minister. So thanks very much for your evidence, and hope you have a good weekend. Thank you.
Thank you for having us.
Thanks for your time. Thank you.
Thanks. Now, I would now like to call to the inquiry evidence from Odyssey Victoria and Odyssey House, New South Wales, who I think are all appearing online. Great. We'll just wait to I'll just read my preamble before we start. I'll just invite the members of the committee to introduce themselves. We'll start with online. We have Dr. Monique Ryan. Monique? Sorry, you're on mute.
Am I on mute now?
No, you're good now.
Oh, okay, that's good. Monique Ryan, good morning, from Kooyong in Melbourne, Deputy Chair of the committee.
Good. Stanley?
Anne Stanley, I'm a federal member for Werriwa.
We also have Dr. Sophie Scomps, the member for Mackellar in New South Wales, online.
Ailey France, the member for Dixon in outer Brisbane.
Jodie Ballier, the member for Dunkley in Victoria.
And I'm Mike Freelander, the member for Macarthur in South West Sydney and the chair of the committee. Before giving evidence for the Hansard record, could you please state your full names and the capacity in which you appear before the committee? Although the committee doesn't require you to give evidence under oath, I should advise you that this hearing is a legal proceeding of the Parliament and therefore has the same standing as proceedings of the respective houses. The giving of false or misleading evidence is a serious matter and may be regarded as contempt of Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I now invite you to make a brief opening statement before we proceed to discussion, and I'll also add to assist with the transcription of the public hearing. It'd be appreciated if you could please state your name before responding to each question. If you could now state your names and the capacity in which you appear, would be great.
Dr. Stefan Grunet, appearing as the CEO of Odyssey Victoria.
And I'm David Kelly. I'm an Executive Director of Odyssey House, New South Wales.
Great. Would either of you like to make an opening statement?
Yes, please.
Go ahead.
Thank you, Chair and committee members, and appreciate the opportunity to appear today. Odyssey Victoria welcomes this inquiry into the health impacts of alcohol and other drug use in Australia. For almost 50 years, we've worked alongside individuals, families and communities experiencing the harms of alcohol and other drugs, and we currently support more than 15,000 Victorians each year across our residential and our community-based services. I guess I'd like to highlight three central points in the opening statement that were made in our submission. Firstly, alcohol and other drug use, from our perspective, is fundamentally a health and a social issue and not a criminal one. And while Australia's harm minimisation framework remains sound, it's not adequately resourced or balanced. And there are limited whole-of-government efforts or accountability measures surrounding it to drive real change from our perspective. Demand for prevention, treatment and harm reduction services far exceeds the capacity to provide those, and chronic underinvestment has left the AOD sector struggling to meet increasing complexity, reporting requirements and need of the community. A few years ago, a coalition of services, peak bodies and research organisations estimate that a doubling of investment is needed in treatment, harm reduction and prevention, and this investment is relatively small compared to the costs that drug and alcohol harms have across Australia. But we understand in a tight fiscal environment, this would need to be achieved through rebalancing the spending that's in the harm minimisation framework, including reducing supply reduction measures and some drug law reform, or through new hypothecated taxes. And investment in drug and alcohol also saves money in other systems. So that's our first point. Secondly, equity of access remains a critical failure point across Australia. We know that Aboriginal and Torres Strait Islander people, families with children, culturally and linguistically diverse communities, regional people and those identifying as LGBTQIA continue to face barriers to care. We know that stigma and discrimination and exclusionary practices of other systems, such as even mental health, family violence services, hospital and health, and a lack of culturally safe specialist programs all undermine people's experiences of feeling safe and having a relevant experience, and therefore the health outcomes. Initiatives, therefore, that reduce these barriers for those populations and improve service integration with other systems is most welcome. And thirdly, Australia must strengthen its continuum of care. We have very little resource or investment in prevention and early intervention, school-based responses, and also after treatment recovery supports. They're all undeveloped despite strong evidence of their effectiveness. At the same time, people with co-occurring mental health and substance use needs are falling through service gaps, and many choose to receive support in the drug and alcohol system, but we're not funded to provide that mental health support. Of particular note for us, many schools have sought help from Odyssey and other drug and alcohol organisations right across Australia to help them intervene early or manage the drug and alcohol issues in their schools. We developed our BRACE program, and it's evolved from more than 15 years of experience to support a whole of school approach, and a recent 2-year trial that was funded by the Commonwealth and evaluated by Deakin University provides evidence of its effectiveness. It's in high need and high demand, but it's currently not funded. Education thinks it's a health responsibility, health thinks it's an education responsibility. And then at the other end of the spectrum...
I might get you to stop there, and we'll give Mr. Kelly a chance to make an opening statement. We'll go to questions later on. You can tell us any other information.
Flesh that out. Okay.
Great. Mr. Kelly.
Thank you, Chair, and I probably entirely agree with everything Stefan was saying anyway, so I was probably happy to hear it. But thank you for letting me make my opening statements. My name is David Kelly. As I said, I'm one of the executive directors at Odyssey House, New South Wales, and also an adjunct lecturer at the University of New South Wales in the National Drug and Alcohol Research Centre. I've been working in the drug and alcohol sector for over 23 years, and before that time had a fair degree of lived experience in addiction treatment and now in recovery, so I'm bringing that experience as well. Just very briefly, Odyssey House is a New South Wales statewide drug and alcohol treatment program, providing residential and non-residential treatment services, as well as a statewide primary and secondary prevention program. The residential treatment programs include the award-winning Family Recovery Centre, offering 16 living units for parents to come and undertake residential rehabilitation with their children, and a range of other programs. Odyssey also supports the multicultural AOD programs, mostly based in Western and Southwestern Sydney. It's one of the few specialised culturally and linguistically diverse programs in our state, and I'll say something a little bit more about that in a moment. So I was, as Stefan said, and as I was hearing the Chair saying, with the previous evidence reflecting the inquiry could have been termed the health and social impacts of alcohol and other drugs in Australia. We understand that alcohol and other drugs harms don't occur in a vacuum. Harmful AOD use is often related to other factors and causes, social determinants of health, family breakdown, domestic and family violence, trauma, loneliness, social isolation, loss of identity, and all of those additional areas. And the impacts, these impacts often outlast the initial treatment for drug and alcohol. The initial sort of health intervention for drug and alcohol, the social impact often outlasts that. We know particularly from our work with CALD communities that this sort of cliche or metaphor of the ripple effect of drug and alcohol harms is certainly true across all communities. Harms related to drug and alcohol use not just impact individuals but also families and communities, and so we know that responses to drug and alcohol harms and prevention need to also take into account families and communities. Speaking briefly about CALD communities, as I said before, we know that 50% of Australians are of CALD background, that is first or second generation. We're a non-English speaking country, and 33% of Australians were born overseas. That is their first generation, and as Stefan alluded to, we definitely know that there's a inequity of access for people from CALD communities. I say we think there is because we don't actually record people from CALD communities accessing treatment in drug and alcohol services. We record what language they speak at home and what country they were born in, but we don't record in the national minimum data set whether people are from CALD backgrounds. And just briefly, and I know many other people have said this too, and Stefan said it as well, but we definitely would like to emphasise the fact that drug and alcohol supports and reduction of drug and alcohol harms are not just a health response. There's a whole of government and a whole of community response needed. Obviously, drug and alcohol harms also impact on homelessness and family breakdown and employment and education and all of those sorts of things too. And
we might leave it there, but what we'll ask you to do is if you can both send through your opening statements to the Secretariat so they can be incorporated in Hansard. It's quite a big committee, so we've got to leave some time for questions. So we might open up to questions. I might ask Dr. Ryan, the Deputy Chair, if she'd like to ask any questions to start with. Dr. Ryan?
Yeah. Thank you very much. Thank you both for your coming to the committee today. With the CALD communities, do you think that we need to target information to those communities in specific ways? And would you think the sort of policies around public education and the like can be sort of broad-based, or should we be more targeted in messages that we get out to different communities are about the risks associated with alcohol?
Yeah, I think both things. Thank you. Yeah, so we've been doing quite a bit of work with New South Wales Health at the end of last year and this.
Can I just interrupt? Before answering questions, would you mind just giving your name so that broadcasting can identify who's speaking and answer?
Yes, thank you, Chair. You did give that instruction and I ignored it. I apologise. Thank you. So David Kelly from Odyssey House. Yes, I do think we need both generalist public education campaigns and specialists. So, and as I was starting to say, we've been working closely with New South Wales Health, particularly on a set of resources, particularly targeted to culturally linguistically diverse families and carers and communities and friends, not so much directly to the person who may be experiencing direct harms. As I think I've heard said before, stigma is a definite barrier to help seeking, and it's certainly probably even more prevalent in culturally linguistically diverse communities in our experience. So some of the public education is about reducing stigma so that elders and community leaders and faith leaders and so on have a better understanding of drug and alcohol use and harms and are more able to support their own communities. We know that specialist services like Odyssey Victoria and Odyssey New South Wales can't be the whole solution to drug and alcohol related harms.
And how do you interface with those communities? Do you have specific individuals that you might be dealing with, or is it via other means?
Yeah, sorry, it's David Kelly again. So yes, we not so much specific individuals we deal with, but we've spent. So our multicultural program's been running for 4.5 years. So we really spent the first couple of years going and engaging with community. We hold lots of, I was at one 2 nights ago for the Indian and South Asian and subcontinent community, where we have events with community and ask a lot of questions. What does your community need? What would you like from us? What would you like to see the government doing? So we're really seeking information from community by going into community and then trying to implement some of those things. A lot of that some people might be aware, we've just had the drug summit in New South Wales, and so we were able to really take a lot of that learning from interacting with CALD communities and present it to the drug summit, and a lot of that information has become part of the recommendations of the summit.
Thanks. Mr. Gruner, just any Victorian specific sorts of insights?
Yes, Stephen Gruner, Odyssey Victoria. Similar experience in Victoria. We've had a number of programs that directly target generally newly arrived communities or communities that we know aren't accessing drug and alcohol services. So an example from 2000 was the Vietnamese community. We did a whole lot of that community development work with the faith leaders, other community members, bridge that pathway into services, but also help build the capacity within the services to better respond to and understand the needs of that cultural community. And that's usually a sort of a 5-year exercise, and then really we do see more people coming through. We're doing the same with people from Islamic faith, and we worked with Council of Imams. They did all did a sermon together right across their mosques to say, look, we've got an issue in this community. We need to seek help and not just let our young people end up in prison. And again, capacity building of both the community and the services. And currently we're doing this also with African community leaders and members, South Sudanese, others right across Melbourne. And we've got a 5-year project to build that capacity. Mm-hmm. And that seems to be really effective, and we've seen numbers increase seeking help as a result of that. And yes, there's some language translation, and you've got to be at all the big festivals and all their community events and have a stall and allow families to come up and ask questions and talk. And we have bicultural workers from those communities on staff to do that.
Yeah, great. Thank you so much. No more questions, Chair. Thank you.
Thanks. Ms. France?
Thanks, Chair. Thank you both for coming to talk to us today. I'm interested in, from my own perspective in Queensland, I think we've been quite terrible in delivering treatment and recovery supports over a very long time, and I don't think we've ever got it right. And I notice that states do different things. It's just like a patchwork, and I know that there has to be some differences, but I'm just interested in the impact of the different funding streams, but also states being the deliverer of those treatment and recovery supports, and the impact on actually delivering best practice around the country, but also just, having a kind of a postcode lottery as well, in that if you're in one state, you hear about another service in a different state that is amazing, and why can't we have that here? I think locally, for me, from my electorate, I quite often hear that we've lost really intensive treatment and recovery support programs over the years. People talk about other programs in different states that are great, and why can't we have that here? So I'm just interested in the impact of the states being the deliverer of these services, but also the different funding streams, and how that, trying to encourage best practice across the country, like how. I'm just interested in that part of it.
Stefan Gruner from Odyssey Victoria. I'll start. I'm sure David's got some things to add to as well. We've got some national coordinating bodies, peak bodies, that's been refunded, and there's conferences and things. So certainly we do come together and share examples of good practice. You're right that the different jurisdictions fund things in a different way, and often it's very restrictive in terms of the treatment type that's funded and the geographic location that you can deliver that treatment type. And even at a state level with the state-funded services, the lack of sort of coordination or equity across regional areas is significant. The Commonwealth's always had a really important part to play to help smooth some of that out. And they've done that in two ways. One, through the PHNs, where some planning around where the gaps are. You can do some small programs to fill in some of those gaps and target some special populations, and often do it in a way that's either longer or different or a bit innovative or creative. And so that's been valued. But the PHNs will never fund some of the more intensive treatments like residential rehab, because it's just too expensive. They want to spread their funding through a few different providers on a number of different programs. So receiving some direct Commonwealth funding through the Department of Health has been really helpful to plug some of those gaps for the intensive services. So I'd encourage that to continue. But of course, there's still that the difficulty, and I know David put this in their submission, around the multiple funding sources mean you've got different reporting bodies, different data sets you've got to report to, different reports that you've got to write, and the complexity of that. And we've really lacked some national sort of framework or guidance that the jurisdictions have also adopted. So I think there is some level of coordination. There's some things that are working well. I wouldn't want to see it all go through the PHNs, because there's some great intensive stuff happening through the Commonwealth. But
yeah.
You want to add something to that, David?
We can't hear you, David.
You're muted.
Sorry, it's against my religion to tell people. So David Kelly from Odyssey, New South Wales. Obviously, I entirely agree with everything Stefan just said, and probably just from a more first-hand experience, Odyssey New South Wales is funded by local health districts, which is how that New South Wales Health is set up, by the Ministry of Health, which is statewide directly, by the Commonwealth directly, and by the PHNs, all as Stefan alluded to. And none of those service systems really, except for what Stefan just said, really talk to each other when they're doing service planning, even within one particular area, for example, Southwest Sydney, where our residential rehabilitation is. And it's a real, I think, missed opportunity to have those four sort of key jurisdictions to talk to each other. As Stefan said, the Commonwealth can do things the PHN won't, and the LHDs will do things that the ministry won't, and vice versa. And I think it is a missed opportunity. I'm aware the drug and alcohol program is also being reviewed at the moment, and I think that that's a real opportunity there to look at that again. Thank you.
Thank you very much, David and Stefan, for the work that you're doing. A question for me, sort of hopping into our helicopters. What do you think is the barrier to the funding that you need? Clearly, there is data and evidence of that need, and I'm just interested in what the barriers are and possible solutions.
Stefan Gruner, Odyssey Victoria. I'll have a go first. I think, put simply, it's stigma and discrimination. We know the harms are huge, and we spend a fraction compared to many other health issues to deal with the issue, because a lot of people in community still feel like people have made their own beds, they should lie in them, and they don't deserve support. This all changes very quickly when it's someone in their family or a loved one or a work colleague, where they absolutely then complain about how long the waiting lists are to get help in services. And we wouldn't for most other health conditions, social issues, accept the delays that happen, and the motivation for change can be so fleeting. To not be able to offer the supports immediately is an issue. So I think we've struggled for years, particularly at a Commonwealth level, to find any champions who, either politically or in the bureaucracy, to say, look, we know investing here is going to save so much elsewhere, because it's not politically an attractive thing to do. So there's stigma and discrimination, I'd say, is still the biggest barrier. And we've overcome that in mental health through a lot of work over many years. And people sharing their stories is still not a safe thing all the time. We see celebrities do it, and if a family member or someone shares that, we know behind the scenes there's often a kid at that person's school who says, oh, I saw your parent talking about drugs, or someone else, and the stigma has an impact, a ripple effect on them, so they're reluctant to do that.
Thanks, Stefan. So David Kelly from Odyssey, New South Wales. Again, I'd entirely agree. I think something that has definitely been put to the committee already is the research undertaken by the Drug Policy Modelling Program about the unmet need in the drug and alcohol sector and the under-resourcing, but particularly in the area of prevention. Obviously money spent in prevention is money saved in treatment and all the other sort of social harms. It's sometimes a little bit difficult to, again, like Stefan was saying, get champions for prevention, because almost the result is invisible. If you prevent harm, there was no harm to treat. But I'm becoming more and more aware that the supporting prevention and some of the education, but also early intervention programs, putting more funding into there would definitely reduce the need for downstream supports.
Thank you.
Okay. Dr. Sconce, do you have any questions?
Thank you both for your time today. Lots of questions. So particularly just very interested in the prevention side of things as well, and their early intervention. And we just had presentations as well about how advertising and marketing is having a big impact. What would you like to see in those fields of education? And I guess harm minimisation, or preventing the harm in the first place?
Yeah, thank you. So David Kelly from Odyssey. Yes, obviously there's a huge range of things that we can do to prevent harms before they happen, or intervene early, and obviously things like school education programs, which Dr. Gruner is probably a bit more across than I am, although we do support the community drug action team programs all across New South Wales, and we have found the introduction of the prevention program in New South Wales in schools has been a really effective way, particularly with older high school kids, to really provide some good, not just information, because I don't think information alone is enough, but some good influence, I guess, on younger people to support each other around drug and alcohol related harms. I do think, like I was saying at the start, it is more a bit of a whole of system approach. A lot of early intervention can actually be done through primary health care and other health services and social services. You know, I think Stefan and I would both hope that we could reduce the amount of people that were coming to our services, although we do prevention and early intervention. We'd like to reduce the number of people who are needing intensive treatment because we're able to support them earlier on in their drug use harm career. So yeah, so being able to intervene early across a range of ways, not just through specialist drug and alcohol treatment, I think would be effective. Thank you.
Stefan Gruner, Odyssey Victoria. Adding to David's comments, like most complex issues, there's no one thing that makes the difference. It really needs a multifaceted approach. We saw the failures around vaping when you get that wrong, when you don't get the regulation right or the policing of those regulations, where you don't have any sort of consistent education in schools, but not just education, it's that early support. All the teachers, all the students can identify which kids are struggling to stay engaged with schools and the reasons why. They can often see the early onset of all sorts of drug and alcohol issues emerging. And so even the work we've done in schools, it's getting a whole of school approach, so you're not just expelling a kid and moving them on to the next school or pushing them out of education full stop, because we know once that happens, the trajectory into justice and other systems is going to cost a lot more and do a lot more harms. But it's having the policies that have a supportive role. It's supporting the wellbeing teams. It's having the drug and alcohol workers in the schools doing not only the education but some programs for the at-risk young people, building their trust, and then they come and see you for counselling. And often it's drug use in the home that's the issue. Sometimes it's they want to cut down on things, they don't know how to do that. And you can work with them out of school hours and the families and on school holidays with some outreach. So even in the education system, it's not a simple thing. It needs to be a whole of school approach. But we've got to get alignment across settings. Otherwise, you see vaping take over, and now that's translating into tobacco use and often other things down the track. So we need that consistent approach, and we need a leadership from the Commonwealth. Otherwise, we end up with these knee-jerk reactions like the current thing around vaping, which then pushes everything underground, and that across any drug types has never worked either.
Thank you. Can I ask just a little bit more? You mentioned, I'm not sure if it was the GRACE or the BRACE program.
BRACE with a B, yep.
GRACE, thanks. Which is currently underfunded because it's sort of been a bit of a football, I think you describe it, between the health department and the education department. So what was that, and how would you like to see it rolled out more broadly?
Mm-hmm. Stefan Gruner, Odyssey Victoria. So this was really an approach that we developed over many years, and it's got 3 or 4 components. One is to work with the school leadership teams for that policy work that has a health response to drug and alcohol issues rather than a punitive one. The second, it's building capacity in the teaching staff and the wellbeing teams around drug and alcohol so they can respond locally. Third, it's having any one of the local drug and alcohol services resource to go into that school. And if you refer to young people in the community, they're not going to show up to your service. You've got to be where they're at, so you've got to get them into the schools. And often you're doing then some specialist programs with at-risk people. And that combination of things we've found worked. So this program is an approach that could be rolled out across the country. We don't have to run that. There's plenty of local drug and alcohol teams that could support it, but it needs funding for, a worker per 2 or 3 schools. To do it, you can do it for 2 years, you've built the capacity and you move on to another school. And it's not required at every school, it's really the schools in the high-risk areas where they don't have the capacity in the wellbeing team and they're really struggling and reaching out for this help. So it was funded through we've had many years and different iterations from trusts and foundations, but most recently the trial was funded through the Attorney General's Department, 2-year trial, 7 or 8 schools, campuses in Melbourne's outer west, really high need areas, lots of drug and alcohol and a whole lot of other issues in those schools. And I can certainly send through the Deakin evaluation report to the committee following this for more information.
Thank you. That would be great. One of the issues we hear a lot is that you get these trials and pilots or short programs that are funded for a short time. You have the research and the evidence, but often, you need a longer time to really get that data that shows you how impactful it is. How difficult did you find that short-term funding?
Would you like to start, David?
Oh, yes, thanks, Stefan. I think we're both going to say the same thing. It's extremely difficult. The sort of program, as Stefan said, these sort of programs really take a bit of time to get traction, and then sort of loss of funding obviously reduces that traction. So much Commonwealth funding is and state funding is year to year, and it's extremely difficult to get traction with new programs. And I think, as Stefan was alluding to earlier in evidence, particularly PHNs, but other Commonwealth funders are probably reluctant to fund new things, trial things, creative responses and that sort of thing, which makes it difficult to get the funding in the first place. Thank you.
Thanks.
Stefan, Odyssey Victoria, and I think some of the specialist communities also lack trust. When new program comes along, they think, do we sort of engage with this because is this just going to be another one that sets up the expectations of help and then a year or two later they all disappear? So they are also frustrated of that. I think you also alluded to the evidence, and often these programs don't come with funding for research or evaluation, or if it is, it's a sort of process evaluation of was it acceptable by the community. It's not for outcomes to really understand the impact that it's having, and I think that's a struggle across most sectors. And I think the best we can do is focus on one treatment type or one sector every couple of years, and put a really rigorous evaluation in, because if you spread yourself thinly, you get poor response rates, and it has no validity or rigour to really make a difference. Whereas if you can focus on one, do some longer term, but states and territories in the Commonwealth have very little funding for research in our area.
Thanks.
Just ask one further question.
We've got to move on, Sophie. We're running out of time. But ask a question.
I might leave it to the end. It was about avoided costs, how we get funding for things, how we account for avoided costs, because that at the moment Treasury doesn't really take account of that, but that might be a long-winded answer. Sorry.
Can I just make a quick comment on that, Stefan from Odyssey Victoria? So we do have some sort of social impact bonds and things happening around the country, including in Victoria, where that's a key component, looking at the avoided costs built into the model. They're incredibly rigorous and difficult sort of to set up. And we've also had some health economists, and I know Odyssey New South Wales have as well, look at some of our programs and look at the return on investment, and that includes many avoided costs, including to the Commonwealth of Centrelink payments, health costs, family impact, as well as their own, issues. So we do have some data that's very strong when we do invest in actually collecting that and looking at the avoided costs in this area.
Thank you.
Thanks. Good. I have a number of questions, but Odyssey, of course, started in my electorate, Macarthur, and I remember James Pitts, the original director, very well. He was a great guy. And it has focused for a long time on residential programs, which I know have been applauded, particularly some of the family programs that Odyssey's run. But are there more innovative ways of providing rehabilitation or support that don't involve residential placement?
Thank you, Chair. Yeah, so David Kelly, Odyssey, New South Wales. Absolutely there is. And I really feel like over the last sort of 7 or 8 years, as a sector, we've really broadened the way that we treat drug and alcohol related harms. I think there's a range of community-based options with a sort of stepped care approach, from sort of fairly low intensity, online groups through to, in-person groups, through to counselling, day and more intensive day programs. It's been interesting, obviously, as a range of community non-residential approaches become more available. It means that residential rehabilitation tends to be really now supporting the people with the most complex support needs, whereas our funding to do that hasn't changed at all. So people who end up in residential treatment generally have really significant mental health concerns, experiences of trauma. They're often coming through contact with the criminal justice system, et cetera, et cetera. So yes, I definitely, and residential rehabilitation is definitely not for everyone. It's not the right option for everyone, and probably shouldn't be first stop on the train of seeking support. So more and more over the last few years, we've been supporting innovative non-residential options.
Great, thanks.
Thank you.
Dr. Gruner?
Just a comment from Stefan Gruner, Odyssey Victoria. I think we work across the spectrum, and we see that the sort of demand for residential programs is clearly as a result of having fewer early interventions and prevention options. I think, like most health systems and human rights initiatives, the lightest touch possible should really be the first, and the growth of online and other lighter touch options has been excellent in providing options for people, including in regional areas where they can access things more easily. We run those counselling and day programs, but when we look at the data, we also note it's not the same groups of people seeking those different things, and it's different stage in their journey. So there's absolutely still a need and a place for intensive residential programs, and we know that even a short stay in a residential program increases people's long-term outcomes. Doesn't matter where that happens in their journey. So we still need investment there, but you're right, the continued innovation in lighter touch options is really critical and important, and a good system has the whole continuum of care, including the harm reduction initiatives where you're accepting that people's choice to use drugs or alcohol is occurring, and you're trying to keep them safe and alive until a point in time when they want to seek help or reduce that.
Yeah. If either of you could send us any information about some of those, as you term it, light touch options that you provide, that would be very helpful to the committee. Great.
Certainly.
Okay. Now, a couple of things have crossed our minds, including we heard quite concerning evidence about the amount of medicinal cannabis that's being imported into the country. Do either of you have a view on whether there has in fact been an increase in problem use of cannabis recently? And
Stefan Gruner, Odyssey Victoria.
Yeah.
So certainly, we welcome the legality of medicinal cannabis and its effectiveness in many conditions. I think there's no doubt that, again, like many systems, it's open to exploitation, and there certainly has been a high pickup in demand beyond, I think, what is probably needed for medicinal purposes. And to some extent, that's just that's as a result of cannabis still being an illegal product. I think there would be a much less demand on that system and that process if it was available in other forms, including lower strength ways of obtaining it. So what happens is when a system cracks down or over-regulates something or makes it too hard to get, it always gravitates to the more potent forms of that substance. And we've seen that with speed moving to ice. We've seen that with even during alcohol prohibition in the past. We've seen people stop drinking beer and wine and moving to spirits. We've seen that with poppies going to heroin. So the system will gravitate towards that because there's more market margin money to be made. So I think the harms could be absolutely reduced with some law reform in that area. Having said that, there's lots of examples overseas where if you don't do that well and get the regulation right, you always get some unintended consequences. So we support it. We don't think the settings are necessarily right across the country to make that as effective as it could be.
Thank you.
Thank you, Chair. David, Odyssey, New South Wales. I don't have anything to add to that. We have seen a small increase, but I don't have anything substantive to add to what Dr. Grunet said.
Great. Thank you. Any other questions? No. Excellent. Well, thank you for your evidence today. It's been very helpful. If you've been asked to provide any additional information, would you please forward it to the Secretariat by the 9th of April 2026. You'll be sent a copy of the transcript of your evidence. We'll have an opportunity to request corrections to transcription errors. And once again, thanks very, very much for your evidence today. It's been extremely helpful, and thank you for the work that you do in our communities. Thank you.
Thanks for the opportunity and best wishes for the inquiry.
Thank you.
Thank you very much.
And I will now call for a short adjournment of the committee, and we will reform at, we'll say 10:15. Thank you. Good.
Awesome. Do you want to get a photo so we can say we're in committee? I offer appointments online. I have mine at coffee shops.
Oh,
But they
yeah.
All right.
have to, like your street stalls or coffee couches.
I will reopen our this meeting of the Standing Committee on Health, Aged Care and Disability, and I'd like to call representatives of the Australian Multicultural Action Network to give evidence for us today. For the Hansard record, before giving evidence, could you please state your full names and the capacity in which you appear before the committee? Although the committee doesn't require you to give evidence under oath, I should advise you this hearing is a legal proceeding of the Parliament and therefore has the same standing as proceedings of the respective houses. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I will now invite you to make a brief opening statement before we proceed to discussion. My committee members have identified themselves earlier today, so I won't ask them to do it again. To assist with the transcription of the public hearing, it would be appreciated if you could please state your full name and the capacity in which you appear initially, and if you can state your name before responding to each question. I now invite one person to make a brief opening statement before we proceed to discussion. So I welcome members of the Australian Multicultural Action Network to give evidence today. Thank you.
Thank you, Chair, and good morning, everyone. Thank you for the opportunity to appear before the committee here. My name is Ravi Krishnamurthy. I am the President of Australian Multicultural Action Network. In short, we call it Aman. Aman is a community-led organization working across the ACT, and there are some advocacies we do across nationally as well. Our focus is mainly on culturally and linguistically diverse communities, including seniors, young people, vulnerable groups through the advocacy, community programs, and policy engagement. Through our work, we see the firsthand that alcohol and other drug harms are not just health issues, but deeply connected to the social, cultural, and economic factors affecting all the families as well as the communities. In particular, the CALD communities face significant barriers such as language, stigma, and lack of culturally appropriate services. And that's one of the main reasons where they get into delay and prevent the help seeking. And I look forward to contributing to this discussion here this morning. Thank you.
Good. Well, we're opening up for questions. Jo, did you have any questions you'd like to start? All good?
I'm interested in thank you first for coming for speaking to us today. We really appreciate it. In terms of your submission talks about some of the international models in other countries. Are you able to just talk to us about, best practice and what you see overseas and how you think that might fit in here?
Sure. I do have families living overseas as well. And time to time, we discuss across the community as well as within the family about this particular issue, right? So from our perspective, and also as a president of Aman, international models clearly show that, treating the alcohol and other drugs as a health issue, not really a criminal one, and that really helps deliver the outcomes in a positive way. One of our members who migrated from Portugal, they say that, decriminalization is basically reducing the deaths, and that stigma is where the help-seeking attitude is slow at the moment, and that is slightly better. That's what we hear from them, and eventually that leads to the improved access to the treatment as well. And I can add few other points as well. Best practice globally. It is also highlighting mainly the importance of early prevention and community engagement. And one of the point that I always mention as well about the Iceland's model, right? They do have a strong family involvement, and programs. Obviously, it's a smaller country than us. And they have some structured activities which are significantly reducing the substance use, mainly for the young people, which is really important. And one other key lesson that we have witnessed is integrating the wraparound support, which we always check with Canada, because our association, we work on a lot of health-related initiatives, and we do read about what's happening in Canada. We take a lot of things happening in Canada as our reference point as well. So housing, mental health, social services, these are all embedded clearly in the recovery. And that's mainly ensuring people are not just treated, but supported to rebuild their lives. That's what we witnessed there as well.
Thank you.
Ms. Stanley.
Thank you very much for providing evidence to the committee today. Can I ask how you would describe treatments that are culturally safe, and how do they look different to what is actually being provided currently in the mainstream of provision of service?
We do have members who have gone through some rehabilitation program. And from Aman's perspective, culturally safe health support means people should feel respected and they are understood. Often what is happening as a judgment, it shouldn't happen. They shouldn't feel that they are judged because, difference of the language or beliefs or faiths, and even the lived experience, it should be recognized as an evidence for future improvement rather than treating them as a barriers towards these people who have gone through the issue, right? And about the mainstream services, I would say it definitely requires, embedding the cultural competence as a core practice from the design phase and not just an add-on. How we can do this is through training the staff and bringing interpreters who have a good understanding of how to deal with culturally safe way while they provide support to the clients. And also systems overall should look after the diverse communities, because we know that Australia is becoming more and more multicultural, and what is happening around the world, we can see that there is a lot of migration happening, and that's a different topic. Migration is always a key topic, but we can't stop it, right? So how we support these diverse communities in a respectful and inclusive manner is what I think we would like this submission to be addressed clearly.
Sure.
And
so to stop you there, the point of this committee is to provide recommendations, which means that government can make decisions about how to do that. So you stated that you know of people who have not been treated as well as they should. How have you supported them to provide that feedback? Because my interest is that you say that, but we need to make a recommendation that gives the people who have to put these programs together a way of doing it properly, or taking that into account. And motherhood statements will never do that. So just hearing, all these programs need to be culturally and linguistically diverse, obviously they do, but from the ground up, what does that look like? Does it look like having interpreters? You said that that people should not be judged. One would hope that in any of these programs, no matter what their background is, they are not judged. They're there for health support and to change their concerns. So I'm just wondering, why do you think that is not part of what we do now?
The trust is something that we hear from our participants and our members who have gone through the issue. Is a major problem at the moment. Creating, building the trust for the members who are seeking the support. I think that is where the first focus need to be. We, as I have mentioned, we actively engage with CAL members in both family settings as well as in the community space as well. As a community leader or myself, we do have a peer network where we support people, and then we just tell them, look, come and talk to us, and let's be open and honest, because this is a way forward approach and a lesson learned from what we are hearing and how we support our members. So building the trust, I would say, is the first point here. And supporting cultural safety, I would say the other point is managing the language barriers. People coming from different backgrounds, they have different cultures, different way of speaking, different way of understanding and things. If that can be taken into consideration to some extent, that will be very helpful. I myself, migrated to Australia, more than 2 decades ago. And at the beginning, it's, trying to mix with everyone was a little bit of a challenge for me. I speak English well. I've learned English overseas. But coming into a new country and then learning the new system is where I think migrants, they need to provide a bit of a focus. At the same time, if the system can give more of that bridging opportunity for that language barriers, I think that will be helpful, because in that case, the individuals can be understood very well for what they need, and they can make informed decisions by themselves. And one other thing in our association we focus and we promote is community-led solution. We discuss with our people, and then we say, look, where there is a problem, you just come back to us and we can voice for a systemic advocacy rather than doing an individual one where we can look into the cultural values and faith and what their belief is based on their experience, and we make sure that is reflected when we talk on behalf of them to different health networks. That's one of the things, Aman, we are focusing, which is partly happening already in the system. There is no doubt about that. Australia is one of the best countries. That's what I would like to mention here. There are some aspects of the support areas, if we can improve it, I think that will be helpful. And the other information I would like to mention is about the information available in different languages too, because having a 2-page pamphlet, written about, these are the different services, you can call this number, that's a bit different. But tailoring that based on that language specific community and adding a bit more of compassionate information, I would say, in it with a bit more empathy, I think that will be helpful. That's one other. And often people going through, different issues, including alcohol and other drugs, we have seen that these are just symptoms. These are not the original problem there in the system. These are symptoms, but the problems come from somewhere else, and mainly for the migrant families, a well-settled family, for whatever reason, when they have to move to a totally different country, and then a breadwinner trying to establish the family, and then bring them to the status of how they used to live in their own country. That's where the key challenge is, that adds their stress. And not only the alcohol and drug, and gambling is something that we notice in the community as well. So how the connectors are, how do I put it? How we can connect these different issues, key issues, to the mainstream system is where the challenges comes, because helping services with more of inclusive practice is what that we are trying to look more into.
Okay. If you have any specifics that you could share with the committee about where you see the system is failing, that would be fantastic. I just have one other question. Do you have any data that your organisation collects about your belief of the prevalence of these sort of addictions in CALD communities or the communities that you look after? That you could, I don't expect you to talk to it unless you've got it at hand. And, you know, if you don't have it, you don't have it, that's fine. But if you could share that with the committee, that would be helpful. Because having some concrete information behind our recommendations is always helpful.
About the data, I can definitely mention that. Some of the workshops, when we run, we do collect pre-survey, post-survey information. I can see that, you know, based on the information that we have, about 60 to 70% of our participants, they have very low awareness and any of the support services available about the AOD, mainly 60 to 70% of CAL participants in our group, they have low awareness, I can mention that. And also, I can't exactly give, but it's almost half of our community members engaged through our Aman initiatives. They do mention about, you know, the both the stigma and the cultural shame that they mention as key reason for not seeking help. It's half of our participants in our workshop. I can definitely say that same for this.
How many actual participants would you have?
We have a member base of about 170 different families. And depending on the workshop topics that we run, we have you know, participants come from all sorts of background. There are some of the gambling workshops we run regularly. It ranges from just 10 members. Sometimes it goes up to 60 people attending our workshops and things like that. So it varies depending on the time. But invariably, we hear from most of them. It's like, look. I don't really go for help because of these reasons, because, you know, community, you don't want to open it up. So that's the key reason we hear from them.
Okay. Thank you very much for your evidence this morning. Thanks, Chair.
Jody.
Thank you very much for your attendance today. So you've talked about the stigma, the shame in engaging with AOD services, and we've heard that previously. One of the key recommendations is about adopting international best practice. So to your earlier responses to Anne, what are the key best practice strategies you think we need to implement here in Australia?
Australia, I think the population-wise, we are pretty similar to Canada. That is why a lot of our health discussions or advocacy points, we refer at what they do. I think alcohol and other drugs, this must be treated as a public health issue, as I mentioned before. This is not just a criminal issue. I think Portugal model is what I mentioned before. And investing in early prevention is something that if we can focus more, mainly for young people, for the youth, that will be very helpful, because this can be this is done elsewhere through more of a family awareness program and family engagement rather than targeting individuals. And that sort of a structured activity, I think I mentioned before, I think it's in Iceland. We see that I think it's been helpful for them. And the critical point here is a full integrated and a wraparound care. That's where Canada is doing slightly good as well. So all these international models, basically, you know, we try to emphasize a community-led co-design approach is always helpful. So include I would say, from my perspective, from our association perspective, the CAL members from the beginning, that will be very, very helpful. Any of the design, if we can be, part of that and contribute from the beginning, that'll be very, very helpful for a long-term commitment and a coordinated policy approach. Thank you.
Thank you.
Good. Dr. Ryan, do you have any questions?
Thank you so much. I'm really interested in this question of stigma. We've heard about it from a number of people who've spoken to the committee, and just wondering if you've got any suggestions regarding how we can help people get around those concerns in order to facilitate them accessing support for issues with alcohol and other drugs.
The conversations need to be just normalized. That's one of the simplest early initial first step I would like to mention here, because rather than making this as a big issue and I'm going to fix you, make it as a normalized conversation. Look, this is what's happening around, and just bring your trusted community leader with you, or people who have different faith group supports. Bring them as well, and let's have a chat about this. That sort of a normalized conversation, I would say, is the first point. I keep mentioning the same thing. I think a few times in the past in one of the previous questions as well. Community-led, education-based, a safe practice, a safe place discussion approach is always, we found, is very helpful for our members, because when they don't feel that they are judged, and then this is not another consultation, another workshop where you just attend and then you don't know what will happen after that. Rather than that, when the discussion becomes more open, and bring everyone that you would like, whoever is comfortable, just bring them in and let's have a chat. And that's sort of a non-judgmental, a culturally safe place. We found people, they find it very interesting, and they're happy to attend with a bit of food as well. And also, whole of community approach is what Aman, we always focused on, rather than targeting about any specific cultural group. We always say, look, this is an open forum, this is open for everyone, just bring, because this is more about bringing awareness, that compassion, and show the empathy, because the future is where we all trying to move together, rather than keeping someone or isolating someone. So these sort of different approaches, I would say, it'll definitely give a lot of values, and it'll make the whole system a best success.
Okay, thank you. No more questions, Chair.
Thanks. I just have one question, and that is whether you feel that we should be encouraging people from the CAL communities to go into alcohol and other drug counselling positions. We do, for example, in the Indigenous community. Should we have specific called counsellors?
We do have members from different backgrounds. Our members, they do have access to. And we hear from them that there is an encouraging sign from the communities, mainly from the CAL communities. They are approaching the counsellors, which is a positive sign. The system is definitely improving, and there is a way where they can approach these members. That's a good thing. And mainly the younger generations is where we're finding there is that bit of that reluctance, because that is a place where community leaders like us, like what I'm trying to do through Aman, we are giving them that open forum. Look, it's something okay, let's go further, and how we can work together for your own betterment and for our betterment. Let's do it together. So that's sort of an inclusive, open conversation that is helping at the moment. We can see that. And One other, mainly for the younger generations, the other approach that we follow is a peer-based approach, right? My own child won't listen very easily from me compared to his own friend. So that sort of a peer-based approach is working very well. It's really working very well. Good. So these are the main three things I would like to mention here.
Great. Thank you very much. If there are no other questions, thank you for your attendance here today. If you've been asked to provide any additional information, would you please forward it to the Secretariat by the 9th of April 2026. You'll be sent a copy of the transcript of your evidence, and we'll have an opportunity to request corrections to any transcription errors. And once again, thanks so much for appearing today. Thank you.
Thank you.
Thank you.
Thank you very much. Thanks for the opportunity.
Good. And I'd now like to call representatives of Next Gen Nurse Practitioners, Advanced Pharmacy Australia, RAD Health and the National Rural Health Alliance to give evidence today. And I think we've got a few people online. Yep. So
exactly.
I think this is going to be a bit complicated, but I will just go through a quick spiel. You will be asked, do you want to make an opening statement? I don't think we have time to have opening statements from everyone. And if you do want to give an opening statement, though, if you could keep it relatively short, it would be appreciated, because we want to leave plenty of time for questions. So before giving evidence, for the Hansard record, could you please state your full names and the capacity in which you appear before the committee? Although the committee doesn't require you to give evidence under oath, I should advise you that this hearing is a legal proceeding of the Parliament and therefore has the same standing as proceedings of the respective houses. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. To assist with the transcription of the public hearing, it would be appreciated if you could please state your name before responding to each question. And I would now invite all of you to just identify yourselves and the capacity in which you appear first, and then those who want to make an opening statement, if they could make it after that, but make it brief. Thank you. So, in person, we'll start with.
Thank you. Thank you very much. Good morning. My name is Susie Tegan. I'm the Chief Executive of the National Rural Health Alliance, and I would like to make an opening statement.
Well, we'll just get everyone to identify themselves first, and then we'll go back to your opening statement.
Hi, I'm Professor Suzanne Nelson. I'm a Victorian Branch Committee member from Advanced Pharmacy Australia, and a pharmacist and Professor of Addiction Research.
Great, thank you. Now online. Would you like to?
Yep.
Sorry, go ahead. Oh, this is difficult.
Carmen Ellis, National Rural Health Alliance Policy and Research Officer. Thank you.
Thank you. Then Mark.
Yep. Mark Powell, CEO, Chief Executive Officer of RAD Health, a community-based integrated service, and happy to do an opening statement if I get an opportunity.
Great. Then next. Sorry, you're very quiet. We can't hear you.
Can you hear me now?
You're very quiet, very muted.
Okay. I'll work on my sound. I'll get back to you.
No, that's all right now. That's good.
Hello, can you hear me now?
Not clearly.
I'll work on my audio.
We'll have to come back to you, I think. So we'll now, next. We can't hear you. No, still can't hear. Can you hear us? we might have to. We might start with Ms. Tegan first.
Thank you. I'd like to thank the panel and you, Dr. Mike Freelander, for inviting us and contributing to this inquiry. The Alliance represents 56 member organisations that represent 30% of the population, or 7.4 million people living in rural, remote and regional Australia. In rural Australia, harm related to alcohol and other drugs use must be understood in context of the broader geographic isolation, structural inequities that rural Australians face. Indeed, they're dying between 12 and 16 years earlier than people in the city, due to the cumulative effects of long-standing underinvestment, inflexibility of funding and policy, and rural healthcare infrastructure and service planning. Over 1/3 of our population live in an environment where access to healthcare, despite the fact that they pay for Medicare levy, they also pay their taxes and work in the industries that are bringing in 70% of our export income. They bring in 50% of our tourism income and produce more than 90% of the food all Australians eat, and yet they're in a situation where they're almost treated like a third world country. These disparities in the social determinants of health are closely linked to patterns of alcohol and other drug use. It is no coincidence that people aged 14 and over living in remote and very remote areas and outer regional areas are approximately 1.4 times more likely to consume alcohol at risky levels compared to those living in cities. In very remote areas, we have the highest rates of alcohol-related injury and hospitalisations, over 8 times the national rate and almost 11 times the rate for people living in major cities. Remote and very remote areas had the highest rate of drug-related hospitalisations, despite most hospitalisations occurring in major cities. It is also well established that alcohol and other drug use often correlates with comorbidities, including mental health, chronic disease, chronic pain conditions, which have higher prevalence in rural areas. And don't forget, we work with communities where people have lost their houses 3 times in the last 5 years due to fires, floods and droughts. And we complain in the city and don't even think about people that live in rural, remote Australia. Access to healthcare is therefore critical. Mediating factors in this relationship, multidisciplinary care is an important element of recovery-oriented care, allowing for the nuanced aspects of alcohol and other drugs. And that doesn't even include how it's impacting Aboriginal communities and also the multicultural community, which is here often leading with trauma and also consistent underservice. Despite this elevated need, rural communities continue to face persistent workforce shortages, and smaller rural communities, for example, MMM5, often have half of the service access than people in the city. Now, as long as I remember Australia as a Western country is supposed to be an equitable country. Place-based community-led responses are essential to rural healthcare. No two communities are the same and their care needs vary greatly. We currently have some people in rural communities and a very large percentage of people receiving at least $1,090 less per healthcare expenditure per person than in the city, and a very large percentage receiving $4,700 less healthcare, and this is from government figures per annum. In terms of our submission, we have asked for the commitment to a national rural health strategy. Without it, we continue to say that rural people are not important. We ask for increased measures to bolster the rural and remote health workforce, especially in primary care. We also ask for funding for innovative models of healthcare through creating a national rural health fund, because currently there is a a massive, many billions of dollars underfunding of rural communities, and they need to be community-led prevention, education and approaches in research. And we also ask for supporting innovative models, grants to provide research with local data through NHMRC and MRFF, increasing investment in innovation and grants and programs that support those models in clinical education, in access to housing, because we know many communities are living in housing where about 55 days of the year they have temperatures of 50 degrees, where community members are in one little room with one air conditioner, and then we wonder why people are going to drugs and alcohol to be able to deal with the situation.
Okay.
We also...
We might stop you there, and happy for you to send your opening statement to the committee. It will be recorded in Hansard.
Thank you very much.
But in the interest of time, we might go to Ms Nielsen next for a brief opening statement, if you'd like to make it.
And if I can also, on behalf of my colleague, Roo Patel, introduce her as the Senior Policy Analyst at Advanced Pharmacy Australia. I know her sound wasn't working. So she's a trained mental health pharmacist by background. So for my opening statement, just to note that ADPHA is the national peak body representing pharmacists and technicians across hospital, general practice, aged care, transitions of care and community settings, and our submission reflects that collective expertise of pharmacists working across all parts of the medicines pathways. I'm sure you're well aware by this point that alcohol and other drugs are profoundly influencing many aspects of health, including medicine safety and systems of care. Much of the preventable harm we see comes from not only substance use itself, but also system gaps. So we have very fragmented care, we have unsafe transitions between care, we have hugely under-resourced AOD programs. We would need to double the size of them to meet the need. A very stretched workforce and inconsistent use of medicines experts across these alcohol and other drug pathways. We know the scale of harm is clear. Almost 60% of drug-related hospitals are due to alcohol, with half requiring an overnight stay. That has a huge impact on our health system. We have an enormous cost of avoidable hospital admissions for chronic conditions linked to modifiable risks with alcohol, tobacco and other drugs. We have rising use of hallucinogens, ketamine and stimulants, creating new medicine safety challenges and pressures for emergency and acute care. And when we look at things like opioid overdose, even though we've made great gains, it's still one of the leading causes of preventable mortality, with more than 2,000 drug-related deaths annually, around 44% of which are due to opioids. So our submission outlines 4 evidence-based reforms, embedding pharmacists in multidisciplinary AOD teams, strengthening the continuity of alcohol and other drug pharmacotherapy treatments and follow-up between hospitals and community, upskilling the workforce through addiction medicine capability and credentialing, and improving AOD services in regional, rural and underserved communities. These are reforms that are practical, scalable and I think essential to reduce this preventable harm and improve medicine safety across the AOD sector. As mentioned earlier, I am a pharmacist with 3 decades of specialist experience in the alcohol and other drug field and a professor of addiction research. From a frontline clinical perspective, pharmacists see the medicated-related impacts of alcohol and drug in their work every day. We regularly manage patients experiencing withdrawal, relapse, toxicity, polypharmacy risks and destabilisation of other chronic conditions which are made more complex by alcohol and other drug use. We know medicines are often the first point of failure when AOD care is fragmented, and it is fragmented. We see missed or interrupted opioid dependence treatment, withdrawal medicines being used unsafely, interactions between alcohol, illicit substances and prescribed medicines. We see a real lack of consistent handover between hospitals, GPs, AOD teams and community pharmacy, and a lack of coordinated care for other chronic conditions. So pharmacists can prevent these harms by identifying unsafe interactions, adjusting treatment plans, supporting withdrawal care, providing naloxone, providing opioid dependence treatment dosing. You may not be aware that in some states of Australia, up to 90% of opioid dependence treatment dosing is provided by pharmacists. So they are an enormous part of this treatment system. But these roles are not consistently recognised or embedded in funded models of AOD care. We know that improving AOD outcomes requires reliable access to medicines expertise at all stages, from emergency departments, hospital wards, transitions of care through to community, and especially in regional and rural areas where pharmacists may be one of the only accessible healthcare professionals. So I just wanted to give you one example in the interest of time of a model of pharmacist-led collaborative care called Epic Matot, and I can provide more information in writing, but we do have models of care that can work in regional and rural areas where we have pharmacists and local communities working in collaboration with prescribers in areas where there are no prescribers, where they can work remotely to provide a high quality of care. I also think it's really important to note that the challenge that we have with AOD treatment is not that we don't have effective treatments. We have effective treatments. Our problem in Australia is that we don't have access to effective treatments. So I think it's really an issue that we need to look at workforce, we need to reduce stigma, and we need to make treatments more accessible. So we really welcome the inquiry's focus on strengthening prevention, treatment and recovery, and we strongly support reforms that centre around medicine safety and the role of pharmacists in reducing preventable harm. Thank you.
Thank you. Yeah. I mean, we are interested in innovative models as well, rather than doing the same thing over and over again. So thank you for your submission. Now we may try Darren Smith again, if possible, just see if we get the audio right. Darren, do you want to speak to us? You're still muted. You're muted.
Still muted.
Still muted. Now you're not.
Can you hear me?
That's better.
Okay. Sorry about that. I'm on the phone at the same time. It's all happening.
So could you... A brief opening statement would be great. Brief, please.
Hello, my name is Darren Smythe. I'm a drug and alcohol nurse practitioner and the director of Next Gen Nurse Practitioners. And look, my opening speech is very brief. Good morning, and thank you for the opportunity to appear before the committee. I'm representing, as I said, Next Gen Nurse Practitioners, a collective of advanced practice nurses focused on improving outcomes for people experiencing substance use and opioid dependence. Australia is facing a significant growing challenge in access to opioid pharmacotherapy, as Susie mentioned. Treatments like methadone and buprenorphine are the cornerstone of evidence-based care. They save lives in reducing overdose, disease transmission and broader social harm. But access is becoming increasingly limited. And the key issue here isn't the treatment, it's workforce capacity. Across Australia, we're seeing a shortage of prescribers, rising demand, and clinics already or near capacity. At the same time, a large portion of the current workforce is approaching retirement. Without action, this gap will grow, and that means longer wait times, reduced access, and more preventable harm. Now, importantly, we are already part of the solution. Alcohol and other drug nurse practitioners are highly trained clinicians who can diagnose, prescribe, and manage complex opioid dependence. We provide holistic, patient-centred care, combining medication with mental health support, psychosocial care, and harm reduction. Put simply, we can improve access, keep people engaged in treatment, and provide continuity when other prescribers step back. We're also critical in the rural and underserved communities, and yet we remain underutilised. That's due to a number of barriers: limited funded positions, high training costs, inconsistent regulations, and quite frankly, a lack of awareness of the role. The result is a system that is stretched, fragile and inequitable. To give a brief snapshot, in New South Wales, clinics are operating at capacity. In Victoria, over 4,600 people are waiting for treatment, with some services closed to new clients. And in Queensland, access is especially limited outside metropolitan areas. This isn't sustainable. What's needed is a practical, evidence-based response. We are recommending a focused set of actions: invest in nurse practitioners, education and roles, remove regulatory barriers, and plan for workforce transition as prescribers retire, and implement a national workforce strategy, to properly understand demand. If we do this, the benefits are clear: faster access to treatment, fewer overdoses and hospitalisations, stronger rural services, and a more efficient health system overall. So to conclude, relying on GPs and specialists is no longer enough to meet demand. Alcohol and other drug nurse practitioners are safe, effective, and a scalable option, and they are ready now. So we respectfully urge the committee to recognise their role and support the investment needed to expand this workforce. Thank you.
Thank you. Probably we should move on to Mark Powell then.
Thank you. Just lost my screen. Mark Powell, thank you to the Chair and to the committee for the opportunity to present to this important inquiry. I'm the Chief Executive Officer of Rad Health, and we're a community-based drug and alcohol and primary healthcare service. So I have a background in over 30 years of working in mental health and drug and alcohol. Being based in a primary healthcare setting is kind of that new innovative model that I think is worth considering. Where we're co-located with a bulk billing medical practice, we have in the vicinity of about 200 permits that we're prescribing in terms of pharmacotherapy. We recognise the complexity of these cases, and I think to support GPs, having a model of a wraparound service is what's required going forward. So we provide that integrated care, we provide the pharmacotherapy services, the bulk billing general practice. As you know, there's a lot of health issues that result from substance use, and being able to meet all of those needs in one environment is, I think, a critical development we need to pursue. We also engage and work with families and have partnerships with mental health and community services to really enhance that wraparound service. So we don't see drug and alcohol issues as simply the substance use issue. They're deeply connected with issues around mental health, trauma, poverty, family stress, the rural isolation, housing issues, the social isolation. So we think we need a whole person approach and the systems to support that. Three sort of key observations that I can share from my experience. I think integrated care is critical. I think we do need the multidisciplinary team kind of model for where pharmacotherapy has gone down this path of sort of training up GPs to prescribe without that adequate support. I think we see people fall through gaps, and particularly having the connections around mental health and primary care in one setting, I think is essential. My experience has really been, my eyes have been wide opened in the last 7 years working for Rad Health in terms of the value of being co-located with GPs in providing that wraparound service. And we've seen reducing pressure on hospital emergency departments in rural areas. You know, the cost of seeing a GP is a barrier. So having a bulk billing service and supporting a bulk billing service, I think, is really essential in rural areas. I think we also need to recognise the complexity of the cases. So sometimes people with co-occurring disorders, their ability to turn up to appointments, do those sort of things it's impaired, and we need to have a service that can actually help support people to get access to those treatments. And distance and cost of transport and all those sort of things are all issues within that. I really want to push for the recognition of families as being part of the treatment system. They're under-recognised, and I think substance use disorders rarely affect just one person. They have a real ripple effect on families who often carry that emotional, financial and caregiver burden and don't get really embraced into the service system well enough. We rely on a lot of mutual aid, kind of voluntary sort of programs, and I think they should be another funded part of the model. So, and the last one is the challenges that regional communities face, and it's been said already about workforce shortages, service access barriers. I think we need models, funding models that really address those kind of needs and not look at sort of statewide or national kind of one model fits all kind of thing. We need to really have that place-based approach. I'd like to emphasise that addiction is a health issue that requires compassionate, evidence-based responses. People do recover when services are accessible, coordinated and grounded in respect and dignity. So the most effective responses are those that recognise the complexity of people's lives and provide support not just to the individuals but to the families and the community as well. So thank you again for the opportunity to participate, and apologies for getting here late.
That's right. Thank you. Would anyone else like to make a statement, or Ms Ellis or Ms Ruju?
I believe my colleague Suzanne has made a statement for me. Thank you.
Oh, good. Your audio is much better now.
Great.
Good. Thank you. Well, look, we might open up to questions. We might start with Ms. France.
Thank you. Thanks, Chair. Thank you all for coming along today and talking to us about this issue, which we're all really passionate about. I was really interested to hear your, Mr. Powell, you talking about the impact of having a kind of a multidisciplinary service and one that's bulk billed, and I'm interested in how that might work and to fill the gaps right across Australia, particularly in rural and regional areas. So it would be good to get your commentary on so probably for Ms. Teagan, Professor Nielsen and Mr. Smith, on how what you think we should be recommending in terms of trying to get that sort of service up and running. And also, secondly, I assume, does telehealth play a part in that? And I assume that many of the opioid, many of the medications to treat opioid dependence, you can't prescribe via telehealth, I would assume. So what do you suggest in that space? Like, would you make recommendations for potentially repeat prescriptions? Do you see a role for telehealth in this space and as part of a multidisciplinary team, but providing some part of the service? If I could quickly get your commentary on how we might set that up.
I think it was, there were quite a few questions. One is bulk billing is fantastic for the city, but in rural areas, the cost of delivery, all of the expenses, the amount, bulk billing doesn't work unless there is block or blended funding to subsidise. We've got communities that are raising up to $600,000-700,000 purely to keep primary care. So bulk billing is not the solution. It would be fantastic if there was some block funding. Secondly, telehealth is a fantastic inclusion, just like a computer. It adds to efficiency and accessibility, but it is not the answer. It is in addition to, it supports. I think some social policy in particular about housing, employment, education, peer education for rural people in particular is really important, and the support. So there are a couple of case studies. Rural Aid does quite a bit of place-based care and confidential counselling, which is really great. They visit farmers and also other other entities in rural communities to make sure that mental health is covered. So that's a preventative thing. Mariba Mental Health Champions Network up in Queensland also does peer counselling. They have 68 mental health champions that are volunteers. And 30 of those are currently actively working in sporting clubs, in communities in general. You asked a question about multidisciplinary care. In rural Australia, we already work in multidisciplinary teams. It just happens. You have to. It works across aged care, disability and healthcare delivery. The problem is the workforce. The workforce is not being supported. They're already stressed and stretched, and we talked before about fires, floods and droughts. And so the infrastructure is not there to support those communities. It includes physicians, clinicians, pharmacists. All of the medical and health workforce across the sector is feeling incredibly stretched. And then on top of it, you've got the housing, the funding of those support mechanisms that are already great models, but they're not consistently funded over longer periods of time. So I hope that answers your question because it was multi-pronged.
Yeah, sorry, it was a few questions in one. But I wondered about multidisciplinary teams that are actually probably travelling. Do you see a role in that space?
Travelling locally?
I guess, yeah,
Yeah, because we need to support the local people. What actually happens when people fly in and fly out?
Yeah, both.
Well, it is both, because you need... So some specialist services cannot be sustained on their own because there isn't enough work for them, right? So you have to fly in, fly out, or drive in, drive out. So that's the first thing. Yes, we need them, and they are generally multidisciplinary. What is often missing is the conduit to bring them all together. But the majority of people in rural Australia actually do work together. The second thing is that there needs to be the support so they can actually drive or fly, right? We've got, through the NDIS and the PBS, and Medicare, we've actually had a massive reduction of any of those costs that actually cover. We've sometimes got the clinicians to cover them to go to another community to service that community. And as we know from our cost of living crisis, people are not able to afford being able to drive to those communities. Even medication review, we can't do many of those because there's no coverage for it. There's no cost recovery so that they can make it sustainable. That includes psychologists. We know of quite a few psychologists that have left rural communities because they can no longer afford to service their communities.
Okay, thank you.
Dr. Ryan, do you have any questions?
Thank you. Yes, I do. I'm interested in a couple of the speakers have referred to the issues with regulatory settings and how they limit scope of practice for nurses and pharmacists. I was wondering if you could give us some insight into that.
If I could jump in there first, I think even if you were to look at the numerous telehealth services, if I lead on from that were in existence prior to November last year, when we had the changes come in that you are required to see someone face-to-face before you actually claim a telehealth item, that actually reduced considerable services offered across the country by GPs and nurse practitioners for people with substance use issues. Many people are being seen, whether it's for any particular substance issue or opioid dependence, was managed quite effectively utilising telehealth. However, it's just not cost effective for the nurse practitioners to continue it because they can't claim any further. So that's been a considerable, many services have ceased existing because it's just no longer plausible for them to continue.
Thank you. Anyone else?
Yeah, if I can speak to that issue in terms of telehealth, we have good evidence that telehealth can...
Could you just give your name?
Oh, sorry, Professor Suzanne Nelson. We have good evidence that we can deliver effective telehealth for opioid dependence, and we have some really fantastic models where we have nurse practitioners providing a lot of the prescribing into rural and regional areas, for example, and we have local community pharmacists that can work with them providing the medication face-to-face and supporting that care. We have insufficient funding, even with the telehealth items, I think, to provide for nurse practitioners. And there is no way that pharmacists can claim for the time that they spend with patients. So they are able to get reimbursed for just the medication dosing, but all of those additional tasks that they can do to support care, particularly when we're talking about telehealth models, there is no mechanism, there's no MBS item, there is nothing that can pay pharmacists for their time. So we have a huge workforce that we can't leverage because we can't cover their time. So I think that's a critical issue.
Would you think it's fair to say that pharmacists are basically choosing not to offer those services because they can't do it in a way that's sort of cost efficient for them?
Well, they offer the dosing, and as I mentioned earlier, pharmacists do the majority of dosing for opioid dependence treatment, but to do more than that, to support clinical assessments, to provide face-to-face care, to do all of those other things and to have the time for that, that's what's not covered. And we know that particularly our regional, rural, but all of our pharmacists are very stretched in terms of time. So if we want a workforce to deliver these services, we have to have them be able to spend that time on those tasks.
Yeah, sure. Thank you. I understand this, but just to be exact, so pharmacists are opting not to offer that service because they can't really afford to do it in the time for the rebate available to them for providing it.
So they do the dosing. We've been trialling models of care where we're actually remunerating pharmacists to do additional things like clinical reviews. That works very well. They do a fantastic job. But we are funding that through our trials and demonstrating that it works, but there's no mechanism for funding for them to continue to do that outside the context of these kinds of studies.
We also know there are also examples of pharmacists working within primary care that are, the practice has to pay for them to be there, when really in rural Australia, when they actually could be adding much more value if they were reimbursed in a rural setting.
So can I just get it clear? Sorry to interrupt, Monique. So the pharmacists are providing the methadone, basically. But they're not providing any clinical involvement. That's what you're asking for, isn't it?
Correct. They can do a lot of tasks beyond simply dosing and dispensing and supply roles, and we need a much larger workforce in AOD. We need to leverage all of the workforce we have available, nurse practitioners, pharmacists, allied health, but we don't have enough funding mechanism for them to do that.
So are you asking for a Medicare item number for that?
That would be one structure that I think could cover the time.
Are you both asking for a block funding model where the GPs could be paid some part of that and the pharmacists another part?
Primary care needs the block funding because primary care is already often multidisciplinary. And so it basically allows the difference between the shortcoming of Medicare reimbursement and the actual cost of delivery to be block funded so that they can deliver a holistic care for patients. And that could include pharmacists, because we know that some clinics already employ pharmacists.
Sure, but in lots of country towns, they already have a pharmacist in town.
Yes, but sometimes they don't.
But if there was one, they could get part of that block funding, couldn't they?
The block funding would be about, the block funding is for primary...
So it's only for the practice?
For primary care. I mean, many of these are now community-based practices. They're no longer businesses of an individual.
Sure.
Or local governments had to pick up the pieces.
Yeah. Okay. Good. Sorry, Monique.
No, that's good. Thanks, Chair. I'm done.
Okay. Jodie.
Mark's got his hand up, Chair.
Oh, sorry, Mark. Yes, please.
Yeah, Mark Powell. Just a couple of thoughts around building the workforce in rural and regional areas that I think is worth considering. And one of the things we've seen some success with is providing rural traineeships. So our GPs train at our local university, and we're looking at, so it's giving them exposure to the alcohol and other drug sector. So it's giving them a greater understanding and appreciation of the work we're doing.
Yep.
We're currently experiencing greater needs around people with neurodiversity, so things like ADHD and autism spectrum disorder, and having the skill set to meet that need. So an anecdote to share, I guess we've had a young Indigenous person who was repeat offending, no supports really for him outside of the service that he was attending, but we got him assessed and tested and diagnosed with ADHD and autism spectrum disorder. He then was eligible for an NDIS package that then increased the supports around that individual. So, in the last 12 months, we've seen no further offending, significant reduction in substance use. So it's about how do we get those kind of services to people with complex needs. And when you're talking about telehealth, the thought, we really struggle as an AOD sector. We don't have the funding to employ psychologists, clinical psychologists particularly, but how do we make a model where they can co-locate to do some of that testing work? And one of the partnership programs with the local university that we're exploring is about having graduates coming in, doing placements, so they're a bit of a cheaper workforce to work in this kind of bulk billing model, but how do we get that supervision funded? Just something else to sort of think about within that telehealth model.
Yeah. Can I ask where are you based?
So I'm based in southwest Victoria, so we're about 3.5 hours from Melbourne, so just on the coast down there. And we have a region that we operate in. It's about 25,000 square kilometres.
And who
populates about 110,000.
And where do you get your funding?
So we have mixed funding, and that's where it's really interesting, the conversation around the block funding. So we get some primary health network funding to support our pharmacotherapy program. We've introduced the long-acting injectable buprenorphine, we've had significant positive outcomes both from consumer experience of that medication, but also from the operations of the clinic. We don't get anywhere near the level of disruption we used to get with methadone, and that sort of daily dosing it works good with the pharmacists in the region as well, to my understanding.
Yeah, maybe for the rest of the committee, can you explain what buprenorphine does and what it is? So
it's just another one of the medications to assist treatment of opioid dependence, so one of the matoid drugs. It's probably, it works well in that being a subcutaneous injection, it can last for up to a month for people, so they don't need to be going for daily dosing. They're not having to get to a pharmacist. So when you're thinking about people, regional areas having to travel significant distance potentially to get to a pharmacist, this really reduces that burden on them. It's financially cheaper. They only have to get it once a month as opposed to paying for, every weekly sort of dispensing, those sort of things. So it's it's only been around for the last 3 or 4 years, possibly for us, and been a significant, well, we call it a game changer, really, in terms of its impact for people with opioid dependence. But in saying that, there is all the other complexities that go along with opioid dependence that I think get lost if we think about one kind of solution to that issue, and that's where I keep advocating for the wraparound service, having the multidisciplinary team kind of model and looking at pathways to train local people, because it is a real barrier for people to move to our area to find housing. So professionals, they're real challenges. But if you're training someone who's local, they've already got the networks here, they've got the family. I think we need to really invest more in how do we create that partnership with academia to get the workforce on the ground.
Sure. Good. Sorry, Jodie.
Thank you everyone for your participation and contributions today. So earlier today we heard from the Foundation for Alcohol Research and Education, and I'm really interested to know what the influences are for people in rural communities in terms of the impact on alcohol and drug addiction, and from a harm minimisation and prevention community education perspective.
If I may start. First of all, we know that the research dollar isn't equitable at the moment. We've worked extensively with NHMRC and MRFF to turn that around, but there is still not enough money going to rural research to look at place-based solutions. That's the first thing, and I know my colleague believes the same. So we need to make sure equitable funding.
One of my colleagues believes the same as well.
Oh, there you go. There you go. In addition to that, it needs to be very much building the capacity of the people that are already on the ground to support that research increasing. The second thing is, in terms of, there's some really great programs already existing on the ground. What happens, though, is that they're very short-term funded. Communities build up this great capacity and all of a sudden it's gone. And so the distrust that is created by that ensures that the next program isn't taken up. Just very quickly, I'd just like to say, in terms of research, we know there's a really fantastic program. This is about housing, but it actually impacts drugs and alcohol, in particular of Indigenous communities. The program's called Will Your Junta. Dr. Simon Quilty is involved in that. It is cost neutral to what we currently have. It's a sustainable, healthy, secure housing project and will address rheumatic heart disease and alcoholism. And I think we need to look at other levers, not just how do we deal with the existing people that are, having problems with drug and alcohol addiction, but also how can we actually, prevent this from ongoing growth, because that's basically what's happening at the moment. Thank you.
Dr. Quilty, by the way, presented to Parliament this week.
Oh, he's a champion.
He is.
He's an absolute champion.
Mark, do you have any thoughts on the influences and what we could be doing from an education and health promotion sort of messaging perspective in regional and rural communities?
I definitely would encourage more in terms of that space. There is some information getting out there, but I do a lot of work with families, and their access to information is really quite poor. And I think we need to think about how we get into not only the school system, but into some of the more the farming community, the rural kind of businesses, to get that information into organisations. We've done a couple of pilot projects with a voluntary organisation here called Let's Talk, where we go into workplaces and into schools and educate them about that sort of early intervention, that recognition, and what to do if you see signs and symptoms of concern. So that's where I would like to see a bit more investment. As a funded drug and alcohol service, we don't have any funding for community development. So I think that's a gap. Really, and that's very much echoing the words that have been said today. We rely very heavily on partnerships. It's the only way it works in rural areas because of necessity and scarcity. So I think if there's any assistance that can be thought about in advancing that for us, we'd be really keen.
It doesn't matter if we go over time.
Okay. Mark, I've come from the community sector and I've done a lot of work around community hubs, particularly in the domestic and family violence space in Victoria with the Orange Door, and I'm aware that the co-location of a range of agencies and health professionals to deal with issues is very valuable. Do you think there is a place? I understand funding is important for co-located hubs with doctors, health nurses, etc., in regional and rural communities.
Absolutely. I think there's efficiencies that can be gained by that co-location and reductions in costs. As I was saying before, I think the capacity to do placements and to grow the workforce through that kind of a model where people can get access to the supervision, those sort of things, that's where I really see the future for us as an organisation, is to really grow, to get people like podiatrists, to get people like pharmacists. There's a lot of, and having the nurse practitioners, what's been talked about here in the group that you've got, I think are kind of the expertise that you would like to have very closely located. At the moment, it's really disadvantageous for people when they've got to navigate services to go from buildings to building to try and access their supports, and different gap fees, all that sort of stuff become real barriers.
Mm.
Susie, you.
Look, I want to go back to Mareeba Mental Health Champion Network. The Mareeba community, which is about an hour from Cairns, they were almost losing their last GP. The community raised hundreds of thousands of dollars in the community, and then they basically took over, and they now have 6 GPs. The National Rural Health Alliance has been working with them. They now have 6 GPs. They are continuing to try to deliver the Mareeba Mental Health Champions, except the money ran out, and then it ended up being given to somebody in Brisbane who had no idea of this community. And so, there's... And they have been in a building that they have to move out of. There is no infrastructure funding. But the point I'm trying to make is that they want to continue to do this sort of service. They are on the ground. They understand the community. They work with 10,000 palm workers every year. There's a whole lot of people in those communities that they want to work with. But there are other communities just like them. So the multidisciplinary hub is fantastic, but they don't have the capacity to do it, even though they want to. They've been looking for funding to actually be able to move into a multidisciplinary care facility.
The hub and the nub of the problem, isn't it? Where do we get the funding from?
Exactly.
And how do we use it in the most
And they're doing it for nothing. They are doing it for nothing. It's all volunteers.
Well, we need quite agree, a multidisciplinary approach. But the question is how we get a funding model that works. And I think from what everyone's been saying today, and correct me if I'm wrong, that we do need to look at using Medicare funding for part of it, but some of it requires either block funding or grant funding.
And infrastructure funding, yes.
Yeah. Now, I mean, the pharmacy, pharmacists being part of the group sounds good, but I'm just interested in how we do that in rural and regional areas when we don't actually have a big enough workforce, and how we pay for it.
I think we absolutely need training pathways to build those workforces, but I would also look to examples in Canada and the UK where they have pharmacists working to full scope of practice, doing a lot more in a very efficient model of care because they are less expensive as a workforce but highly skilled. And if you look at the US, and as a really good example where nurse practitioners are a huge part of the workforce and they've really increased capacity. And again, I think making sure we're using our whole workforce to their full scope of practice, because we know that primary care is at capacity and we need to really enhance them. And there are many things that we can have nurse practitioners and pharmacists doing that would be more affordable in those models of care.
Yeah, I don't think we would argue any differently, but it's how we get them all together, because I take Mark's point that in the alcohol and other drug space, you can't be sending people to multiple different appointments with multiple different fees and gap fees, etc. So how do we get them all working together in a hub?
And we're doing some current work with health economists to look at different models of delivering pharmacotherapy treatment that might be more effective for the same amount of money. That's work that's underway, but it's certainly something that I can forward when it's available. But I think that there are examples internationally.
When do you think that will be available?
It's probably a little while away, but I can send further information about the work that's going on and some of the international examples that we've got.
Yeah, and I know we're a bit over time, but one of the other groups who've approached us have been the College of General Practitioners, and they are keen to have more involvement in the alcohol and other drug dependency space, but they have asked for increased funding for more prolonged consultations. I just wondered what the Rural Doctors Alliance...
ACRIM, I was just going to say ACRIM is also looking at that because we have more complex issues in rural, remote and regional Australia. They're usually comorbidity issues, and we know that rural people tend to go to, nurses, doctors, a lot less, partly because of the workforce shortage, partly because we have a continuous revolving door and the trust sometimes misses, and then in addition to that, partly because they are just stoic. So longer consults are good because usually they come with a shopping list.
Okay. And what about using telehealth in having doctor-to-doctor consultation, for example? Is that...
So doctors and doctors with patients?
Yes.
Well, I think people are actually doing that to a certain extent. We know that the rural workforce likes being supported by urban people when they don't have the skills at a local level. You can't just refer to a specialist, down the street. And so, the colleague system is really important. And that is why the training, and Mark mentioned this before, the training of the future workforce, having rural background, rural medical training or allied health or nursing training, and then being placed in rural. We know the evidence is there, and the relationship between an urban large hospital or large practice or specialties is really crucial. It's so important to people on the ground.
So more efficient use of maybe case conferencing, item numbers, that sort of thing. I'm interested what Darren and Mark think about that. Maybe start with Mark. You've got your hand up.
Yeah, Mark's Al. Just to add to that, we fund an addiction psychiatrist to provide that supervision of our GPs, so they're getting that blend of an understanding around mental illness presentations, but also the pharmacotherapy and the addiction kind of management. But that's unfunded, so we fund that out of our own resources. And there's Medicare items when he does secondary consultations to patients, but he also provides the supervision as well. So it's one model.
Great. And Darren, what do you think of that? Would you like to comment? Having an addiction nurse involved as part of the team?
Sorry. Nurse practitioner, a bit different than the general nurses. Look, I think we should be probably looking at a lot more innovative models in regard to sort of hub and spoke delivery of care. I know that there are some already existing that providing sort of opioid pharmacotherapy around New South Wales that might be operated perhaps out of Newcastle or Sydney, for example, and they're looking at managing various patients elsewhere. The problem with that is if that doesn't exist, then people have to go and try and utilise Medicare or other NGO systems that just not going to be able to do it because they're unable to get the funding for it. But I do think a lot of it relies more, and we need to be providing more undergraduate education regarding alcohol and other drug use to medical, nursing and allied health to attract people into the profession to be able to provide the, I suppose, the staff to work in this space to begin with.
Yeah, because at the moment we don't really seem to have the workforce that can cover this.
No, because very few professions actually have undergraduate education in substance use, so it's not actually seen as a specialty, and therefore, and it still is so heavily drowned in stigma and discrimination that very few people come to this space. So if we want to, and we realise now that we're going to have state, national and international shortages of clinicians, that is showing itself very much at the moment. And you work in various areas where I am in northern New South Wales, the flood capital of, I suppose, Australia, Lismore. You can't get people up here. So because there's no housing, you don't have the education within the undergraduate curriculum. So how do you fall into this space? And managing RPA, like I did many years ago, was quite often people that have injuries that want to come into the space. But I think we need to be much more innovative in how we deliver care, being that we are going to see considerable shortages of clinicians moving forward. How do we actually address the particular issues? And I think because we are in these areas where I am now, you can't get a train. Many areas don't have buses. You cannot get into this facility if you live 40 or 50 minutes away. So having your local pharmacy that may be out in that location might be great, but it is very much about us building relationships with those people, and we work very well with them at the time. But it is undergraduate education, but I do think we need to come up with more innovative hub and spoke models where you are providing telehealth, but that the person can afford it, and hopefully they've got the services that they can be involved with that telehealth. That's another big issue in drug and alcohol as well, whether people have access in regional areas to the internet or do have a phone or do have a computer where they can be involved in telehealth. But I do think we need to move more in that direction.
Great. Thank you very much. Sorry, Professor Nielsen,
Yeah, we just skipped over your earlier question about kind of longer consult time for GPs, and I think that's absolutely part of the picture as well, because we know when we're talking about patients with opioid dependence, for example, these are often patients with complex needs. They've got multiple chronic conditions. It's not like this is a brief intervention. We do need a team around, and I think that the current funding model for these very complex patients just doesn't quite fit. So I think that's part of the solution that I don't think we got to kind of properly acknowledge is really important, but as part of collaborative care with other parts of the treatment team being able to support the GPs so we're making the best use of their time as well.
Sure. Well, I think we need to make the best use of all our clinicians' time. I just don't think the Medicare model is the total answer, though I would say, from a lot of the evidence we've heard.
Despite the fact that we're very lucky to have it, it just doesn't suit rural, remote Australia.
Well, it can in many areas, but I think there are some that require a broader look at how we make it work best. And I think the multidisciplinary teams in particular is, we would all agree, is the best practice. It's just a question of how we do deliver that. It's probably very easy in my electorate. We have Odyssey House in my electorate, and they do provide a multidisciplinary team, but when you move a few kilometres away, it's very hard to provide those sort of services.
Correct. We can learn a lot from the ACHO model, actually.
Yeah, I agree. Yeah, 100%. Good, but any other questions from the team? Monique, you all good?
I'm all good, thanks, Chair.
Good. Well, thank you for your attendance here today. If you've been asked to provide any additional information, would you please forward it to the Secretariat by the 9th of April 2026. You'll be sent a copy of the transcript of your evidence and will have an opportunity to request any corrections to transcription errors. And also, if you'd like to forward us your opening statements, we will happily include them in Hansard. It's just that we were a bit short time today, so I'm sorry about that.
Thank you for including us.
No, thank you for coming. It was great.
Thank you.
Thanks.
Thank you.
Thank you.
Goodbye, everyone. Thank you. Thanks a lot. See you later. Right. Now, I would now like to call witnesses from the Australian Medical Association, Dr. Danielle McMullen, and the Australian College of Nursing, Ms. Frances Rice. Hi Danielle, Frances.
Morning.
Now I'll just very briefly go through the thing. For the Hansard record, before giving evidence, could you please state your full names and the capacity in which you appear before the committee? Although the committee doesn't require you to give evidence under oath, I should advise you that this hearing is a legal proceeding of the Parliament and therefore has the same standing as proceedings of the respective houses. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. To assist with the transcription of the public hearing, it would be appreciated if you could please state your name before you respond to each question. And I will now invite you to make a brief opening statement after you could identify yourselves and the capacity in which you appear. So we might start with Ms. Rice, if that's okay.
Thank you, Chair. Frances Rice, Chief Nursing Officer, Australian College of Nursing. Thank you for the opportunity to speak to the committee today. I'm representing the Australian College of Nursing and I speak from the perspective of the nursing profession, Australia's largest and most geographically distributed health workforce. Alcohol and other drugs continue to have a profound impact on the health, safety and well-being of individuals, families and communities. Nurses see these consequences every day in emergency departments, primary care, rural settings, mental health services, aged care, correctional health and community outreach, all the way across the health system. We not only see the statistics, we see the people behind them. The Australian College of Nursing strongly supports a public health, evidence-based approach to alcohol and other drug policy and funding. We advocate shifting from punitive or crisis-driven responses to prevention, early intervention and continuity of care. Nurses are central to achieving this shift. Nurse-led solutions are among the most effective and scalable tools we have. Nurses deliver brief interventions that can reduce harmful drinking. They provide withdrawal management, harm reduction education and ongoing psychosocial care. They're trusted health professionals capable of engaging people who often do not connect with other parts of the health system. Nurse practitioners and advanced practice nurses are already leading alcohol and other drug services in parts of Australia with demonstrated improvements in access, retention in care and health outcomes for consumers. Australia can leverage this expertise further through nurse-led assessment and treatment models that reduce waiting times and hospital burden, expanded scope of practice including registered nurse prescribing in structured models of care, investment in alcohol and other drugs specialist nursing roles including in rural, regional and remote communities, integrated community-based services jointly addressing mental health, chronic disease and substance use, education and training enabling every nurse to confidently screen, intervene early and provide culturally safe care. If Australia is to meaningfully reduce the short and long-term impacts of alcohol and other drugs, nurses must be equipped, authorised and supported to deliver the care they are trained to provide. This is a practical, workforce-ready and community-centred solution. Thank you.
Thank you. Dr McMillan.
Thank you very much. Dr Danielle McMullen, National President of the Australian Medical Association, and also like to thank the committee for inviting the AMA to be here today. We're the peak body for medical professionals representing doctors of all specialties and all career stages right across the country. And I'll acknowledge that I'm joining you today from the lands of the Yuggera and Ugarapul people and pay my respects to their elders past and present. And note that alcohol and other drug use has had a disproportionate impact on our Aboriginal and Torres Strait Islander communities, and that we must strengthen culturally safe supports and our Indigenous workforce in particular. I'm both the president of the AMA and a GP. In my job, I see and treat people with alcohol and other drug dependencies. In fact, in the past week, had 2 new patients disclosing harmful alcohol use and reaching out for my support. But I also hear the stories from my many colleagues and members who do the same, and we welcome the chance to contribute a medical perspective to your deliberations today, and thank you to our ACN colleagues for being here from a nursing perspective. I want to start by saying that we need to do better. We need to do better in tackling the stigma that people face when they have an alcohol or drug problem. We need to do better in delivering and maintaining harm minimisation and treatment options. I think we are examining 2 slightly different issues today, and that the approach needs to be different for alcohol as opposed to other drugs. And while the harms can be similar in many ways, there's a significant difference in the social licence and stigma between alcohol and other drug use, which impacts users, the use environment, and of course our opportunities for action. No one's locking up the person with an addiction to alcohol who's ordering their 3rd or 4th or 5th bottle of wine from an alcohol delivery service. But on the other hand, someone with a very real and incredibly difficult to beat addiction to an illicit drug may face the full force of the law. And that, of course, isn't to undermine the very real harms that alcohol's causing in our society. As doctors, we see our patients' social, physical and mental health and that of their families is often at risk because of their substance use, which leads to things like reduced household income and social disruption. I think that disruption is often felt across society, which in turn sometimes leads to ill-informed policy decisions that can sometimes cause more harm than benefit. People who experience the harms of alcohol and other drugs need to be supported and not condemned. Treatment for substance use disorders must be based on clinical decisions about the most appropriate holistic approach for the individual, considering both the extent and severity of their problem, but also the individual's goals, their context, health and safety considerations. GPs and addiction medicine specialists play a crucial role in that care, but these services are in short supply across the country, most particularly in rural and regional Australia, as you just heard from your previous speakers. I think that's not through lack of desire, but rather a lack of supports for that workforce. Some groups are especially at risk of harmful substance use, and the intersectionality of substance use with other issues, including domestic and family violence, is really a real issue. And this highlights why it's not a health problem alone, and addressing harmful alcohol and other drug use must be a shared responsibility across social, housing, legal and health services. So at the AMA, we strongly encourage this inquiry to make recommendations that put a harm minimisation approach first. And we've made a number of clear suggestions. Firstly, that GPs and other health practitioners who treat substance use are essential, and a concerted effort is needed to boost workforce and services, particularly in rural Australia, and a blend of fee-for-service Medicare funded services and blended funding through coordinated teams, coordination across both state-based hospital services and primary care are really essential. Community-led programs for education, prevention and intervention need long-term investment. Too many programs, good programs, begin and then really quickly are gone due to a lack of funding. I think the recent report into PHN business models would be interesting perhaps for the team to have a look at in terms of how we can improve some of that grant funding and sustainability. A prevention and harm minimisation approach is needed, including alcohol marketing regulation, mandated labels, pill testing, medically supervised injecting centres, and school-based and other education. And lastly, minimum data sets collected across Australia are really critical to ensuring that our research, investment and actions are directed in areas dictated by evidence. Our discussion today, as my nursing colleague said, needs to recognise the benefits of shifting our focus from stigmatisation, criminalisation and penalties to providing suitable healthcare and treatment for people who desperately need it for substance use disorders. So thank you, and I look forward to questions.
Great, thanks, Danielle. Monique, would you like to open questioning?
Oh, thank you. I might speak to Danielle if I could. Would you be able to just comment on workforce for general practitioners in particular, but I guess for all medical doctors, and challenges from a workforce point of view in addressing the issue with alcohol and other drug services in Australia?
Yeah, I think so. GPs obviously have a broad breadth of practice, including alcohol and other substance use. It is part of our curriculum through GP specialty training. And then there are broader, other workforces commonly involved are psychiatrists and other physicians with an interest in alcohol and other drug use, including toxicologists and clinical pharmacologists. The GP workforce has a range of pressures at the moment, but as the previous panel talked about, one of those is around longer consultations, and I would echo that strong call to modernise our MBS framework so that there is a fair and adequate rebate regardless of the length of your consultation. Alcohol and other drug use often requires more than 10 or 15 minutes to really unpack the issues, build trust and talk through the range of issues while you've got a captive audience. You don't always get these patients back regularly as much as you might try. And so being able to address a range of health issues in the one consultation is important. And at the moment, Medicare rebates incentivise shorter care, higher throughput. And so at the AMA, we do have a campaign to modernise Medicare, but any measures taken to better support longer consultations in this context would help with the workforce pressures, as well as broader reforms, particularly in rural and regional workforce, to encourage rural GPs and other doctors, and also investments in multidisciplinary care. So this is an area where close collaboration with our nursing colleagues and pharmacists and others, social workers in particular, is really critical. And so in practices where they're seeing particularly a high volume of people with other alcohol and other drug use problems, investing in some of that boosted multidisciplinary care, potentially through an increased workforce incentive payment, would help address the issues and support our workforce to do that.
Thank you. So just to summarise that, so longer rebates for the doctors, but also potentially increased block funding to allow group practices to function to a higher level. Would that be fair?
Yep, agree.
Great. And in terms of, thank you, and in terms of just making sure that we've got bums on seats in medical practices, but also in community health centres and things like that, do you think that we have workforce planning strategies that are up to speed at this point, or do you think that they could be improved?
There's definitely room for improvement for national workforce planning. We still don't have a clear idea of how many doctors we have, where they are, and what kind, more importantly, what we need into the future. So we would strongly call for better national health workforce, not just medical, but all of health workforce planning, strategy and implementation so that we're prepared for the workforce we need into the future.
Thank you. Agreed. Thanks, Chair.
Thanks, Monique. Jody, would you? Jody?
No.
Ali?
No, I'm good, thanks, Chair.
Good. Would you like to ask?
No. Okay.
Ms. Rice, do our nursing staff get enough training in alcohol and other drug areas?
Probably not. Nursing, a registered nurse qualification is a minimum of a 3-year bachelor degree or a 2-year master's for those who've already got other qualifications, and there is a lot to fit into a 3-year curriculum to train a generalist nurse in this country. So there are elements of it taught throughout the curriculum, but probably not in the quantity to enable nurses to sufficiently support people across the health system with alcohol and other drugs in the quantities that we see them, because they are all the way through the health system, in the acute system when they need to attend, and nurses are supporting them to manage their withdrawal and substance abuse in those locations, and also in every other health service.
They're also, as you I think pointed out, are very widely distributed in rural and regional areas, and even remote areas where there may not be doctors or other health workers. There is usually
a nurse. Yeah, definitely. And so there is a growing number of nurses who are specialising in alcohol and other drugs. Still reasonably small, 2,500-ish nurses and around 80 nurse practitioners in the 2024 data.
And do they get a special qualification?
There are qualifications out there. They may have chosen this as a specialty or are already specialised in a mental health service delivery and then continue to specialise into alcohol and other drugs. But in the nursing scope of practice, you can use a lot of different educational opportunities to bring knowledge into your scope of practice.
Yeah, and is there a demand, do you think, for people to want to look at working in these areas, or for nurses that work in rural and regional areas to get some training in alcohol and other drug management?
Absolutely. There are nurses who are always looking for support to grow their knowledge and skills in particular areas to service the communities that they work in, be that in a metropolitan area or those who are servicing smaller communities with less resources, as we see as they get further and further away from metro regions. But there is a challenge in access to support to study and to gain those additional qualifications.
Right. Does the College of Nursing keep data on people who work in that area?
We don't specifically keep data. That's data that's collected in the Commonwealth, but we can access it in a similar way. We do have a great relationship with the Drug and Alcohol Nurses Association in Australia and work with them to grow their skills and knowledge of the nurses who are working through that organisation, as well as those in ours.
Worth asking them for some information. Yeah. Have they made any views known about workforce to you?
There's always workforce challenges in nursing and a need to grow nurses with specific skill sets to address particular issues across the country and particularly in alcohol and other drugs, as we see its impacts on society more broadly. So there is always a need to grow more nurses and to support more nurses.
Sure, but do you have any data about that, or any workforce information that you could forward to us about it?
Not necessarily about people who want to join, but there's lots of data I can provide you about alcohol and other drug nurses and mental health nurses more specifically, but not necessarily about nurses already in the profession who are looking to train into that. But I can find it through expressions of interest into programs and things like that.
Some information would be good about the numbers that are already working there and the numbers who've expressed an interest, or what training programs are available, because we don't have any of that information.
Great, I can collect that for you.
If you wouldn't mind forwarding that to us, because we have heard from a number of sources about the importance of access in rural and regional areas and even in metropolitan areas, and the use of multidisciplinary teams, of which nurses would be a big part.
Yeah.
And it'd be interesting to have some concrete information about that.
Absolutely. I can support. I can send that through.
Great. And Daniel, if I can go to you just now, we've heard also a lot about different funding mechanisms, and you've mentioned the remuneration for more prolonged consultations, multidisciplinary teams, but what we've heard is that the Medicare system doesn't really cover the funding for that. So where would you envisage we get the funding from?
Like many complex conditions, substance use disorders would benefit from a blend of funding. And I think we need to recognise that we're in a federated health system. So some of this will be state-based funding through their drug and alcohol treatment services in public hospitals. Some will be Commonwealth funded largely through primary care and general practice, but also through PHNs and grant funding and other Commonwealth-based community funding. And I think while that's messy, that mix probably needs to continue. These people will often access different services. Yeah. We would suggest that all Australians should have a regular GP, and we are working not just in this space but across general practice more broadly to support more blended funding there. And so that would be an increase in our workforce incentive payment to allow practices to hire more nurses and allied health staff to meet the needs of their population. And in the context of this kind of work, that could be social workers, mental health trained nurses, or other drug and alcohol support staff. So the AMA is supportive of more blended and block funding to allow practices to expand in that way, but still recognising that you do need a medical workforce involved, GPs and other specialists. And at the moment, the large block of that is through Medicare fee-for-service funding. And that's where I mentioned longer consultations are particularly underfunded. We're open to looking at how that blend of funding changes over time, and there is work happening in the department around that. But I think to be realistic and the pace of change that we need to happen in areas like this, your easiest mechanisms are looking at your MBS and your workforce incentive payments that already exist, because we know that building new things and new streams will take time and change management. So that agenda is continuing in parallel more broadly than just alcohol and drug use.
Yeah. And look, I think there has been pretty general agreement, not just from the AMA, that we need a harm minimisation approach, and to try and remove the issues from the criminal justice system wherever possible. What's the AMA view on things like pill testing and better education for young people about the dangers?
Yeah, we're supportive of whole-of-life education campaigns, so from school-based, evidence-based education right through to public education campaigns about the harms of alcohol and drug use, but also where to get supports, including directing the public to talk to their usual doctor. In terms of pill testing, we're supportive of pill testing to reduce the harms, and there's been various state-based trials that have shown a reduction in harm, or at least a picking up of where there is a particularly harmful or contaminated batch of pills that consumers, the general public, change their behaviour based on the advice there. And it's also an opportunity for brief interventions about alcohol and drug use more broadly. And medically supervised injecting centres, while they're few and far between, have been really valued by communities, along with needle syringe exchange programs, including in prisons and other environments. These programs need to be supported. We would appreciate both Commonwealth and state-based leadership on this. I think advocacy groups and medical groups, including the AMA, have been talking about this for decades, and it still seems like a fight that it shouldn't have to be. These are medical services that support the health of our citizens, and yet either continuing things like pill testing or existing medically supervised injecting centres, let alone expanding them, seems to be this, a really difficult fight when it shouldn't have to be. There's good evidence for these programs, and they need to be supported.
Yeah. If I can take it a step further, we have had a lot of evidence about alcohol availability increasing harm, and also increasing risk of family violence and violence against women. Does the AMA have a view on that?
That also features in our submission. So alongside any education around the harms of alcohol to the individual, we do think it's important to highlight to the public around harms to families, including domestic and family violence. I think the increasing availability or ease of availability of alcohol and increasingly other drugs with home delivery services, online availability. These things do increase the risk of harm. It's when you no longer have to be able to safely drive and get to a bottle shop but can have large volumes of alcohol delivered within the hour, that is a concern to us. I understand some jurisdictions have now put time limits on some of those things, but we do think regulation of alcohol supply, labelling and marketing could be stronger. You mentioned the youth market, I think, and we remain concerned about the advertising of alcohol where children and young people might be exposed to it. Bright colours, new flavours, packaging that's attractive to young people, and some of the health claims on some of these items about being sugar-free or healthier options all feeds a narrative that some products within an alcohol category are safe, when clearly evidence would say they're not. And I think some of the public messaging is slipping there, and we could do harder both from a regulatory but just a general community awareness perspective to reboost the awareness of harms of alcohol.
Thanks. Now, Ms Rice, does the College of Nursing have any views on the harm minimisation and alcohol policy as well?
Oh, absolutely. Well, I would support what Dr McMullen has just shared in terms of harm minimisation being the preferred approach in this space, particularly when we see impacts across the lifespan. I don't have expertise in that area to speak to it specifically, but we are very supportive of harm minimisation and any reductions to people becoming addicted to alcohol and or other drugs, or it becoming problematic in their lives.
Right. Okay. Any other questions? Good. Well, thank you so much, both of you, for coming along today and giving us your professional expertise. We value the work that you do as well, and we value the evidence that you've given us, and we are still having a few more public hearings, and we are going to Western Australia after Easter to hear from them about some of the aspects of alcohol and other drug dependency, particularly in isolated communities. And we hope to have a report ready in the second half of the year, probably around July, August. But if you've got any questions you want to ask us, please feel free. And if you've been asked to provide any additional information, could you please forward it to the Secretariat by the 9th of April 2026. You'll be sent a copy of the transcript of your evidence, and we'll have an opportunity to request any corrections to transcription errors. And once again, thank you so much.
Thank you.
Thank you very much. Thank you.
All the best. And have a good Easter.
You too.
Thanks. And I will now interrupt our meeting for a break, and we will reconvene at
That's what I had to ask. Has
12:45.
given us evidence? I know how they talked about Aback with complaints.
Professor Alison Ritter from the Drug Policy Modelling Program at the Social Policy Research Centre, UNSW.
Thank you. And the guys in the SPH Advocacy Lab, I think you're from a number of organisations. Perhaps you could introduce yourself.
Hi, I'm Dr. Rachel Rose, Senior Lecturer at the School of Population Health, and I'm accompanied by postgraduate students of public health. I'll let them introduce themselves.
I'm Dr. Fiona DeMello. I'm one of the postgraduate students from the Advocacy Lab.
My name's Amy Leahy, also a postgraduate student from the Advocacy Lab.
And I'm Laura Bathy, also from the Advocacy Lab.
Great. Well, thank you all for attending this session this afternoon. We might just start with, give you the opportunity to just make brief opening statements, if that's okay. Dr. Ritter, would you like to start? Professor Ritter, sorry, would you like to start?
Sure, thank you. Thank you very much for the opportunity. We made a submission back in September 2024, and I wanted to update a couple of things from that, and also with reference to the March 2025 issues paper that the committee tabled. 3 key points of evidence from my point of view. The first is in relation to alcohol and drug treatment services. The second is in relation to decriminalisation. And the third is in relation to novel pharmacotherapies. So in relation to alcohol and other drug treatment, the terms of reference are about assessing whether current services deliver equity, value for money and best outcomes. I would argue there's a more important question, which is simply, is there enough treatment being provided? And in recent research that we published last year, we did an estimate of the number of people who miss out on alcohol and other drug treatment in Australia. Our epidemiological estimates indicate that about 400,000 people is the potential treatment population in Australia, and in 2023, 200,000 people received treatment. So we're treating about half the number of people who want and seek treatment. This is not just everybody with substance use disorder. And that number hasn't changed since 2014, when we developed our first unmet demand for treatment estimate. So Australia is not making progress in relation to delivering treatment, let alone equity, value for money or best outcomes. Second area I wanted to comment on was the removal of criminal penalties for drug use and for the possession of drugs for personal use. It's really pleasing to see in the March 2025 report that the committee is concerned about investigating this issue further, because it links directly to health harms and health outcomes. There are multiple different arrangements across Australia, and we've summarised these in a bulletin that we published in June 2024. Happy to make these materials available to the committee. My team is currently leading the evaluation of the ACT decriminalisation reforms. In fact, the final report is due on Monday, and that will be subsequently tabled in the ACT government, Parliament, and I anticipate that that will provide important information for reforms for other jurisdictions. I'd also refer the committee to UNAIDS that last week issued a guidance note for good practices in relation to the decriminalisation of drugs. And importantly, they included significant input from the international network of people who use drugs. And I think the importance of living and lived experience voices into this dialogue is essential, and I commend the UNAIDS guidance note on decriminalisation to the committee. Finally, novel pharmacotherapies. We've seen a significant increase in long-acting forms of opioid agonist treatment. What Australia has failed to make available is short-acting injectable opioids, such as hydromorphone and diacetylmorphine. We've just completed an NHMRC funded trial of short-acting injectable opioids with Uniting and St Vincent's Hospital, Sydney. It was a small feasibility and acceptability trial. It resulted in excellent outcomes. 68% of the people in the trial subsequently have been maintained on opioid agonist treatment 2 years after the commencement of the short-acting injectable opioids, which was time limited. It would be important for us, and this evidence contributes to international evidence on short-acting injectable opioids. So this is a novel pharmacotherapy that's currently not available in Australia but has strong evidence. Thank you very much.
Thanks for that. Really appreciate it. What about the team from the UNSW School of Population Health Advocacy? Would you like to give us a short introduction to your feedback?
Thank you. Committee members, thank you for inviting us to provide evidence today. We are a group of postgraduate public health students and academic researchers who come together in the School of Population Health's Advocacy Lab to support equitable responses to the harms associated with some alcohol and other drug use. We speak today from the experience of working in detox units in major hospitals, non-government drug and alcohol treatment services, specialist programs for culturally and linguistically diverse populations, and with lived experience of substance dependence. Harms related to drugs are exacerbated by inequitable systems. For example, a justice system that disproportionately criminalises Aboriginal and Torres Strait Islander people, or a housing system that prioritises investors over people who are homeless or living in precarious rental conditions. It is important to acknowledge that not all substance use generates harm, and that assumption actually fuels stigma. We urge the Standing Committee to address the dramatic imbalance between a health and wellbeing centred approach to drugs and law enforcement approaches. Law enforcement approaches are more costly and often exacerbate the cycle of harm to families and the wider community. We support the attention in the issues paper to alcohol advertising and would like to offer further evidence today regarding the urgent need for better regulation of online platforms that sell alcohol. Another area that is relatively unattended in the issues paper, but relates to the inquiry's third term of reference, is the urgent need to fix Australia's housing system with investment in public housing and stricter protections for tenants. In our professional experiences, lack of safe, stable and secure housing is a crucial missing element for people exiting AOD treatment, including detoxification services. We thank you for your time and welcome any questions.
That's great. Did any of the others of you, is that just a joint statement on your behalf?
Yes. Yes.
Okay, thanks so much. You're very good. Thank you. Great. And then I might just go to the guys in the room, please, to, just scrolling. Yes.
Thanks very much. And thank you for the opportunity to present here. We'd just like to note that the impacts of alcohol and other drugs in Australian society are quite broad. And as we have done in our submission, we're keen to focus on the areas we can contribute to the evidence base. And we would note that we are a research centre and not an advocacy organisation. But as far as the national picture is concerned, we have a system in Australia that has had international recognition for its innovative approach, particularly to harm reduction. However, more recently, the approach to governance, funding and workforce development and human rights issues for the broad and complex treatment sector has not kept pace with the challenges of a modern and changing society. As an organisation, we're internationally recognised and work across both the country and with international organisations to make significant impact to contribute to the evidence base that forms the structure for the national drug policy. We're happy to report that this year, and we'll talk a bit later about it, is the 30th year of activity of drug trends, and next year will be the 40th year of NDOC's functioning, which indicates a sustained approach of government to supporting research and an evidence framework for policy, and that forms the bedrock of the thing. And we work along with other national research centres and other key organisations, including user organisations and special populations. The range of work across interventions and prevention, treatment, justice and harm reduction with policy impacts overlap between criminal justice, health, key populations and evidence-based policy. Basically, I think one of the things to note is that, noting Alison's mention of the injectable medication, we would also note that Australia has probably one of the most elaborate opiate dependence treatment systems, and now that a quarter of the population in treatment are on long-acting injectable buprenorphine, and the provision within the prison system has increased substantially as a result of that. So as well as noting limitations in terms of investment, it should be noted that there are some aspects of the system here that are exemplary. That doesn't detract from the point Alison made about funding and treatment capacity issues. Just to note that other areas we've been involved with is areas of development of methamphetamine treatment, and in partnership with NCRED, developing areas where there are major need for new innovations and new tools for treatment, and also in development of medicinal cannabis guidance for both for the TGA and currently for the Veterans Administration. I think we need to leverage new methodologies to shine a light on policy options such as alcohol pricing in Australia and pricing options for young people's access to alcohol. In the other area that we are being quite keen on is evaluating the impact of the diversion program from the criminal justice to health, showing a 6% reduction in imprisonment rates with those who access these diversion programs. And we're keen to focus on key population groups and special populations. We also look to the future, to the importance of new data technology and new linkage processes and new information technology to revolutionise and to understand the systems into the future. I will hand over to Amy Peacock, who will mention briefly about drug trends.
Thank you, Michael, and thank you all for the invitation. To overview Drug Trends, Drug Trends is Australia's national system for monitoring illicit drug use, markets, behaviours and harms, and it's operated for 30 years now. Led by us at NDARC in collaboration with national centres across the country, and we're funded by the Commonwealth Department of Health, Disability and Ageing. We provide timely, independent and policy-relevant evidence, and our model is internationally recognised as best practice in drug monitoring. What we do is we collect data from a range of sources. We do interviews with people who use drugs across the country each year. We analyse a range of administrative data such as hospitalisations, mortality and treatment episodes. And we also take advantage of technology advances to collect more novel data, such as looking at drugs being sold on the darknet and on the surface web. We issue around 80 outputs per year, so that's bulletins, reports, data assets, presentations and briefings, and these are widely used by federal and state and territory governments, as well as national agencies such as AIHW and international organisations such as UNODC, as well as the broader sector. Some of the key developments that we've identified in the recent years include the emergence of new psychoactive substances, and in particular data around the emergence of synthetic opioids and novel benzodiazepines, increases in harms related to a number of drugs including methamphetamine, and changes in drug use patterns and markets with the pandemic. Our work informs parliamentary inquiries and regulatory decisions and has guided policy in Australia and the evaluation of that, including take-home naloxone and drug checking in Australia. I would note that we also have a strong program of work around alcohol and policy priorities in that space, including alcohol pricing, delivery practices, marketing to young people, and parental supply of alcohol to young people. Thank you.
Thank you. So was that Ms. Kowalski? Did you want to say anything? Or? I'm good. You're good? Okay, lovely. We might go to questions then. Thank you all for that feedback. And it's amazing to see UNSW doing such great work in this space. Ms. Stanley, did you have any questions?
No, I'm good at the moment, thanks.
Okay. Ms. Bellier?
There are so many of you doing incredible work and research in this space, so thank you all. For me, one of the things we're trying to understand is what are the recommendations, your key recommendations here for the committee, and I imagine that you will have similar and different recommendations. Would someone like to share with us what if you had a magic wand, what would you like us to do?
Is this for...
And we can start with you, Professor Farrell.
Well,
How about that?
I think I applaud your focus on the importance of the system. I would like to emphasise, first of all, the need for it to be a priority in broad social and health and justice policy, and for it to be linked across those, and to note the importance of the justice health link and the need for capacity to reduce the number of people going through the justice system, are better again going through the health system rather than the justice system, and that whatever way that might be achieved be considered. And we're not the one to say exactly how that will be achieved. Alison has strong views on that, but I think the point of it is that it is a priority that we shift the resources from criminal justice to health and we get people the help they need.
Thank you, Professor Farrell. Alison, do you want to go next to add to that?
I think the question was specific recommendations. I think we know that the vast majority of government spending in responding to alcohol and other drugs is law enforcement at 64%. That's the drug budget work that we published in 2024. Prevention receives 7% of the budget, harm reduction 2%, and treatment 27%. So the lion's share of resources are expended in a law enforcement response rather than prevention, treatment or harm reduction. More specifically, we need to increase the investment in treatment. It's not just about more funding, it's also about better systems of care and better leadership from the federal government. You will have heard, no doubt, about the challenge of the absence of any national governing framework for alcohol and other drug treatment in Australia. The committees that used to meet, which people like Michael and myself were on, around developing national guidelines, national workforce initiatives, all of those things were disbanded at the time of COVID, and we no longer have an intergovernmental committee on drugs. We have no national system, and this is particularly problematic because alcohol and other drug treatment is cost-share funded. About 30% of the funding comes from the Commonwealth Government and 70% comes from states and territories. And there's enormous opportunities for better leverage of that investment with coordination, national leadership and national governance.
Thank you. That was really helpful, Alison. Who would like to go next? Is it the Advocacy Lab?
Yeah. We note the attention in Section 5 of the issues paper to the need to regulate advertising, which we note has also been raised by the Australian Medical Association, and we wish to elaborate on two key points, particularly in relation to online advertising. The first is the need to regulate online food delivery platforms. I work in an inpatient AOD detox ward here in Sydney, and one thing I hear often from patients is how impossible it feels to escape alcohol marketing. A common example is opening an app like Uber Eats just to order dinner, only to see alcohol featured at the top with special offers based on their previous purchasing history. These ads also continue to appear even after the person selects the opt-out option for advertising sales on their app. Alcohol is being sold through platforms that people primarily use for food, which can be delivered easily to their homes. For people trying to reduce or stop drinking, this constant targeted advertising is unwanted and very harmful. We're asking people to reduce harms in an environment where highly sophisticated advertising algorithms push alcohol on them on everyday apps with no meaningful consumer protections. We would not accept this for tobacco, and we should not accept it for alcohol. Industry algorithms should not be allowed to target people with alcohol advertising when they're simply trying to order dinner. The second issue is the urgent need to get ahead of alcohol advertising with regards to regulations that protect communities. New research led by one of our group members, Laura Bathy, found that alcohol companies are making unsubstantiated environmental claims about alcohol products, which is known as greenwashing. This is particularly concerning for young people who are generally more conscious about environmental issues and therefore may be more susceptible to being misled by this kind of marketing. Further, there's a growing concern about zero alcohol products and their potential to increase young people and children's exposure to alcohol branding and the normalisation of alcohol consumption in this group. Laura's recent research found that there is moderate support for restrictions on the advertising of zero alcohol products in public spaces, possibly reflecting the lack of awareness of the role of zero alcohol products in promoting parent alcohol brands. In order to protect young people who are more vulnerable to alcohol-related harm and appear to be targeted by these emerging marketing trends, stronger restrictions on alcohol advertising are needed. For example, prohibiting the use of environmental claims on alcohol products and applying the same restrictions that are currently in place for alcohol product advertising to the zero alcohol products. International experience shows us that stronger advertising controls work. For example, Norway's comprehensive alcohol advertising ban was associated with an immediate and lasting 7% reduction in alcohol sales, linking out to lower overall consumption. If Australia reduced our alcohol sales and consumption by 7%, that would result in an annual reduction of $5 billion a year in the cost incurred by the harms associated with alcohol.
Wow. Thank you so much for that. Dr. Peacock.
Thank you very much. There's probably 4 things that I would highlight. To start off with, I would say that the drug landscape that we're looking at presently is more complex and more rapidly evolving than ever before. We're seeing some major shifts in our more traditional illicit substances in terms of rising harms, but also the emergence of newer synthetic drugs. So related to that, firstly, I would call for continued investment and focus on monitoring around these substances. We need to have systems that are proactively identifying emerging trends of concern and bringing together data for us to be able to respond in a timely fashion. Related to that, because of the nature of these emerging substances and because consumption is often unwitting, so unknown to people, there needs to be a real emphasis around our harm reduction practices. Obviously, we have quite a strong take-home naloxone program in Australia, but thinking about reaching those populations who may not typically be associated with take-home naloxone, where we see people using stimulants who are being exposed to, say, opioids. Related to that, the importance of drug checking as a means for people to have information to understand what they might be consuming, and I'm really heartened to see Cantest presenting after us today. To move to my next 2 things, I'm going to jump a little bit on the alcohol side of things as well. Firstly, I'd like to talk about alcohol taxation. Our work around alcohol pricing has shown that in New South Wales, you can buy alcohol for as cheap as 26 cents per standard drink. That means that you can consume in excess of the alcohol intake guidelines for $1.30. Our current taxation system is inconsistent and in particular enables the sale of cheap, high-volume wine and is something for consideration. I would also note work by a colleague as well, and building on what we've just heard around alcohol marketing. My colleague from Catherine Backholer from Deakin University has been looking at exposure to alcohol marketing online to young people and has noted that among people aged 8 to 13 years old, they see approximately 4 alcohol ads a day, 6 alcohol ads a day for those aged 14 to 17 years, and approximately 7 alcohol ads a day among those aged 18 to 25. Now, these are preliminary results, but the take-home message here is that young people are being exposed to these alcohol ads in this online environment, and there's a real opportunity there to address that. Thank you.
Monique, back to you.
Thanks, Jodie. Sophie Scomps, would you like to introduce yourself and would you have any questions for the team?
I do thank you, Dr. Ryan. Hello, I am Dr. Sophie Scomps. I'm the independent member for McKellar. Thank you all for your presence here today and the work that you're doing. I might just follow up from the last point there, and that was around the advertising or the marketing online. What would you like? I'm not sure who to target it. I haven't got names either on my screen, I'm sorry. But what would you like to see happen with legislation around alcohol advertising? Is there a particular way of doing that, as in limiting how many ads are seen on TV or online, or what would you like to see happen?
So I'm referring to a work from a colleague here. We are doing ongoing work in this space, but my understanding from the evidence that we're seeing to date is that it is very difficult to try and restrict advertising to young people. They are often logged in, say, on family devices or similar. So it means that interventions that are targeted just at young people are probably not going to be effective. There are ways around this. So really what we need to be looking at is restrictions on alcohol advertising more broadly across the board in the online space. But I would pass to the Advocacy Lab to see if they have further thoughts on that.
I might just jump in on that, if I may. That question you raised about Uber is a bit fascinating. Would it be, if you could expand on the question, that would be great. But can I just also add a sort of a supplementary bit? Would it be true to say that any child who is jumping onto the Uber Eats app could be or might well be exposed to alcohol advertising?
I imagine that would, again, I think to Dr. Peacock's point, if they're on a family app or if it's a family login, and we've seen, I think, recently with, the social media ban, they're just creating an account where they're over 18 years of age. So, yeah, it'd be very common, I imagine, to see, and is there any regulation that Uber Eats wouldn't be advertising to those even with an account that is under 18, right? So, yeah, it'd be very likely. I think I don't know if there's if you can, not order something, but again, all you have to do is put in a fake birthday and we can be any age online, really. There's no other verification.
Okay, thank you. Sorry,
oh, that's okay. Just to add to that, so again, talking about Kath's work over at Deakin, most of the exposure that the particularly young people, like the children really, like the 8 to 12-year-olds that Amy was talking about, their exposure is on like a family device, mainly on YouTube is where a lot of those ads were coming up. And just so I don't know how many of the 8-year-olds are on Uber Eats, not saying they're not, don't know yet, but it's kind of that exposure at the family level on not just social media, but like YouTube's not part of the ban as far as I understand it. It's on all, and also there's exposure just while you're online, not just necessarily on the apps. There's a different part of that work as well, which is that it comes up that these ads are targeted, and that's something that's kind of important to bear in mind, which means that not everyone sees them. So referring to studies from other people, also I think they're up in UQ, that we're looking at who gets served these ads. This is a different cohort. This is like university students. So at least half of the university students in this study were not served ads at all for alcohol. But those who were seeing an ad every 3 seconds. So that kind of builds on what they were talking about with the Advocacy Lab about people who are having problems with alcohol being constantly served these reminders about like, come and drink this, order this. So there's the problem about the exposure to the ads, but there's a real problem around the targeting. So there's a question about whether there could be policy to address the specificities of like, you can't necessarily have targeted and tailored ads in that space. Yeah.
Is that targeting, do you think, because these people have been found to be more vulnerable to alcohol advertising?
So they're very good at protecting their algorithms and how they're targeting people, but generally, so I can speak from the other side of it of, say, buying ads while looking for research participants, which is something that we do sometimes. When we're looking to recruit participants online, so we'll do an ad spend through, like, let's say Meta, and that will be on Facebook and Instagram. And they're more likely, they tell us that they will do everything to put that ad in front of people who are more likely to act on it. So what we know from that side is they will try and get people who are as susceptible to what's ever being advertised to them as possible. How they go about that is one of the questions that I personally would love to study and hope to get funding to do. But yeah, we don't have those answers.
We would be happy to take the question on notice and consult with some of our colleagues who work closely in this space here at UNSW if the committee would like that.
Thank you. Thank you. Would anyone like, Dr. Ryan, would you like to continue on that vein? Otherwise, I was thinking about shifting.
Well, I would actually, Dr. Scomps, if that's okay. Thank you. Can I just ask you, so we had some of the public health researchers from Deakin in the House this week, actually, and they spoke with a group of it around how increasingly the gambling industry is using paid influencers to market gambling, essentially, but not through what appears to be paid advertisers, but what is embedded content within the content that the influencers are disseminating. Do any of you have evidence of that happening with drug and alcohol for young adults or children?
So not that we have undertaken directly, but there are collaborators who have undertaken work, and we can take that on notice and provide some information if useful.
Oh, thank you. Yeah, I would really appreciate that. I might circle back to you, Professor Risher, if I could. Can you just briefly, for the committee's benefit, assuming that we're at a degree of ignorance, summarise for us why it is that the short-acting agents are better than, which aren't yet available in Australia, are better than the long-acting variants on the opioid agonists?
Yeah. Thank you for the question. I mean, they're not necessarily better, but what they do is reach a population for which the longer-acting opioid medications have failed. So there's a proportion of people who are experiencing opioid dependence who have tried methadone, buprenorphine, long-acting buprenorphine, and have not found it to their liking. And it's about between 5 and 15% of the population of people who use opioids. And these are the people experiencing significant harms. So for the NHMRC study, we collaborated with Uniting, the people who run the medically supervised injecting centre, and they had people who'd been coming to the injecting centre to inject illicit opioids for years and years and years. And this was the first time that they felt there was a treatment option suitable for them that would be acceptable to them. So it's about targeting a population of enormously marginalised, stigmatised and very high risk and very unwell people who are opioid dependent. So it's that small group. And I think making it available, our study looked at how to integrate it within an existing opioid agonist treatment clinic. So you don't want to set up new bricks and mortar. You don't want to make this a big thing, but you want to have it available as an option for the small number of people experiencing enormous amounts of harm who haven't responded to the other medications that are available.
Okay, thank you. And Dr. Peacock, can I ask you something? Does your monitoring through the drug trends system, does that pick up medicinal cannabis that's being prescribed by online telehealth providers?
Unfortunately,
outside of the PBS?
Unfortunately, not. Sorry. Yeah.
Do you have any insight at all into the sort of the relative? So my impression is that there's an absolute explosion of medicinal cannabis being prescribed to those sites. Sometimes with a vertical system where you can obtain it via the telehealth provider. Would it be fair to say that we're missing that, do you think?
Well, I'm not sure we're missing it. I think we're quite aware of it. It's been clear that the explosion of online prescribing as the key and large-scale provision, and I think there's a need for regulatory review of that and also professional overview of some of the practices associated with it to see that it is in line with decent professional practice. So that it is one of the issues I think when we talk about new technologies and distance treatments, that the takeoff in internet prescribing presents as much as advantages, presents potential risks also.
I would also note, just to come in there, that the ACT has legalised cannabis for personal consumption, and you're allowed to grow a certain number of plants. And it would be interesting to look at the rates of medicinal cannabis prescribing in the ACT relative to other jurisdictions where there is only a black market for cannabis, recognising that the use of medicinal cannabis is not necessarily for a condition for which it is indicated medically, and that there's a very blurry line between use of cannabis for overall well-being and quality of life versus for specific medical diagnoses.
That's a really good question. I guess my question is, do we have the capacity to do that study? Could we compare between the jurisdictions, given that the people who are accessing the medicinal cannabis via these telehealth sites? I'm asking, are we capturing that data? Do we actually know? I think we all know phenomenologically that it's a really big problem and it's happening a lot. Yeah. But do we actually have any insight into the numbers of people who are? I don't think we do. It's a bit of a Dorothy Dixon, I guess. We're not capturing that. It could be a much bigger problem than people. Anyone contradict me if I'm wrong, but I think it could be a much bigger problem than people appreciate. We don't know what adverse effects could be resulting from it, and so we're possibly, I think it's probably fair to say we'd struggle to do the study that you're suggesting might be helpful, Professor Ritter.
I think there are ways to access that information or that data from multiple different sources. I'd refer to Professor Wayne Hall's work along with Mefwani Graham. They've been reviewing the prescribing patterns of medicinal cannabis extensively, and they're probably the experts at being able to answer how is online prescribing monitored and what do we know about the postcodes and the apparent indications for use that are being recorded.
Yeah, great. I'm sorry, I don't want to monopolise things. I'm not sure if anyone else from the committee has any questions.
I just have one question, if you don't mind, Monique.
Sure. Ms. Stanley?
You've talked about greenwashing. I don't understand what you mean. Do you want to explain it to you? Because sorry. Can you explain the whole greenwashing thing to me?
Yeah, sure. So greenwashing is a term that applies across kind of all forms of advertising to make a product seem more environmentally friendly. So kind of like a lot of the airlines, they carbon offset, things like that. And within the alcohol space, they'll say that this is better for the environment, or we plant a tree, or all these sorts of things that make it seem like the more environmentally friendly choice. If I was choosing through, from 5 different beers, this one might be one that plants a tree for every time I buy a case of beer. So I would buy that one because I'm, environmentally conscious, which is quite something that's interesting and a focus of like young people as well. Would I have said that right? Yeah.
Okay. All right. Thank you. Sorry, I still don't see what... yeah, okay. It wouldn't appeal to me, but anyway, maybe to somebody else. Like, I don't know how you even know that they would plant the tree that they're promising to plant, but okay,
it would be
sure.
Advertising. So again, it's a big part of a marketing strategy for a lot of companies. Again, not just in alcohol, it's coming across. I think we saw in the paper that we did, it was something that we looked at with QR codes, and they did have kind of like a corporate responsibility page, and it showed you, how they reduced emissions and, things like that. So again, it's not unique to the alcohol industry. And again, it's very targeted at young people because, a lot of us would be like, I don't know if I trust you anyway, or are you going to plant that tree? But it's a really common across a lot of industries, and we're seeing it in the alcohol industry to target young people in particular, who that is something, but they do put it forward in their advertising. You'll see like a company, page about, how eco-friendly they are and things like that.
Okay. In the same vein as putting influencers into social media. Mm-hmm. I am on social media a lot because it's the nature of the job that I do. And I don't think I have seen an advertisement for alcohol at all. I know I'm clearly not the demographic. Clearly I'm not the demographic on top of which I don't partake. That doesn't help it either. And I expect this afternoon all I'm going to get is advertising because I have my phone here and whatever. So I'm just wondering how effective is this marketing then? Like, I am really concerned that we're giving 7 to 14-year-olds so many pieces of alcohol marketing every day. Is the marketing obvious that it's alcohol, or is it like is it a bottle of wine stuck in the screen, or is it just suggesting that that's a good thing to have with a dinner? Like, is it a glass of wine on a dinner table? I just wondered what this advertising looks like.
Would you like, if it's okay,
Sure.
I might kick off and say, I think you've kind of hit the nail on the head there a bit, in that often it isn't, it's almost subconscious, the display of it. So for young people, I guess maybe to start, more broadly, people are quite bad at recalling their exposure to alcohol marketing online, and that is because it is just embedded as a natural part of it. And even in this study that I referred to, conducted by my colleague Catherine Backola, when they asked young people, often they didn't know that they'd been exposed to it, or said, actually, isn't it a bit weird? I do remember that one. Why are they targeting, a 12-year-old with an alcohol ad? So the displays of it might be, as we've heard, an influencer, just chatting away and having a drink at the same time. It might be watching a clip about a sporting ad and there's alcohol marketing all over them. But there is very explicit advertising as well of some products where it is very obviously an ad being delivered to young people. Again, I would refer to the Advocacy Lab if you'd like to add anything to that.
Can Laura say? I might just jump in the meantime then and say that we can provide the committee with visual examples of some of the ads that they've circulated before that they can show. And there's also, UQ also has a repository of all the advertisements, almost all the advertisements that Meta has run in Australia for alcohol. So I can try and get some of that in, but we can also get some of the advertisements or examples of advertisements that specifically young people have been exposed to. Yeah. But also to say, like you, my feed does not have any alcohol on it. But I pick up a friend's phone and we look at her Instagram and the whole thing, and almost every third thing you see has alcohol in it. Wow. So that's the point about it and being targeted. They know that there's no point showing it to you. Like, my feed is cats and knitting and food. Yeah. So they're very good at targeting.
Yeah. Okay. I'm sure it won't be this afternoon though, but anyway. Okay. That would be fantastic. Yeah.
Laura's not listed on the hand side. She's very keen to contribute, but she's not listed for the hand side, which is why we're sitting here awkwardly. But we would be very happy to take that on notice and send you some more information.
And also on greenwashing as well.
Yeah. Oh, thank you so much. Thanks, Dr. Ryan, very much.
Thank you, Ms. Stanley. Dr. Scompton, do you have any more questions at all? You're on mute, Sophie. Back.
Thank you. I just have one last question if we have time, and that's around a number of the submissions, I think, mentioned needle and syringe programs and injecting centres, and I just wondered if we might just briefly have maybe comment on the impact that these programs have had on the incidence and prevalence of different diseases, bloodborne diseases like that in Australia compared to other countries that maybe don't have those programs.
Sorry, I just missed the tail end of that.
Oh, it was just around a comment on the impact of these programs on the incidence of different diseases compared to other countries that don't have those programs?
Sure. I mean, I think it's incredibly strong evidence that needle syringe programs reduce the prevalence of bloodborne viruses, HIV, and Australia has one of the lowest HIV rates in the world because of the early introduction in 1985 of needle syringe programs to Australia, and it's an enormous public health success in relation to that. Supervised injecting centres are obviously, a somewhat sensitive topic, but having operated the supervised injecting centre in Sydney for coming up to 20 years and not a single fatality, I think there's very strong evidence that for people who attend these services, it is life-saving. And in addition, their referral out to attend to wound care, general health, contraception for women, all sorts of general health services is also exceptionally high. So the healthcare, the add-on healthcare from attendance at a supervised injecting site is enormously positive.
Can I follow on from that? Have we got enough of these injecting centres? What would you like to see of those?
I think it varies by jurisdiction. I think what's important about the locations of supervised consumption sites is that they're located in areas where there is an existing cluster of people who are injecting in risky and harmful ways to their health. So that's an important consideration. They are very site-specific. Secondly, I think we're at a point with the international literature that we shouldn't be thinking about bricks and mortar services. We should be thinking more about mobile services which are available overseas. So sort of a van that drives around and assists people, for example. And in addition, I think there is opportunity to think about needle syringe programs as offering a place for someone to also safely consume. There's an enormous paradox in our extensive distribution of clean needles and syringes and injecting equipment that we provide this, but we don't provide the support. Knowing that someone's going to inject, we don't then provide the support for a safer, more healthy opportunity for injecting. And I think there's some innovations there around needle syringe programs being able to potentially also offer support in relation to safer consumption, notwithstanding that all injecting drug use is potentially harmful.
Could I just add a little bit to that?
We're going to have to finish up talking after this. Thanks.
The challenge, as Professor Ritter mentioned it earlier, is the challenge of the funding of the system as a whole. And then there's sort of the question for us about cost opportunities and different options. We know that in evaluation we did of the New South Wales treatment programme for opiate dependence, it results in a 40% reduction in mortality. And the achievements of it are quite extraordinary. But the challenge for us is how we broaden the population treated and how we can afford different modalities. And that's one of the big challenges for us into the future is what the funding will be and how extensive the options and interventions can be. But most of these interventions demonstrate that they reduce mortality.
Thank you.
Well, thank you. I think time is up, so I'm just trying to find my chest notes, but thank you all for appearing in front of the committee this afternoon and sharing your expertise with us. There are, I think, a few outstanding things which people have offered to provide to us as information on notice, and would be very grateful if that could be forwarded to the Secretariat. Sorry, 1 second. Trying to open a document, but parliamentary Wi-Fi internet is very, very slow. I just remind you, so it won't open. I just remind you that the information that you've given today, it does attract parliamentary privilege, but it is a matter of parliamentary record. Jim would be very grateful if you could forward it to the Secretariat by the 9th of April. You will be sent a transcript of your evidence and have an opportunity to request any corrections to errors of transcriptions. Thank you very much for appearing in front of us this afternoon. Very grateful.
Thank you for the opportunity.
Thank you,
Thank
everyone.
you.
Thank you.
Thank you all.
Yeah.
Yeah.
Can I ask a question? Yeah. Norway has been cited on a number of occasions. Do you reckon we could talk to them?
May I have some water?
No, there's two of them. You're on mute, Monique. You would think after you.
Happens to the best of us.
Oh, yeah.
It's all the algorithms sucking in all our comments to spit back some alcohol advertising to us. Oh, I'm waiting for the advertising this afternoon.
Okay, sorry about that. I keep getting cut off. I'm not sure what the problem is. Thank you. Sorry about that. Thank you to the members from Cantest. Is that Ms. Stevens?
It is. Good morning, or good afternoon, I should say.
Hi, how are you? Sorry about the technical problems. Thank you for appearing in front of the committee this afternoon. We'll just start by introducing members of the committee and then we'll go to you, Ms. Stevens. Dr. Scoms, could you introduce yourself, please? No, you're on mute, so.
Again. I'm Sophie Scoms. I'm the independent member for Mackellar on the Northern Beaches of Sydney. Welcome.
Thanks. Jodie and Anne.
Anne Stanley, I'm the member for Werriwa.
Jodie Ballier, the member for Dunkley in Victoria.
Lovely, and thank you. I do apologise for the delays. Ms Stevens, for the Hansard record, could I ask you to state your full name and the capacity in which you appear before the committee, please?
My name's Stephanie Stevens and I'm the Acting Chief Executive Officer of Directions Health Services.
Thank you. And although the committee does not require you to give evidence under oath, I should advise you that this hearing is a legal proceeding of Parliament and therefore has the same standing as proceedings of the respective houses. The giving of false or misleading evidence is a serious matter which could be regarded as contempt of Parliament. The evidence you give today will be recorded by Hansard and attracts parliamentary privilege. I now invite you to make a brief opening statement before we proceed to discussion.
Thank you very much. I'm here on behalf of Directions Health Services, which is the lead behind Cantest Health and Drug Checking Service, alongside our partners Pill Testing Australia, CARMA, the Canberra Alliance for Harm Minimisation and Advocacy, and the ANU Research School of Chemistry. I'd like to acknowledge the work of the committee and the Proceeding Issues paper, which I'd like to note has a wonderfully affirming health lens to the AOD issues we're talking about today. Directions Health has been operating in the ACT in New South Wales for nearly 50 years. We've always taken a harm minimisation approach and a non-judgmental approach to ensuring that vulnerable people have access to essential services. Our services span early intervention, harm minimisation, not just Cantest, but also the NSP or needle syringe program for the ACT, amongst other things, residential rehabilitation, community-based treatment, primary health care, mental health services and family and carer support. My remarks today will focus on harm minimisation as being a cost-effective health investment, offering early intervention, reducing demand on acute services and improving long-term outcomes for people experiencing vulnerability, with opportunities for us to improve harm minimisation together. I'll draw on ACT-specific examples, including Cantest and integrated harm reduction services, which together demonstrate strong returns on investment, measurable health impact, and the need for extended services that can meet growing demand to avoid harm. I'll just cover some familiar ground for us as context. Approximately half of all Australians report having used an illicit drug, with 18% having used one in the last 12 months. We know that around 3 to 5% of the population will experience problematic use or perhaps dependency, and that they perhaps may require a more intensive or expensive form of treatment or support, meaning that the majority of people who use substances will benefit from a harm reduction approach to avoid preventable harms. However, we continue to take and fund a stigma perpetuating and harm inflicting legal approach to substance related harm, as opposed to an evidence-based health approach, which your paper notes. Over 87% of national drug offences are consumer related offences, as opposed to 11% which relate to drug supply offences. Those who experience dependency and the greatest AOD harms often have lower social determinants of health. This means that the disadvantaged are further marginalised, then subsequently experience greater harms at the hands of the system intended to make our communities safer and healthier. Personal use of drugs is a health problem, not one we have been able to solve with legal penalties. These serve to perpetuate harm and stigma. Despite this, we continue to invest most heavily in the supply reduction pillar of harm minimisation, and as your paper notes, up to 56% of people seeking support every year cannot get access to it. It is time to put our money where the evidence is, both for the health of our nation and because it makes economic sense. Harm reduction is a preventative approach that directly supports health system sustainability. To build on the evidence in your paper, the ACT recently commissioned economic modelling by the Burnett Institute and the ANU that showed that the combined harm minimisation package in the ACT offers a saving of $185 million every year in health and social costs. This is a return of $11 on every one invested in harm reduction in the ACT. And this is not taking into account the recent developments with the introduction of nitazines and novel and counterfeit benzodiazepines, which the modelling indicates returns a greater investment for the dollar invested in harm reduction. This speaks to government budget objectives to reduce avoidable demand on acute services, to shift investment upstream, and to support people before crisis point is reached. Despite this, harm reduction receives the smallest share of funding, with my colleagues who spoke previously finding that only 1.6% of government drug policy expenditure is allocated to harm minimisation. This compares 1.6 to 64% on law enforcement, 22% on treatment and 12% on prevention. We'll now turn to Cantest. The Health and Drug Checking Service provides a clear example of how preventative investment responds to true community demand. Over its first 3 years, now into our 4th year, Cantest has tested over 6,000 drugs. This has generated critical early warning intelligence and more than 50 community safety notices about dangerous or concerning drugs. We've also provided almost 6,500 health and harm minimisation interventions. Our sustained growth since inception indicates a reliance on this service as core public health infrastructure, as opposed to some sort of novel or pilot service. Importantly, our 3rd-year report confirms that we are now at capacity, with people often turned away from the service, which shows that there is demand in the community for people who are seeking to prevent drug-related harm for themselves and those around them. From a budget perspective, this signals a service that is absorbing pressure that would otherwise surface in emergency departments, in ambulance call-outs, hospital admissions, and all come at significant cost to the health system. Cantest reaches people who would not otherwise engage with mainstream services until it's critical. I refer you to the 2023 ANU Independent Cantest evaluation, which demonstrated its effectiveness in impacting drug consumption behaviours and risk-taking, and also showed that 70% of people attending Cantest had never spoken to a health professional about their drug use before. This is a population actively seeking to avoid health services or to not disclose their substance use, who willingly came in and had a health and a harm reduction intervention about their drug behaviour. From a budget and a policy perspective, this is critical. These are individuals who typically might otherwise present late and expensively to the system. Cantest provides early engagement, brief intervention and referral at the fraction of the cost of acute care. The purpose of drug checking is not to endorse or encourage taking drugs, and we never give a green light on taking a drug. Our information is grounded in evidence-based recognition that no drug is safe and that providing accurate information reduces the risk of serious harm, including overdose, if drug consumption does occur. The value lies not only in testing, but in measuring behaviour change, which the ANU evaluation demonstrated. To date, around 40% of substances tested don't match client expectations. On average, year by year, 9% of clients discard their drug in the service. And the report also showed that people are less likely overall to take a substance as a result of coming into Cantest. But if they do, they are more likely to do it in a less risky way due to the information they've gained. It's a clear example of a small, targeted investment producing population-level impact. Finally, regarding Cantest, the 3rd-year data highlights increasing complexity and volatility in the drug market, which my colleagues before me also mentioned. This includes the presence of novel psychoactive substances with unknown risk profiles. Cantest has detected hundreds of novel psychoactive substances, including world-first detections. These have spanned multiple drug classes, from synthetic opiates to benzodiazepines to stimulants and dissociatives. The multiple world-first detections play a critical early warning role, not just for the ACT, but the nation and globally. Many of these substances have little clinical evidence and therefore have increasing risk and uncertainty for the people who would otherwise, often unknowingly, consumed them. In March of this year, the UN Commission on Narcotic Drugs placed 3 new psychoactive substances under international control following the World Health Organisation's recommendations. These included 2 nitazenes and a synthetic cannabinoid. One of these substances was first detected here in Canberra at Cantest, highlighting the service's critical early warning role in detecting emerging drug market risks. Through detection and testing, Cantest not only helps individuals make more informed choices, but we're also providing early insights into drug trends that both law enforcement and health services are aware of and that support and strengthen public health responses. I'd also note that usually within 24 hours of a Cantest notice being shared on social media, we have reached hundreds of thousands of people online. The impact is not just the individuals accessing the service, but more broad than this. Understandably, pill testing is largely supported by peak bodies, medical bodies, and for families. The community has welcomed Cantest, understanding that we are here to reduce drug-related harms and the risk of overdose. From a budget risk perspective, early detection is essential. If high-potency synthetic opiates enter the local drug market, the cost of inaction is measured in preventable deaths, emergency surges and long-term system strain. We were able to get in ahead of that. I'll just comment briefly on integrated care, which has come up.
Sure. Sorry to interrupt, but we don't have a huge amount of time,
okay.
and thank you for your submission. You can, if there's more written comments that you'd like to submit to us, we'd love to have those. We might move to questions now, if that's okay, just sort of in the interests of time. But thanks for your submission thus far. Ms Stanley, did you have any questions for Ms Stevens?
Just one. We heard early this inquiry from the people that were pill testing in Brisbane, which unfortunately has been defunded, but that their clientele was not all what you'd expect it to be. So young people, or people that were going to music festivals or whatever, that they had a significant cohort of older people who were sourcing what they thought to be medicinal sort of medications online. Do you see the same thing in your area as well? And has that grown over time as people are aware of what you will do?
Certainly, we've had a more diverse client group appear over time as people have come to understand what we do, and additionally, decriminalisation in the ACT, we hope, supports some people to feel more comfortable coming in to have drugs checked. So certainly the population has changed. We've seen the introduction of novel and counterfeit benzodiazepines, and that does appear to different age ranges. Overall, the data, as I recall it, is that 30% of our clients are over 35. So you're absolutely right. While there is a proportion of young people who access the service, it's not in isolation. If there's more data that we can access on that, I'll gladly provide it.
That'd be great. Thank you very much for coming today. That's excellent. Thanks, Dr. Ryan.
Thanks, Ms Stanley. Ms Bellier?
Thank you very much for your comprehensive report. So just a couple of things around the service. Are you a national service, or where are you based? I was thinking maybe it was New South Wales and ACT.
We wish. Cantest was the first fixed site in Australia, and it's only Canberra-based, funded by ACT Health.
And can you just provide, I hope I don't seem too naive, just a bit of an oversight of the actual service and where we might find you?
Absolutely. We're located at 1 Moore Street. We're open 6 hours per week, 3 hours on a Thursday, 3 to 6, and 6 to 9 on a Friday evening. We're in a government health building, and so you can walk into the building and be accessing anything. We are tucked away as a confidential and free service that's delivered by Directions, Karma, and Pill Testing Australia. Every shift that we open, we have a nurse on shift alongside peer and harm reduction workers and the chemical analysts, and people can bring in a very small amount of 1 to 5 substances to have checked. We can't check plant matter, but we can check pill, crystal, powder, a range of substances. And the person engages with someone in a discussion around what they think they've got, their understanding of harm reduction strategies, what they're intending to do with the substance, and then they get to see that substance go through multiple different forms of chemical analysis. These different methods are adopted because they give a full picture, or a more full picture than could otherwise be given, about that drug. So we try to identify the different components in it, because we know that often it's multiple things within a drug, and then we try to quantify or determine the purity of some of those components where we can. We also check for particular adulterants that we're really concerned about, like fentanyl, nitazines, or benzos, which we know to have a correlation with overdose risk. And then the client sees all of that information. They get to ask the scientists questions about the drug, and then the conversation continues with the harm reduction worker to talk about the risks, not just about the drug, the risks about their body in the social setting that they might be in the choices they might make, to have quite a holistic a complete and a practical conversation about what risks they might be exposing themselves to, what they might do and how they might reduce those risks. And they can discard that drug then and there if they wish to do so. And the ANU evaluation determined through their findings what people actually did some weeks after those results to see if what they indicated they're likely to do was what they did in practice. And it showed a reduction in both drug consumption and in risky behaviour.
One more question. So in regards to your experience and our broader inquiry about alcohol and drug harm, related harm, what would be some of the recommendations you would suggest to us as we deliberate everything?
Harm reduction needs to be better embedded across the service system, not just in the specialist harm reduction services. We need better coverage of specialist harm reduction services like drug checking. It's a crying shame that we're a novel service still. We need better NSP access, and we've talked already about medically supervised or period supervised injecting services or drug consumption sites. The importance of decriminalisation has been touched on and is very valid. We need far more sustainable funding. We as a service have over 40 funding contracts, and you can imagine the administrative burden that comes with that. We choose to do that because through that we can deliver an integrated primary health, mental health, alcohol and other drug service, because these activities are currently siloed in how they're typically designed and funded. But we come as a whole person and we need the whole person addressed at point of contact. That enables opportunistic health engagement, like people have mentioned in relation to NSPs before. You might come in for the fits, but you might leave with contraception and bloodborne virus screening and a range of other things. We'd also like to see improvements to opioid dependency treatment programs and incentives for GPs through Medicare. I could go on.
Thank you. Back to you, Dr. Ryan.
Thanks, Ms. Bellier. Dr. Scoms?
Thank you so much for your time today. You just touched on there greater incentives for GPs to be able to treat people with dependence problems. What would you like to see in that regard?
We would like to see greater Medicare incentives for GPs to prescribe opioid dependence treatment pharmacotherapies and also to address the holistic needs that those clients often bring. It's either dehumanising or subpar to try to get someone with those complex needs through a 7-minute consult, and the billing does not support the length of time GPs require to engage these clients who deserve that kind of care given the degree and the combination of vulnerabilities that often sit alongside opioid dependence.
And can I ask, are many of the other states and territories providing a more holistic service such as you're providing there?
There are some.
Are other states doing similar things?
There are some comparisons, and as I understand it, it's rarely because that's what the funding or the design has enabled, and more at the impetus and the strength of the service that they've been able to acquire those kind of diverse streams of funding. There are some similar NGOs.
So it sounds difficult to me that you're having to get different streams of funding for the one service just to try and give that wraparound holistic type care. And
yes, that's correct. Yes, so through we might have say seven funding contracts for what looks like one door to a client, so that they can access a mental health nurse, a psychiatrist, a GP, an AOD counsellor, and at the same time access sterile injecting equipment, come into our drug checking service, be referred to our rehab if that's what they need, or their family or their carer come and find support as well.
Yeah. So how much time would that take if your organisation is constantly having to apply for funding, and the funding is, I assume, and please correct me if I'm wrong, that the funding is often short term?
Correct. Yeah, so not only is the funding short term, so you have to compete for it, you have to write tenders, design services, advocate for the opportunity, but then you have unique compliance and contractual obligations for each contract, and then we also have the reporting outputs for each every 3 to 6 months typically, which has a data set, a narrative report, and usually outcome treatment measures that sit around it. But the funding for the business model that sits around those sustainable systems is usually usually pushed down to 10% or is pushed down through a competitive process. So it's very difficult to acquire sustainable funding to, one, deliver at the quality that we should all be required to deliver at, but two, be able to have efficient systems so that you can make that a sustainable practice to keep that funding, the funding requirements met, while simply trying to have one open door for the client.
Can I just ask, what does it mean in practice? I'm sorry, just that, what does it mean in practice when you have to put so much time into applying for funding?
Absolute stretch and total economic pressure to cost save. And this is why you see so many NGOs and charities struggling.
Thank you.
It also means
Thank
that our
you.
staff can't be paid sometimes at the rates that the government might be able to. And so the competition for the workforce is impacted, our ability to acquire appropriate premises, all of these things are a flow-on effect.
Can I ask you about that? So if you're open up to 6 hours a week, it sounds like you're getting people cold in terms of they're planning to come. Do they actually have an appointment to come to your centre, or they just walk in?
Yes, so people just walk into Cantest.
But you're not able to offer pill testing at music festivals and things for that?
Cantest is funded only to be a fixed site, but our partners Pill Testing Australia do a wonderful job stepping up pill testing at festivals such as recently DigiFest and previously Spilt Milk here in the ACT.
Thank you. And just last question, do you have any sort of comparison information about the amount of time that it takes, I guess, to take... presumably when you're doing it at music festivals, you can't go through the whole process that you've been just described when people come to your standing facility. Do you have any way of comparing and contrasting the services that you offer in the mobile as opposed to the fixed facility, or is that a bit difficult?
They both have their unique place, and Pill Testing Australia's work in the festivals is incredible, and they do actually have the range of testing available on site that we do in the fixed lab now, which is phenomenal. So they can test purity and they do check for those other adulterants. They have their own place because if you only had the festival testing, we're presuming that the drug-related harms only happen within festivals, and we know that that's, a naive view. So really it's about that equitable access for people. People are organised ahead of time and looking to make informed choices. So while we might be only open 6 hours per week, you might have people coming in to check things for that weekend or for next month because, they're aware of the harms and they're wanting to get the information that they can.
Oh, okay, that's great. Well, thank you, and thank you very much for appearing in front of the committee today. If you've been asked to provide any additional information, we'd be very grateful if you could forward it to the Secretariat by the 9th of April 2026. You will be sent a copy of your transcript of your evidence, and you will have an opportunity to request corrections to transcription errors. We're very grateful to you for appearing in front of the committee this afternoon.
Thank you, committee. Thank you for your work.
Thank you very much.
Thank you. The next individuals that we have with us are the representatives of Victorian Legal Aid. So I'll just give you a chance to move into... Oh, there you go.
Sophie, your hand is up on the app permanently, if she's there.
Apologies, Jan and Eleanor. We've had a few technical issues this afternoon. I keep dropping out my internet, so if I disappear, don't take it personally. Thank you for attending in front of the committee this afternoon. My name is Monique Ryan. I'm the Deputy Chair of the committee, the Health Committee. Dr Mike Freeland has had to step out this afternoon, I'm afraid, but we've got a number of the members of the committee, and we'll introduce ourselves in a second. Just firstly, although the committee does not require you to give evidence under oath, I have to advise you that this hearing is a legal proceeding of the Parliament and therefore has the same standing as proceedings of the respective houses. The giving of false or misleading evidence is a serious matter and may be regarded as contempt of Parliament. The evidence given today will be recorded in Hansard and does attract parliamentary privilege. I now invite you both to... Actually, I'll just introduce ourselves first and then I'll invite you to make an opening statement. So I'm Monique Ryan. I'm the member for Kooyong in Melbourne. Sophie?
Hi, I'm Sophie Scomps. I'm the member for Mackellar on the Northern Beaches of Sydney.
Anne?
And Stanley, I'm the member for Werriwa in southwest Sydney.
And Jodie Ballier, the federal member for Dunkley in Victoria.
Lovely. So we've got an all-lady brew this afternoon. It's fantastic. For the Hansard record, I'll ask you to state your full names and the capacity in which you appear before the committee, and invite you to make a brief opening statement.
Sure. Thank you, Monique. My name is Jen Black. I'm one of the co-directors of Summary Crime and Therapeutic Justice at Victoria Legal Aid.
My name is Eleanor Peaty. I am the other co-director of Summary Crime and Therapeutic Justice at Victoria Legal Aid.
Lovely. I invite you to make an opening statement.
Thank you. So thank you for the opportunity to appear and expand on Victoria Legal Aid's submission to this inquiry. And we would like to acknowledge that we appear before you from the unceded lands of the Wurundjeri people and pay our respects to elders past and present. Victoria Legal Aid provides legal information, education and advice for all Victorians, and we're the state's biggest service provider to socially and economically disadvantaged Victorians. Our practice experience of working with clients who use alcohol and drugs, problematic AOD use is really intrinsically connected with a lack of support for complex issues. So this includes historical experiences of trauma alongside issues such as mental health, disability, physical health issues, social marginalisation and homelessness. A key barrier to AOD support for our clients is the chronic shortage of services and treatment opportunities in the community. And additionally, in our experience, the criminalisation of drug use can make early intervention very difficult, as viewing drug use as a criminal law matter and not a health matter can make people reluctant to seek help. Many people who are unable to access help to address their problematic AOD use end up in contact with the criminal justice system. And in our practice, we see people charged with matters directly related to their drug use, such as possession, but also cases where people's problematic AOD use also contributes to their offending. The criminal justice system contact can really inhibit AOD recovery, and a criminal conviction has really profound consequences, including stigma and discrimination. It creates a really significant barrier for full participation in the community and can negatively impact on people's job prospects as well as their relationships and housing. So all of these factors make it much harder for someone to address problematic AOD use. Our clients tell us that being remanded and spending time in custody is traumatic and it just disrupts their lives. And people in custody may not have opportunities to engage in alcohol and other drugs programs, and too often our clients are also released back into the community without having addressed the issues that contribute to their contact with the criminal justice contact with the criminal justice system in the first place, and also with very little support. So these conditions make it difficult for our clients to avoid relapsing. So for these reasons, Victoria Legal Aid supports approaching alcohol and drug use as a social and health problem rather than a law enforcement issue. And as much as possible, people should be supported to address their AOD use in the community rather than entering the criminal justice system.
If people do end up in contact with the system, the most effective responses in our practice experience are diversionary programs and therapeutic justice interventions. Diversion is a way to prevent a person becoming entrenched in the criminal justice system by allowing them to avoid a conviction and by connecting them with the support for their underlying behaviour. Evidence demonstrates that this works and that these options should be expanded. Therapeutic justice interventions focus also on addressing the underlying issues behind offending and on engaging people who have offended in a more holistic and collaborative way that supports them to develop their own solutions. Our practice experience demonstrates that these approaches are much more effective in addressing people's AOD and other issues compared to mainstream court settings. In Victoria, we have a range of established therapeutic courts and programs that engage professionals from different disciplines to help address those underlying issues, including health and wellbeing, AOD use, accommodation, homelessness. So all of these programs that exist in Victoria have been positively evaluated in terms of both reduction of offending and also in terms of cost saving. However, these programs are unfortunately not available at all courts. And this means that Victorians who would benefit from them can't access them, and this is a particular issue in regional and remote areas. At Victoria Legal Aid, we're also piloting a remand support service which works alongside our duty lawyers, assisting clients who are remanded in custody to help connect them with supports, including alcohol and other drug services. In our submission, it is important that non-legal services such as these are funded alongside legal services to ensure people are supported in relation to their health needs. So in summary, our submission is that AOD use is best treated as a health issue and that timely access to support can prevent problematic use and prevent people from becoming entrenched in the criminal justice system. The federal government can assist by addressing funding gaps for AOD services, including First Nations-led health services, as recommended by the Europe Justice Commission, and also by driving national leadership in promoting a public health response and expanding the availability of diversionary and therapeutic justice approaches.
Thank you. I really appreciate it. Ms. Balliot, do you have some questions?
Incredible work, and coming from Frankston and Dunkley, I see the impact of substance abuse, particularly on young people in the community, and having had a background in youth work across 20 years, I understand the importance of diversion programs. This is a very generic program question. I think my concern is we're not investing enough in these diversion programs, and there's a real gap, need and opportunity for that. Are there other states and territories that are investing in diversion programs? And how many programs have we got in Victoria?
Thank you for that question. The question about other states and territories, we will have to take on notice and can provide some information in writing to the committee if that's suitable. In relation to Victoria, there are three main mechanisms for drug diversion. Mm-hmm. So two are through Victoria Police. So Victoria Police have the discretion to not charge adults with small quantities of drugs for personal use through drug diversion, which is for substances other than cannabis. This program requires the person to attend assessment and appropriate treatment. And then the second program through Victoria Police is the Cannabis Caution program, and that doesn't require the person to attend for assessment and treatment. The third option is through the Magistrates Court of Victoria, and this is the Criminal Justice Diversion program. So a person might be eligible for that program where they're charged with a low-level offence such as possession and they have no prior convictions. Again, there's police involvement in this in the sense that they must agree to the diversion and the person must take responsibility for their offending. The court, as part of that program, might impose a condition of the diversion, for example, that the person attends AOD treatment and they've given a period of time through which that diversion continues. If at the end of that period they've completed all the conditions and they haven't reoffended, then the charges are dismissed with no finding of guilt recorded. There is one barrier that we do see to accessing these diversion programs, and that is that the models rely on police discretion. What we see in our practice is that this is often inconsistently applied across the state, and that does provide a significant barrier to access. However, we can also say that the success of these diversionary approaches is evidenced by the Crime Statistics Agency study, which was undertaken in 2016, of the Victoria Police Drug Diversion Program. And what that study showed is that it meant that people who went through the diversion program were 10% less likely to reoffend. So there's evidence that shows that they work. There are, however, some barriers to how they are accessible.
Thank you. Back to you, Monique.
Ms.
Dr. Ryan.
Do you have any questions? Thank you, Ms. Ryan.
Thanks, Dr. Ryan. No, I don't have any questions, but thank you so much for your evidence. It's really interesting.
Thank you. Dr. Scomps.
Questions. Thank you so much for that evidence. It's really very, very interesting. It would be great. One thing I just would love to see is the evidence, the independent evidence around the effectiveness of these alternate courts. That would be really, really helpful. And then I just was wondering, do you have a view on restricting the restriction of alcohol marketing or the need for that?
Well, I can talk to the effectiveness of the therapeutic justice approaches that we spoke about in our opening address. So in Victoria, we have a range of therapeutic courts and programs available. They are the Drug Court, the Assessment and Referral Court, the Koori Court, the Neighbourhood Justice Centre and the Court Integrated Services Program. I might just start by focusing on the Drug Court because it's a really relevant model to this committee, but we can speak in detail to the other models or provide further information in writing. So the Drug Court, it focuses on the rehabilitation of people who've committed criminal offences who have an alcohol and other drug dependency that's connected to their criminal offending. So unlike the diversionary models we spoke about, this program is aimed at high risk, high harm offending where the person is facing a term of imprisonment. What the Drug Court does is it connects that person with a multidisciplinary team, or it engages other disciplines in a team that sits around this person to connect them with supports that include case management, clinical supports, mental health supports, accommodation supports. And essentially also a really important part of the model is that they work with peer mentors in some of the drug courts. And what the participants in drug courts say is that the peer mentoring is a critical part of the program that really supports their rehabilitation and recovery. In terms of evaluations, the drug courts in Victoria were evaluated by KPMG in 2023. That evaluation found cost savings of $2.09 for every $1 spent on the drug courts. So it's essentially double savings on investment. They also found that participants who had completed drug court were 15% less likely to reoffend than non-drug court participants. So this was even higher. That was all drug court participants, I beg your pardon, were 15% less likely to reoffend. But participants who had completed the program, which in the Magistrates Court is up to 2 years and in the County Court of Victoria is up to 4 years, so a long, intensive program. So if they completed the program, they were 27% less likely to reoffend, so a significant increase. And then where there was reoffending, it was found to be less serious, less frequent and less likely to result in a future term of imprisonment.
What was the level of the length of follow-up for that, do you know? Over what sort of, when we're talking about reoffending, over what sort of period?
We'll just, apologies, have to take that on notice and can provide it's quite a detailed evaluation.
So,
but can I just also quickly indicate, I guess, a personal illustration of the impact of the drug courts that shows that it goes beyond cost savings and beyond individual impacts into families and communities. So we wanted to share an example of a previous graduate of the Victorian Drug Court. There was a man whose life had been marred by substance abuse and incarceration. He grew up in a boys' home and at the age of 17 was committing robberies. He was in drug court for 22 months. During that time, he obtained stable and safe accommodation. He completed a certification in AOD counselling. He had his teeth fixed. He developed lifelong coping strategies and he had his 2 sons reunited into his care, both of whom attended his graduation from drug court. So it just really illustrates the really significant impacts that a therapeutic justice program like that can have. Unfortunately, at the moment in Victoria, it's only available in 4 locations, in Melbourne, Dandenong, Ballarat and Shepparton. So there's a really significant access to justice issue here and access to people who need this type of treatment to rehabilitate and avoid contact with the criminal justice system.
Thank you so much for that story. Thank you.
And I could just add to that the KPMG evaluation for drug court was over the period of November 2022 to October 2023, so the year study.
Thank you. Any more questions, Sophie?
Just one quick one, if Sophie doesn't have anything. We've talked a little bit about hubs for people accessing support services to deal with AOD issues, and that could be a doctor, a pharmacist, counselling. As professionals working in the sector and seeing what the lives of these people look like, how do you think that sort of hub and spoke model that provides that holistic care would work?
Yeah, we would support an approach like that, and in fact it is similar to the way the therapeutic justice courts operate in Victoria, so essentially providing that holistic support but in a way that is essentially a one-stop shop. In our practice experience, is accessible for clients, means better engagement and better outcomes. So an example of that does exist in the criminal justice context is the Neighbourhood Justice Centre in Collingwood in Victoria. It is essentially, it's Australia's only community justice centre, and it is essentially that hub and spoke model that you were talking about. There's more than 17 on-site services available for people going to the magistrates court there, which includes AOD counselling, mental health support, accommodation, financial counselling. And there is an Australian Institute of Criminology study from 2015 that found that approach resulted in a 25% lower rate of reoffending, and also significantly higher rates of completion for people who are undertaking community-based orders in that court.
Yeah, and I just might add to that, in terms of legal service delivery, we also see that there's a role for access to civil legal services in prevention. So Victoria Legal Aid has a specialist in-house statewide civil legal service, but obviously also the community legal centres across Australia do terrific and significant work in terms of their contribution to civil legal work. And civil legal assistance for people with alcohol and drugs can really actually prevent their contact with the criminal justice system. So legal assistance can help with addressing issues like discrimination, obtaining NDIS supports, seeking citizenship, ensuring appropriate social security payments, and understanding the rights and options for victims of crime. And these sorts of supports can actually assist people in obtaining stability in their lives and play a role in supporting people out of a period of problematic alcohol and drug use. So essentially addressing the underlying causes of engagement and potentially avoiding re-engagement with the criminal justice system.
So just on that particular service in Collingwood, I think you said, is that focused on AOD, or is it like a community centre, health centre that people access for a range of different reasons?
It's not just focused on AOD, it's a community centre. Yeah. It can be accessed in two ways. If someone who lives in the city of Yarra has a matter in the magistrates court at the Neighbourhood Justice Centre, they can access any of the services. But if someone just lives in that community and needs access, they can also access the services. So it's essentially established for the community.
I've got one more question. If you had a magic wand and you could get us to implement a few things, what would be your top three?
Sure, I can take that one. So really we see there's a really significant leadership role for the Commonwealth in terms of a public health response, and that includes coordination of whole of government investment in community alcohol and drug services, and as we mentioned earlier, including implementation of Yoorrook Justice Commission recommendation for First People-led access to alcohol and drug services. Consideration, I guess that's the first point. The second one is consideration of opportunities to decriminalise conduct that should properly be treated as a health issue, such as alcohol and drug use and low-level drug possession. And where there are matters in the justice system already, as Eleanor's talked about, evidence-based diversionary processes and therapeutic models. So obviously the decriminalisation point and the establishment of diversionary and therapeutic models are largely the responsibility of the state and territories, but we feel that there is a real role for the federal government to aid jurisdictions in essentially designing and implementing evidence-based drug policies.
So on that, I mean, we've just heard from some representatives from the ACT who are telling us about what goes on there in terms of legalisation of cannabis. Would it be a source of some frustration to you that laws around decriminalisation are very different between different states and territories? And if so, because I'm assuming the answer is yes, what would be the best way of bringing them together and standardising them?
Well, I mean, I think the source of frustration is essentially that so much of the justice system's resources are used on very low-level possession and use charges. I've got some stats on that it's close to 80% of all drug offences are actually possession and use charges. So they were 2025 stats from the Crime Statistics Agency, Victoria.
So that diversionary sort of stuff that you were mentioning doesn't operate most of the time, is that fair?
It's a very small piece. Yeah, a very small piece. So I think this is something that we can respond to in more detail in written submissions, but I think there are examples of the uniform evidence laws, for example. The federal government's leading the way to establish best practice leadership in relation to evidence-based policies, and it would be really great to have a Commonwealth response that reflects that.
Okay. So would that involve us, the Federal Attorney General bringing together the Council of Attorneys General to work on that, or would it be something that we could legislate at a federal level? Or maybe that's not a fair question, sorry.
I think that's quite a complicated question. That we would be keen to respond to on notice, but I think that you've identified some possibilities there, like the Council of Attorney Generals. We could respond in more detail on in written form.
Okay, one last question from me. There was note of the Victorian Legal Aid Service currently piloting a remand support service. Are you able to tell us about that?
Yes, so that service is funded by the Victorian Legal Services Board and Commissioner. It commenced in June last year. It's essentially responding to a review that Legal Aid had undertaken of its remand services by the Centre for Innovative Justice. And that review recommended that Legal Aid establish non-legal supports for people we were representing who are in custody, so remanded on criminal charges, brought into custody to appear before the court. The reason for that recommendation is because what we know is that people who are remanded in custody need assistance with their legal matter, but need assistance with a range of non-legal matters, with housing, with mental health supports, with AOD counselling. So the recommendation was to pilot a service that works alongside our lawyers. So the lawyers do the legal work, the non-legal service assists with all of the other supports. And that means that the client, when they're released from custody, essentially is more likely to be set up with appropriate supports to both engage in their legal matter, but also address the issues that underlie their offending behaviour. So since June last year, when the service was piloted, we have had significant positive impacts through that service in terms of people in custody contacting family and friends to let them know where they are, arranging care for pets, care for children, things like that, because when someone's remanded, they're taken from their life without notice and put into custody without ability to contact anyone. So that contact is really critical. It's also helped us navigate support services. So when someone is released on bail, they are linked in with accommodation services, they're linked in with alcohol and other drug services. But it's also helped people navigate and understand the court process because they have someone who can help explain it to them, who can help people who are in emotional distress. And what that means is that when they're in court, they're better able to understand what the court is saying and what is happening with their legal matter.
So who's staffing the support service?
Yeah, so it's staffed by remand support practitioners who have a variety of qualifications, but social work kind of experience. So they're really filling that non-legal service delivery gap where they're assisting the duty lawyers for people who are remanded by meeting the people who are remanded's non-legal needs, like contacting family and really making that experience of being remanded, the aim is to make it a less dehumanising experience, a less sort of horrific experience of suddenly being in the community and then being on remand.
Mm.
And how is it funded?
By the Victorian Legal Services Board and Commissioner, we've received a few years of funding to pilot a service. We are going to undertake an evaluation of the service, and we'll be needing to advocate for further funding to continue and ideally expand the service, because we're here in Melbourne. This is where the service is being piloted at Melbourne Magistrates Court. We're in Horsham earlier this week, visiting our colleagues there, and in Horsham there are very little access to services both in the community and in the criminal justice sector. And so ideally we would like to see a service like this being able to reach remote and regional communities and provide essential linkages there that don't exist at the moment.
Thank you. That was my last question, actually, you've talked about the need to implement the recommendations of the Justice Commission. Presumably to do that, would it be your position that we need to improve services for people in rural and regional settings primarily, given that that's where many Indigenous Australians are living?
Yes, but with the leadership of ACOs, with Aboriginal community-controlled organisations who are really best placed to enliven self-determination and know what their community needs and are best placed to deliver those services.
Sure. Thank you very much. Does any of the committee members have any additional questions?
No, thank you.
No, thanks. No, lovely. Okay. Well, thank you so much for your attendance today. We really appreciate your time. If you've been asked to provide any additional information, we'd be very grateful if you could forward it to the Secretariat by the 9th of April. You will be sent a transcript of your evidence and have an opportunity to request corrections to any transcription errors. Thank you again.
Thanks so much.
Thank you very much.
Thank you. Great. Well, I think we have, we have a break for 10 minutes in the schedule. So we'll come back together at 2:45. Thanks, Tate. names and the capacity in which you appear before the committee.
Hi. Yes, Professor Michael Lavarch, and I'm appearing as the Chief Adjudicator of the Aback Adjudication Panel.
Lovely. And Ms Taylor?
Jane Taylor, and I'm appearing as the CEO of the Aback Scheme Limited.
Lovely, thank you. My name is Monique Ryan. I'm the federal member for the seat of Kooyong. Dr Scomps, welcome back. Would you like to introduce yourself?
Hello, I'm Sophie Scomps, the independent member for Mackellar on the Northern Beaches of Sydney. Welcome.
Thank you so much. Ms Bellier?
Jodie Bellier, the federal member for Dunkley in Victoria.
And Ms Stanley?
Anne Stanley, I'm the federal member for Werriwa in southwest Sydney.
Thank you all so much. So just the introduction, although the committee does not require you to give evidence under oath, I should advise you that this hearing is a legal proceeding of the Parliament and therefore has the same standing as proceedings of the respective houses. The giving of false or misleading evidence is a serious matter and may be regarded as contempt of Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I now invite you to give a brief opening statement before we proceed to discussion.
Well, thank you very much, and thanks for the opportunity to appear. Look, we weren't planning to make an opening statement per se. I did listen in a little bit earlier, and the chair at one point asked an earlier witness how the Aback scheme works. So look, I'm happy to give you sort of a quick run through of how the scheme works and where it fits into the overall regulation of alcohol marketing, if that's helpful. Otherwise,
yeah.
Okay.
Oh, that would be great. Thank you.
Okay. As you no doubt know, alcohol marketing is a pretty complex system in terms of its regulatory framework. There's an amalgam of direct government regulation at the Commonwealth level, to some extent through requirements, what has to be on alcohol packaging, pregnancy warnings and things of that notion. There's also federal regulation in terms of particular channels of media, most notably around free-to-air television and the role that ACMA plays there. The principal regulation of alcohol, including alcohol marketing, sits with the states and with state liquor authorities and various guises under the State Liquor and Territory Liquor Acts and supporting guidelines and regulation. And then there's a matrix of industry-led codes of practice and sort of self-regulatory schemes which work to some extent together with the direct government regulation. So there's the overall sort of standards for all marketing, irrespective of the product, which is run by ad standards, and that goes to things about sort of taste and decency and sexism and racism and vilification, which is applicable whether you're selling a beer or you're selling a pair of shoes. So that applies to alcohol. And then there is specific alcohol self-regulatory requirements. Retail drinks runs a code which goes to sort of online delivery and that style of marketing. The Outdoor Media Association has alcohol policies which go where alcohol ads can be placed on billboards, on the side of buses and things like that. And then sitting within all of that is the Aback scheme, which is the sort of self-regulatory scheme initiated by the alcohol industry itself. It has both content standards, so what the messaging within alcohol marketing should not contain, that it shouldn't appeal to minors, that it shouldn't be encouraging excessive consumption or implying that alcohol is needed to cope in life or to be successful at life. So things like that in terms of the messaging. And then there's a series of what we call placement standards, and the placement standards have the policy aim that alcohol marketing, to the extent possible, should be directed towards adults and not towards under 18-year-olds. And there's a series of stipulations around what is required to try to achieve that policy goal. So that's a very quick overview of how all of the sort of bits of regulation sort of form this sort of ladders of requirements which hit alcohol marketing. Aback itself, as I said, it's an industry-led scheme, so it's sort of self-regulatory at its heart, but its governance, its overall governance has a representative model. So there's sort of 3 members from the alcohol industry and 3 members on the governing board who are not from the industry. There's an independent chair. It's currently Tony Smith, the former Speaker of the House of Representatives, a Deputy Secretary of the Federal Department of Health is a full member of the committee, and a representative from the Communications Council, so sort of the advertising, marketing side. So they're the overall governance responsibilities. And then the core elements of the scheme is this code I was talking about, what's contained in the code, a sort of proactive regulatory model around running alcohol through tests before it's allowed into the market. It's called a pre-vetting service. And then the final component is the bit that I particularly run, and that's the public complaints process. So any member of the community who's troubled coming across an item of alcohol marketing is able to make a complaint, and then we'll determine that complaint against the standards in the Aback code. So that's a quick 101 in terms of how Aback works.
Thank you. Ms. Taylor, did you want to add anything to that at all, or no?
No, I'm happy.
Thank you. Okay. Ms. Stanley, did you want to kick us off?
Thanks, Dr. Ryan. Can I just confirm the Deputy Secretary of the Health Department is a full member of the committee, therefore has full rights with any determinations that the board makes towards the complaints or so forth, or is are the complaints a separate way that you deal with things?
Let me in terms of your question, is the Health Department member a full member of the governance committee? Yes, he is. So at the moment it's a male, and he's a full member of the committee, so full voting rights, so full participation in the governance of the scheme. The governance of the scheme has responsibility for setting the terms of the code itself, and oversight of the operation of the scheme to sort of determine its risk model and things like that. So it's got governance responsibility. It plays no role whatsoever in the actual decision-making processes of those 2 other parts of the scheme. So when a public complaint comes in, it's assessed and determined by the panel that I chair, and the panel I chair has it's a 5-person panel. 3 people sit on every decision. So I'm a lawyer, so I'm sort of the legal member. I have a public health member of the panel, and that public health member is appointed through the Federal Health Minister. So that's one of the decision makers. And I have a panel member who has a background in marketing and communications. But we have no relationship with the alcohol industry. We're completely, in fact, the rules require us not to be employees or have any financial interests, or, so there's full, independence of the decision-making process of the scheme from the governance oversight of the scheme. Equally, the pre-vetters, so the people who sort of, if I'm an alcohol company and I want someone to give me an independent view as to whether my TV campaign is going to be consistent with the good practice standards, the people giving that advice, again, are completely independent from the alcohol system. So I think, for instance, I chair, another one of my roles, I chair the board of the Telecommunications Industry Ombudsman. and it's basically the same system. So there's Telstra and, telco people on the board of the TIO, and the TIO is funded by the telco industry, but the actual decisions on public complaints and dispute resolution is done by the ombudsman and the staff of the service, and there's no control, no influence whatsoever of the board over the handling of complaints and dispute resolutions. That same model applies in terms of the way in which the Aback scheme operates.
Sure. Thank you.
Can I just confirm something just from earlier? Did I hear that you said the 3 members on the management committee are from the alcohol industry? Did I hear that?
Yeah, there is a 6-person management committee. 3 of those members are drawn from the alcohol industry, and 3 members are not from the alcohol industry. There's an independent chair, Tony Smith, a deputy secretary of the Department of Health, and I think he's currently the CEO of the Communications Council, so from that sort of side of it. So 3 from alcohol, 3 not from alcohol.
And would it be true to say that the management committee sort of sets the strategic direction, sets sort of the rules of engagement in many ways, that how the board applies?
Yeah, it's got, obviously, the management committee has governance responsibility for the scheme. So it is the owner of the code itself. So it owns the code. So the code that I apply is handed to me and my other panellists, and we apply that code against the complaints that we see.
But it's the management committee. But it's the management committee that sets the code.
It sets the code. It sets the code. It approves the sort of regulatory sort of strategy and basic operation. It oversights the operation of the complaint system and the pre-vetting system. Is it running efficiency? Is it making its timelines? Is it doing those sort of things? But as I say, that is quite the standard in the way in which effectively self-regulatory models operate. It's exactly the same, for instance, the way the TIO operates or AFCA operates or Water and Energy Ombudsman operate in terms of complaint schemes which are funded by the industry that the complaints or the disputes are related to.
When was the last time the code was updated and you were given a new set of guidelines to look at?
The code, the last time was 2023, so relatively recently. The code is fully reviewed around about every 4 to 5 years. So, so the code that was reviewed and given to us in 2023 had a number of significant changes. For instance, it extended the coverage of the code to what's called alcohol alternatives, zero alcohol beers and wines and that style of product. So the code was extended in 2023 to cover those new product lines in terms of their commonality of branding and relationship with alcohol brands. Equally, the threshold for the basic, where alcohol has to reach targeted adult audiences was raised from 75% reasonably expected adult audience to 80% reasonably expected adult audience. So there was a reasonably major revision in 2023, and then there's been earlier revisions, as I say, about every 4 or 5 years.
Do you
have the life.
Sure. Do you have any data about the effectiveness of those changes to compliance with the code? We've heard significant evidence today that there is marketing to children, particularly in the 7 to 14-year-old age group, and particularly online and through YouTube. And I would just be interested to know, because clearly it's been raised to 80% that marketing of alcohol-related products should not be at that audience, how Aback is going about making sure that their own code is being adhered to, and, you know, do you have any data? You don't have to share it today, but is there data you could share with the committee that shows over the last 3 years that compliance is up, that, you know, you have put on notice anyone and everyone who clearly, if this evidence is to be believed, is breaching their own code?
Okay. In fact, it's more than the 80% rule. There is a series of placement standards which are linked to effectively the technical capacity of the medium by which the marketing is carried. So for digital platforms, which is really what we're talking about here, your Facebooks, your Instagrams, your YouTubes, TikToks, and the like, the requirement is not simply the 80% rule. You have to apply all available age restriction controls to exclude under 18-year-olds being served with any alcohol marketing. The 80% rule comes in if there are no effective age restriction controls. So that means on television, for instance, and we can talk about television separately, but on television, you're not able to place an alcohol ad where the reasonably expected audience of the TV program that the ad might appear with would be in excess of 20% minors. But if I'm going on to Instagram and I want to advertise on Instagram, I have to apply the age restriction controls that Instagram allow, that have as part of their platform, to stop anyone who holds an account with Instagram, and Instagram, you know, all these platforms, collect so much data on all of us, but one of the things they collect is date of birth data when you open an account. I mean, this is the backbone of how the e-safety commissioner and the new regime around under 16-year-olds and things is operating. You're not to be served with an alcohol ad. Now, in terms of data, one of the scheme does do compliance monitoring, and in fact, last year, compliance monitoring was done in terms of the effectiveness of various industry subsets in terms of whether the age restriction controls had been applied. Now, we can certainly give you, in answer to your question, the data from that. Previous exercises have been done in relation to that as well. And what that in brief showed is that while there is, reasonably good levels of compliance with the use of the age restriction controls, it's not universal. Some industry sectors are more poorly performed than others in terms of the application of the age restriction controls. But certainly the notion that, huge numbers of alcohol ads are being served to 15-year-olds or 7-year-olds in terms of social media platforms doesn't stack up against other surveys and work that have been done. But to the extent if that is occurring, that certainly is a breach of the code. Now, I have dealt with complaints where alcohol marketing has been placed with content which is directed at children and the ad should not have been placed with. I had a string of complaints, for instance, at the beginning of last year about alcohol ads being placed with children's podcasts, for instance. And it turned out there was a systemic problem. and that problem was around the classification of the content of the podcast. So it hadn't been classified as children's material, and this resulted in a problem with the ads being placed with them. And we were able to respond and work with the agencies and the platforms to try to overcome that systemic problem.
Thank you for your explanation, Professor Lavarch. I think we'd be all very interested in that data. Back to you, Dr. Ryan.
Monique.
Well, just on that, I mean, I think what we would like as a committee is details of the investigations that have been undertaken under the current iteration of the code, and how many of those resulted in sanctions being imposed on organisations, and what the nature of those sanctions were.
Well, I can answer very briefly on that.
Can I also add to that? I think it would be really good to understand what the complaints are that you've received. You know, what a summary of the types of complaints you're dealing with, and then of course the sanctions. I think that would be really important.
Thank you. Well, we certainly can do that. I mean, in fact, every quarter we produce a full listing of all of the determinations that the complaints panel has made, all of the decisions that have been made. Our annual report lists every complaint that has led to a breach finding. We actually list that. We send out, decisions as they're made to each of the state liquor licensing authorities in terms of it. In terms of last year, my panel made, I think, 103 decisions on complaints. It was roughly about 50-50 upheld and dismissed. In terms of what sort of nature of those issues, well, there's a whole, I won't go into them, but we'll send you that data. But all of this is completely published. You can go on to the Aback website, and every decision that has been made since, I think we go back to 2004, is it? Anyway, every complaint decision that has been made about alcohol marketing that we have made since 2004 is on the website.
May I just ask a question on that? The digital environment we find ourselves in right now is very different from what it was back in 2004, and it's rapidly evolving, of course. And there's been evidence today that was mentioned earlier that, in reality, what's happening is children aged 8 to 13 are seeing at least 4 ads a day, alcohol ads a day, and then up to 18 to 25, it's at least 7 a day. But one of the issues that was raised was that now that social media, advertising through social media platforms and other things is very highly targeted, that many of the times we as parents or others will not actually see that advertising content. So we actually don't know of it or hear of it or see of it or even know it exists. It doesn't exist as many of us are concerned. How is that being addressed? So many complaints will just simply not be made because it's so highly targeted and that information and the algorithms are so powerful. How can that be addressed?
No, that is a very pertinent question to understand. So obviously, in terms of the complaint part of the scheme, understanding the scheme has both proactive and reactive forms of regulatory response, what you say is 100% right. I mean, I don't get 15-year-olds making complaints to me. I get parents making complaints to me in terms of what they've seen either over the shoulder or in some other way in terms of what has concerned them. So if a parent or guardian or someone is not aware, then that is, complaints won't be made about it. And look, I don't pretend this is by any means a straightforward way. The operation of global digital platforms are not easy to unpick. I mean, nation states have difficulty enough dealing with these entities. let alone, little self-regulatory schemes like ourselves. What we do try to do is in terms of our proactive regulatory tools and the application of that work through guidance, tools, resources, training, and the like, to try to equip, the industry, both the alcohol participants itself and then marketing agents and advertising components and the like, as to what the requirements are, what steps you need to go through to try to achieve proper targeting of alcohol to keep it away from children, the application of the age restriction controls and the like. But in terms of clear visibility, that is a difficult question for the very reasons that you've identified.
It is hard, isn't it? Can I ask one other question? Another thing that was raised was I guess it's an exemption around the permission of alcohol advertising around sporting live streams, and of course children often sit with their families during those times, and so they are being exposed to alcohol advertising while there's children watching family times. Is there something we should be doing around that? That sporting exception?
Yeah, look, this is a core issue for public policy. I mean, ultimately, it will be for yourselves and your colleagues in the Parliament to determine that sort of setting. ACMA, as you no doubt are aware, are at the moment doing a review triggered around the free-to-air TV code, where the so-called live sport exceptions are currently sits. I mean, there is a range of problems, I have to say, in this space. That code itself, the Commercial Television Industry Code of Practice, was devised in the early 1980s, I think, and it was a very different media environment, obviously, where you basically had 4 TV stations to use from, and well before the day of KO Sports and streaming platforms, Netflix, not to mention, each Channel 9 having 5 subsidiary little channels and the whole like. The underlying legislation, that is the broadcasting legislation, is still to some extent set back in that previous era. So ACMA itself will say that it has difficulty sort of applying those sort of sentiments in the code into the streaming digitally delivered TV program. So something delivered over the internet, as opposed to the system assumes you've got a TV aerial and you're getting it through that way. That's why when Aback moved into this placement space, which was 2017, we moved from being a content only, the messaging in marketing, to where you see the marketing. So we moved to placement. We moved away from the notion of these proxy sort of time of day things that sat in the old TV code, because that's a proxy. It's assumed, well, kids are in bed after 8:30, or they're at school at this time of day, hence they won't be watching. And that's where our 80% rule came. So if you're watching sport, okay, and that State of Origin game or the AFL game or whatever, Matilda's game, is attracting more than a 20% of its audience as minors, then that will be a breach of the Aback code, irrespective of any carve-out and exemptions that sit in the free-to-air TV code. So because that code really had reducing utility because of the change in the whole sort of environment, the way in which people were taking their entertainment and the way it was being delivered through technological change, we didn't think it's still part of our code. You've got to comply with it, but we go beyond it and have this 80% rule of adult audiences. Now, to date, when we have actually received complaints about ads during the Australian Open and things like this, you get pretty good data because of the rating systems. So they do have pretty good idea of what the actual sort of demographic breakdown of audiences of sports programs are. And it might surprise people, but Australian Open, Matildas games, NRL game, AFL games have generally got something approaching 90% adult audiences. They are predominantly, in terms of all the data that we've seen, are watched by adults. And that doesn't mean if you've got the entire Australian population watching, the Matildas play their game, you've still not got a lot of minors watching it. But in terms of the total audience reach, I think all the data to date has suggested that it's less than 20%. Now, why 80-20? That was selected on the basis of census data. In fact, there is a bit more than, that's a bit high. I think it's about 78% of the Australian population is over 18, but the standard is set at 80%.
Professor Lavache, I think that much of the concern from people who've appeared in front of this committee has been that we're not so much talking about the paid broadcasters like television. We're talking about online spheres. We're talking about platforms like YouTube. We're talking about advertising within commercial organisations, for example, Uber Eats.
Yes.
We're talking about the advertising of alcohol on supermarket websites potentially, and we're talking about product placement with paid influencers online.
Yes.
So they're all things I think people are less concerned about the television because that's probably easier to monitor, and more concerned about this place where children are spending their time, which is the online sphere.
Yes. No, I 100% agree. The biggest slice of the complaint business, the complaint side of the Aback scheme, is indeed it follows the channels as you'd expect. So if I went back 10 years ago, the profile of where the media that was being complained about is very different now. So by far the biggest proportion of the complaints that we deal with are about digital chat channels, exactly as you've been speaking about. The single largest area where we have found breaches has been marketing over Instagram. That's got a bit of a head lead over marketing over Facebook, and the other platforms tend to be a bit below those two. But Instagram is unfortunately getting a bit of a gold star in terms of being the platform where most of the complaints have been identified. Now, our scheme indeed covers, in terms of those standards, each of the forms of advertising that you've mentioned. Influencer marketing, that is captured by the scheme. The placement of organic forms of advertising as opposed to strict paid advertising. All of these things are covered. Now, that doesn't take away the point that Dr. Scomps was making about, how easy is it to have visibility in terms of what's occurring. So the complaint side is very much an imperfect response to how the regulatory sort of settings should operate in terms of what we'd be trying to achieve in terms of public policy outcomes. And that's why the balance and indeed the greatest amount of activity that our part of this overall regulatory system puts to it is towards proactive engagement with marketers and trying to reinforce a culture of compliance in the way in which the industry operates, but that also requires, proper engagement by the platforms themselves. So look, there's a role for different, points of intersection here. Government certainly has a role, and I think there is a role in terms of self-regulatory responses as well.
Ms. Bellier, did you have more questions?
Yes, some higher level questions. So we're looking at the impact of alcohol and drugs on the community and individuals within it, and you have a role as an organisation in helping us to mitigate that. What would you suggest are the recommendations that you would like to see on the table to ensure particularly young people under 18 aren't being influenced or impacted by the advertising that they're seeing?
Yeah, look, it is a complicated system because of, all the joys of Australian federation and what all that means between the different areas of government sort of in play here. So you have different governments and then different government agencies. To me, from where I sit, it's not always clear that all the parts of the system sort of communicate sort of clearly with themselves. There isn't national consistency in terms of that primary level of alcohol regulation, including alcohol promotion at the state territory level. The similarities in the regimes, I accept, are more fundamental than the differences, but there are quite considerable differences there. One of the points, we try to align the scheme to the aspirations of the national alcohol strategy and its harm minimisation objective as the overarching piece of architecture of public policy. And one of the sort of points you'll find in the national alcohol strategy is that the states and territories should be moving to the best they can towards sort of national consistency in their part of the world, and I would particularly support that. I congratulate what the government has done in terms of its work with digital platforms and digital safety in terms of the engagement of under 16-year-olds. That hopefully will take out, if that's a robust scheme and works well, that will obviously take a whole hunk of the potential for minors to be delivered alcohol marketing through those platforms. Of course, it doesn't capture the 16 and 17-year-olds who are able to be on social media and are still below the legal age. So there still has to be, considerable, other parts of the regulatory regime working. My sort of thoughts would be around the overall coordination of what is quite a complicated regulatory system, drives for national consistency between state and territory regulators who, as I say, are the core level where alcohol as a product is dealt with in Australia, and close sort of examination at the national level in terms of how effective the e-safety changes around digital platforms are operating. So they'd be all, I think, very worthwhile measures that could be taken.
Thank you.
Well, I think our time's just about up. Is Ms Stanley still there?
Yeah. I don't have any more questions. I appreciate the witnesses' information.
Yes,
thank you very much.
Helpful.
Thanks, Ms Bellier. Dr Scrumps, are you still with us? I'm not sure. I think Sophie's gone. Okay.
Very late in the afternoon, and you've had a big day.
Yeah, no, thank you, Tom. Look, thank you for your attendance today. We have obviously asked you to provide some additional information, so it would be grateful if you could forward it to the Secretariat by the 9th of April. 2026. You will be sent a copy of the transcript from your evidence and will have an opportunity to request transcription errors be corrected. Thank you again for your time today, and I will declare the public hearing closed. Thanks, everybody. Thanks, Secretary.
Thank you very much.